Dr. Ma.
Yes, can you hear me?
Hello, Dr. Ma. Calling Dr.
Yeah.
Ma. Good
Hi.
morning, Dr. Ma.
Good morning.
Are you ready?
Sort of.
Okay, it'll be okay, don't worry. You can take out your mask, you know.
Yeah, me too.
Okay, now I need to figure this out, how to look for the questions in here. Dr. Nazlin, good morning. Go. Nadia, good morning. Hi.
Sorry, dia punya background.
Background mana?
Ini aja tak ada background. Mana pergi mana punya background.
Kenapa?
Vilma, good morning. Can you hear me?
Good morning. Hi.
Morning.
Oh, wait, let me put up the, whether I can change my, sorry, change my background somehow. Let's see. Okay, it's better now. You can hear me well, no problem.
I can hear you well as well.
Okay, good. Thank you.
Nazlin, can I hear you? Nazlin?
Hi, morning, Miss Priya.
Okay, you heard well as well. Are you starting?
No, not yet. We're just testing the camera first.
No, I mean, are you the first MC or something?
Yes. I'm for today.
Nanti nak question kalau nak mute macam mana? Ni.
Bismillahirrahmanirrahim. Ya Allah, Ya Rahim. Praise be to God, Lord of the worlds. Peace.
You can reach me many ways, it don't matter.
Okay, morning, Asmin.
Hi, morning, Wan Jiu. How are you?
Yeah. Okay, live.
Okay.
See you soon. Good to be
All
there.
right. Nice to see you.
Okay.
Okay, we got 5 minutes to go. All the best. Thank you.
Miss Azmi, we're just going to test our reminder bell. Nazleen, go ahead. We can't, you have to unmute yourself.
Okay, yeah. Saying the reminder bell. Can everyone hear?
Can't hear.
The mic.
Okay. Morning, Dato' Azmin. Assalamualaikum.
Cannot hear lah. Too soft.
Okay. I think we have already Dato' Azmin. Prof. Siawan Tiu is already available. And Miss Priya is there. And Ma Jung Koi also is there. Okay, good. Morning, Dato' Azmin. How are you? Boleh test mic dulu?
Yeah, good morning.
Okay, all
Testing.
right.
Okay.
Thank you for joining us. So we will wait for the countdown by the MC.
Good morning, Dr. Asmin.
Morning.
Good morning.
Morning, Prof.
Morning. Good morning, Prof. Xiao.
Haven't seen you for a long time already.
Yeah, yeah. Time goes so fast.
Yep.
We all used to be so young last time.
Many, I think it must be at least 5-6 years minimum.
Yeah.
Yeah, good to see
I
you.
remember.
Looking well.
Yeah, it's good to see you. Yeah, I remember when we just started in the 80s. You know, time.
Long time already. We're all old. You see the white hair.
Yeah.
Leave it to young people like him. Well, he's not so young, but
Yeah.
Both are you still young?
How's the COVID process in Singapore? It's here. We also going. The cases seems to be going up as well. Actually.
yeah, I think it's just going up. I think our problem is we're counting too many. Because every week I have to do 2 tests, ART myself, and then a lot of people have to do compulsory testing. So I think you're picking up a lot. You don't test, you don't find so many.
Yeah, true.
Yeah, it's okay. I think most of them are not that sick. I think more than 85% vaccinated, so should be okay. But of course, it's not nice seeing numbers every day, kind of worried.
Yeah, of course. You've had your booster already?
Yeah, finished about 1.5 months ago already. Probably January, February, I'll get my fourth jab. I'm sure it's coming, and it's just a matter of when they announce it. That's all.
Yeah.
I'm sure you had yours too.
Yeah, I had mine about, I think about 3 weeks ago, 3 weeks ago.
Quite can be quite severe, the symptoms.
Yeah.
It's not as simple as the first two. Mm.
Yes, yes, yes. I hear on the 29th, the borders are going to be open for the Changi and KLIA.
Flying in and out only, I think, not the causeway.
Yeah, yeah, yeah.
Yeah, I mean, I think have to do it someday, otherwise nothing's gonna happen, no business, everybody's crying, complaining. Don't think governments have a choice.
True, true. Because in Europe, cases are going up as well.
I think it's the same thing. Unfortunately, Singapore is always the herald for things to come. Like, one of the earliest cases, I was just looking back, I think Singapore had the highest number of COVID-19 cases in February 2020, last year, for the first, when everybody else was, quiet, because we had some, there's a tourist from Wuhan, and then they start passing, and then so our numbers suddenly increased. And of course, after that it became steady. But I think the same thing happened to SARS also. I think the problem is, we are in some ways too prepared. So, taking a lot of all this contact tracing and all that to pick up. I mean, like what's happening in China now, they still don't want to admit that, there's no such thing as zero control, zero COVID numbers, I think it's something that's just gonna happen. I bet you if you count, but now I think because everybody has to wear masks more or less, number of flu cases actually have dropped a lot because they're not passing.
Yes.
I think in any flu season, you're looking at numbers of 1,000-2,000 a day as well, if you start counting. So I think it's
true. Yeah.
But you are stationed in KL, or you used to be in Johor a long time, right?
No, Penang.
Penang.
7 years.
Penang. Okay.
Johari used to be in Johor.
Oh yeah.
Yeah.
Mhm.
And so he's back in KL because his wife is working in KL,
Mhm.
in the private. And
I see.
I'm working in Sungai Buloh now, in the Klang Valley.
Yeah. Sungai Buloh. Yes. Yeah.
But,
The very well-known, highly digitized hospital.
okay, but but at the moment it's also a COVID hospital, fully COVID hospital. So I have to decant my service to other hospitals around.
Yeah, it's happening everywhere. Luckily, also bad now.
So we will start maybe around 1 minute because the IT team are arranging few queue. So for your information, actually our online registration reach maximum exceed 500. So if everybody try to get in at one time, they will be difficult. But I'm sure they will come on and off.
Yeah.
So we received about I think registration from 54 countries. That's very good.
Yep.
And also with the Neurosurgical TV and YouTube, those who cannot register can still view the event continuously. So that is good.
Do they go to YouTube or they go to Neurosurgical TV or both?
They decided to do YouTube.
Okay.
Because yesterday they test run, Facebook Live was not very stable. So John Bennett decided that better go to YouTube. Yeah.
Yeah, I mean, I think he's a great guy, doing all this, So
I think he guides us very well. So this is a good exposure to our team, especially the registrar and paramedic. Actually, we just mobilize our own team. So I think once they're ready, we will give the signal. Yeah, then we can start the opening very fast, and immediately we adjunct to our scientific session.
Sure.
So just give about 1 minute. Nadia and Nazlin, if you are ready, you let us know. We give a few second gap, then we can start the session when you are ready.
Good morning, Ms. Azmi. We are ready. We will start in 2 minutes, if that's okay.
Make it 1 minute, can?
Boleh? No problem.
Okay. Thank you.
Okay, Mr. Azmi, we shall begin.
Okay, please continue.
Assalamualaikum and a very good morning, distinguished speakers, friends and colleagues, ladies and gentlemen. We apologize for the slight delay. We were facing some technological difficulties, but we will now proceed. My name is Nazlin Said and I'll be your Master of Ceremony for today. It is with great pleasure that I welcome you to the joint AASNS educational course and second Kuala Lumpur Neurosurgical Emergencies 2021 webinar. This exclusive event is brought to you by the Department of Neurosurgery, Hospital Kuala Lumpur, and in collaboration with the Asian Australasian Society of Neurological Surgeons, AASNS. In addition to this, we are also broadcasting live via Neurosurgical TV, Facebook Live, and also YouTube Live. Ladies and gentlemen, the COVID-19 pandemic may have restricted us physically attending the conferences both locally and globally, but it has definitely not dampened our fiery spirit to seek knowledge and gain more experience in our ever-expanding field. C.S. Lewis, the author, quoted once, "The only people who achieve much are those who want knowledge and badly that they seek it while conditions are still unfavorable. Favorable conditions never come," they say. This is our unfavorable condition. So this is us moving forward with online learning platforms that allows us to connect globally despite these trying times. On behalf of the Department of Neurosurgery, led by Dr. Azmi bin Alias, Head and Senior Consultant Neurosurgeon and Vice President of AASNS, we are deeply grateful for the partnership with AASNS for this event in creating an education platform to share recent developments and discuss previous experiences that may benefit others. We would like to thank our speakers who have prioritized us in their busy schedule to enhance our knowledge on various topics. Lastly, to the participants, thank you for joining us. Without your support, this would not be possible. Ladies and gentlemen, let us kick off our event here. We will start with our national anthem, Negaraku. As a sign of respect, please kindly mute your microphones. We will now invite Dr. Hafiz Buhari to say a little prayer for a smooth sailing event. Once again, please kindly mute your microphones.
Bismillahirrahmanirrahim. Ya Allah, Ya Rahim. Praise be to God, Lord of the worlds. Peace and blessings be upon our Prophet Muhammad sallallahu alaihi wasallam and his companions, and for those who followed his example till Judgment Day. Allahumma ya Allah, on this blessed morning, in conjunctions with the AASNS educational course and second KL Neurosurgical Emergencies Update 2021, we beseech your infinite blessing upon us, your humble servants, to lead a safe and prosperous life. We seek your blessing for a smooth and fruitful event from the beginning to the end. We seek your guidance to steer clear of any difficulties that would be detrimental to this event. Ya Latif, Ya Rahman, please bless us and guide us to greatness, peace, glory, and prosperity in this world and hereafter. Grant us valuable knowledge that will be beneficial to mankind. Ya Munzil al-Barakats, bestow peace to our beloved countries. Preserve us from any threat and disaster, and recovered from pandemic of COVID-19. And to you, Ya Allah, we ask for security and prosperity upon us, our leaders, and our country. Bestow patience in us in order to face the challenges that may come. Please accept our deeds and please reward us accordingly. ربنا عليك توكلنا وإليك أنبنا وإليك المصير. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. وصلى الله على سيدنا محمد وعلى آله وصحبه وسلم والحمد لله رب العالمين.
Thank you, Dr. Hafiz. We now invite Dr. Azmi bin Alias, our organizing chairman, for his opening speech. The floor is yours.
Thank you, Nazlin, our master of ceremony. Assalamualaikum warahmatullahi taala wabarakatuh, and very good morning to everyone. Yang berbahagia, Datuk Dr. Azmin Kas Rosman, Head of the Neurosurgical Service, Ministry of Health Malaysia. Professor Sia Wan Tiew, the President of Asian Australasian Society of Neurological Surgeons, distinguished speakers, moderators, local and international participants, ladies and gentlemen. It gives me a great pleasure to welcome all of you to the joint AASNS educational course and second Kuala Lumpur Neurosurgical Emergencies Virtual Conference 2021. As the world is still fighting with the COVID-19 pandemic, we are very grateful to be here today to commence in what I believe as an exciting series of virtual educational programs meant for the young, established neurosurgeon and trainees. In addition to this course, they will be attended by local nurses and paramedics. The first KL Neurosurgical Emergencies Physical Conference was successfully organized about 2 years ago, covering various aspects of neurosurgical emergency. But for this year, the local scientific committee has decided to put special effort focusing on pediatric. The program was initially involved local speakers, but later, with the help and discussion with Professor Sia Wan Tiew, we are able to merge with the AASNS teaching faculty and therefore expand the scope of this conference. For that reason, I would like to take this opportunity to thank Professor Sia Wan Tiew and the honorable invited speakers AASNS from abroad for their undivided support and contribution to the scientific presentation despite their busy schedule. We truly appreciate your dedication. Not forgotten to the local speakers from various pediatric specialties, including neurosurgery, anesthesiology, neurology, emergency medicine, radiology, neurorehabilitation, and oncology for their participation. So in fact, we will have a 37 scientific presentation presented by 33 speakers, including 12 international and 21 local speakers, covering 16 academic continuous hours. And we also receive more than 400 online registration from 57 countries. And of course, the highest from Malaysia, followed by Indonesia, as well as India. And we also will be joined by 18 moderators locally. So we are pleased and equally excited to receive this overwhelming response. And to ensure this novel effort is reaching more audience, this two-day conference can be viewed live through Neurosurgical TV and YouTube. So special thanks to Dr. John Bennett from USA for helping out our technical team. So my sincere appreciation to organizing committee from Department of Neurosurgery, Tunku Abdul Rahman Neuroscience Institute, Hospital Kuala Lumpur, and Department of Pediatric Neurosurgery, Hospital Tunku Aziza, Women Children Hospital Kuala Lumpur, for their commitment since the beginning of the planning stage. Finally, I wish everyone a wonderful day and hope you will enjoy and benefit from the course. Thank you very much.
Thank you very much, Dr. Azmi. Next, we would like to invite Dr. Azmin Kas bin Rosman, National Head of Neurological Services, Head and Senior Consultant of Sungai Buloh Hospital, for his welcome speech.
Good morning, Professor Xiao, Mr. Azmi, Organizing Committee, and all the participants. Thank you very much for the invitation. It's an honor to extend a warm welcome to the joint AASNS and the second Kuala Lumpur Neurosurgical Emergencies educational course. This ongoing COVID pandemic seems relentless in its pursuit to create a world tragedy at a biblical proportion, resulting in not a single person who is spared from the suffering by loss of life or financial support. And while we still try to do our best in the control and not the eradication of COVID, I am very happy and proud of the Zoom webinar, which is jointly organized by Mr. Azmi and the organizing committee in collaboration with the AASNS. During these 2 days, the speakers and organizers hope to share their experience and knowledge on many topics with focus on pediatric emergencies. I believe it will be a benefit to all the staff in our neurosurgical centers. We are happy and grateful to have the presence of prominent speakers from Singapore, Indonesia, Taiwan, Japan, India, Australia, and Israel. And we are also equally delighted and grateful to have Malaysian speakers from different public and university hospitals. Finally, and again, I wish to congratulate the event organizers for their time in organizing the event during this difficult time, which will be of benefit to all. Thank you very much.
Thank you, Dr. Azmin. Finally, we invite the Associate Professor Seo Wan Tiew, the President of AASNS and Senior Consultant at the National Neuroscience Institute, Singapore, for his welcome speech and officially to open our event. Welcome,
Thank
Professor.
you very much. That was Dr. Azmin Kas, National Head of Neurosurgery Services, Ministry of Health Malaysia, Dr. Azmin Alias, Chairman, Organizer of this meeting, and to all our honorable speakers who have sacrificed the time to join us. On behalf of the Asian Australasian Society of Neurological Surgeons, I extend my warmest welcome and greetings to everyone who is attending this joint AASNS educational course and the second Kuala Lumpur Neurosurgical Emergencies 2021. I thank and applaud Dr. Azmi and his organizing committee for the tremendous effort in organizing and hosting this Zoom webinar from Kuala Lumpur. They have invited an exquisite group of speakers whose lectures will surely benefit all our young and budding neurosurgeons and also help us, the older neurosurgeons, to reflect on what we do. And I also need to thank Dr. John Bennett of Neurosurgical TV for his help and guidance in getting this meeting streamlined on YouTube and Neurosurgical TV. I mean, the COVID-19 has made things bad, but again, as was mentioned, it's all our effort to try to get things going. And actually, in this case, I must say that Azmi has done a great job. With very little time, he's actually put up a lot of speakers that will help us to enjoy this course and learn more. And so for this course, they'll be discussing a range of topics from neurotrauma, neuro-oncology, neurovascular surgery, as well as neurosurgical emergencies with a special focus on pediatrics. So they planned a great program, and I hope that you all will have a productive conference and a great learning experience. Thank you very much. Yes, and I officially open this course and meeting. Thank you.
You can reach me in many ways. It don't matter how and when. Simply make the time for the best time of your life. Think of what you always dream. Think of what you want to see. Simply make the time for the best time of your life. Malaysia, truly Asia. It's the place with it all. Malaysia, truly Asia. Why wait for the best time of your life? For the best time of your life. Malaysia, truly Asia.
Thank you very much, Prof. Wan Tiew, for the warm welcome speech. We hope you have enjoyed the video. A special thank you to Dr. Fazli Shah for his much appreciated creative contribution of these videos. Ladies and gentlemen, before we begin our sessions, here are several housekeeping rules. This housekeeping rule is for our distinguished speakers today. Each session will last for 20 minutes. So, to be respectful for other speakers and to keep schedule on track, you will receive a reminder bell 15 minutes into your session to mark that you have 5 minutes left. Here is the reminder bell you will receive. I repeat, we hope that you will be able to complete your session within the 20-minute mark. Next, to the attendees, if you have any questions for the session, please kindly type them at the Q&A chat box. These questions will be discussed at the end of each session. Thank you. Ladies and gentlemen, we will now kick off our scientific program. I would like to invite our moderators for the first session, Dr. Priya Sharda and Dr. Mahjun Kui. Dr. Priya and Dr. Ma, the floor is yours.
Very good morning. Thank you very much for the kind words. Dr. Ma and I are both ecstatic to start off this first session. Without further ado, I would like to invite Dr. Yap Xiao Leng, who's a consultant pediatrician who's working in the Women and Children's Hospital HKL, currently in Malaysia. Her vast experience in both clinical and administrative work and organizing experience makes her a valuable asset to the pediatric community in this country. Dr. Yap Xiao Leng.
Thank you, Dr. Priya. I'm just sharing my screen now. Are you all able to see my screen?
Yes, very clear.
Okay.
Yep.
Okay.
Thank you.
A very good morning to everyone, Mr. Asmi and a lot of the other neurosurgical colleagues that I've had the pleasure to work with. Thank you for inviting me to speak to you all today. The topic that was given to me is ABCs in neurotrauma. So I'm going to only focus on the pediatric side of neurotrauma, as you have been, you know that I've been introduced as a pediatrician. So this is the outline of my talk. Just because it's a 20 minutes talk, I will be focusing on the traumatic brain injury and not touching anything on the cervical and spinal injuries. So traumatic brain injury is one of the most common fatal injuries when a child faces trauma. In the US, this contributes to a very huge number of patient visits to the emergency department and also a large number that needs hospitalization. And although we are clinicians, we do not see those who have died on scene. There's also a very significant amount of patients. And whatever is said, I think we are here mainly also to prevent disabilities and also to deal with them as well. What are the mechanisms of injuries faced by children? Predominantly, it is falls as well as from the motor vehicle accidents on the road. And polytrauma is a very common thing. So it's not just isolated traumatic brain injury. And do not forget that any young child, especially less than a year old, non-accidental injury is very, very common. And in UK, they have about half of their ICU admissions are actually traumatic brain injuries in children that is less than a year old. So for me as an emergency physician for pediatrics, I need to probably communicate with my neurosurgical counterparts. And one of the things that you will see and hear us talking about is the conscious level when we assess the disability. And we use the concept of AVPU rather than GCS as our first initial conscious level assessment. We can interpret it and translate into the Glasgow Coma Scale, but this is actually a very rapid response. So again, we have a response to the GCS component. We also, hear the vocal aspects, the motor aspects, as well as the eye aspects, okay? For those who are in the more junior side, how do we actually know that this patient has a potentially serious traumatic brain injury? The history taking is very important, the mechanism of injury, whether there's a history of loss of consciousness from the time of trauma, and when the patient presents to us, what is the conscious level and responsiveness. And anyone with any obvious significant neurological signs and symptoms are actually kind of classified to have serious injuries. So just a very basic, back to the basics of Glasgow Coma Scale. We have divided into mild, moderate, and severe. And you know that severe is definitely anything less than 9. Just to highlight for those who do not deal with children, children have a different developmental age and milestones. This is where we do have a modified Glasgow Coma Scale called the Pediatric Glasgow Coma Scale for the non-verbal children. So the verbal response, rather than the talking and speaking with you, they may actually cry. So you have to use the age-appropriate developmental milestones to assess that. I'm not going to teach the neurosurgeons here on how to read CT scans. Basically, we still also use the same classification of injuries if we look at imaging, whether it's a diffuse or focal injury. Now, as a pediatrician, I always need to talk about prevention. So primary prevention is the most important. And you can see in Malaysia and most of the Asian countries, you will have children on motorbikes without helmets, squashed in between or put in front of the basket. So this is something that we, even as hospitalists, we need to advocate and speak to the public about it. Now I'm just going to go to our core business, which is secondary brain injury. We know that it is something cellular. The effects are because of the biochemical and metabolic changes during having a brain injury. And the aim I would say, if anyone who's in an emergency, we have to halt and prevent the process of secondary brain injury from the word pre-hospital care, means at the scene, to the emergency department, to the OT or the ICU. Now, what happens after an injury? We know that the direct injury causes cerebral hypoperfusion and hypoxia, but over the next course of a few days, cerebral edema kicks in and the raised ICP causes the worsening of the secondary brain injury. So I'm just going to concentrate on the emergency department's management. Again, the concept for whoever who is very, very scared of children and you freeze when you see a child in front of you, the principles of management is the same for child or adult. We still use the advanced trauma life support principles. Now, in the ED, our goal is to identify traumatic brain injury, classify the severity, look for impending herniation, and do cerebral resuscitation, apart from looking after the whole polytrauma effects as well. So in the airway and breathing component, as well as the C-spine motion restriction, our goal is to prevent hypoxia, so give oxygen, whether if they cannot ventilate, have a good ventilation or breathing their effort, then we need to intubate and use this. We definitely need to use rapid sequence intubation. This is because if we intubate without giving a proper good muscle relaxant and sedation, we will actually contribute to a raised ICP. And ventilation no longer is called hyperventilation. We want to have a target of a good CO2 of about 35 to 40 millimeters mercury. And in the circulation, we will have to treat shock. So in the adult ATLS, there was a term called permissive hypotension. It is not advocated in children, especially in anybody who has a traumatic brain injury. So I don't think in an adult population, you would want to use permissive hypotension when you have a traumatic brain injury. This is because any systemic hypotension can worsen the cerebral hypoperfusion. I won't be teaching you formulas on the cerebral perfusion pressure, but it is actually correlated. And very important because in children, we do sometimes use hypotonic solutions as our maintenance fluid. In traumatic brain injury, we try very best to use isotonic solutions. This is to also protect the brain. However, in very young infants, the caution is that you do not want to also have hypoglycemia. So if you are using pure isotonic solutions, means you don't have any dextrose-containing solutions, I would suggest you have to do very frequent sugar checks. But anyone who's less than a year old, unfortunately, sometimes we can't avoid giving some dextrose-containing solutions. In the disability part, if they have seizures, treat seizures. We have to probably also prevent seizures from happening. If there's any signs to suggest there is a raised intracranial pressure, even in the ED itself, we will have to come to the management. I will talk about it in the next few slides. And neuroimaging, I think we will not be able to run away with it for those who definitely are indicated. And it's always a balance between, CT versus stabilization. I always call the CT scanner a tunnel of death. If you do not know how to, you are just rushing to get a CT just because you need to refer to the neurosurgeons for that matter. So sometimes in a child, we will have to always have a good conversations with our counterparts, which is our ICU colleagues, our neurosurgeons. At times, begging them to come and have a look despite we don't have a CT image because the patient is unstable. So we have to sometimes have this conversation. And temperature control. Don't forget, children get hypothermia very fast, especially in the cold ED, but hypothermia also worsens the brain injury. Now, these are our components. I'm not sure whether there's an ICU colleague going to be speaking about it, but it's actually a same kind of principles when we treat and prevent raised intracranial pressure. So things like hypoxia, hypocarbia, hypotension, making sure the head is elevated and stays in the midline for a good venous return, all the other metabolic components that we need to make sure they are in the target range, temperature, if they have any anemias, seizures, pain, and also sedation. So now I want to just highlight that pain can not just because of injury, but sometimes bladder distension, because a lot of people, after you have intubated, you are focusing on other aspects of management. We tend to forget to decompress the bladder as well, and bladder distension can also lead to pain, and this can also worsen the intracranial pressure. Now, tranexamic acid is something I know that there's a crash trial for crash 3 trial, right, for the adults, but in children it's also widely used, and please use it especially in the pediatric trauma. There's a very small study in Afghanistan on civilians with associated with war injuries, and they find that it is actually improves the neurological outcome, especially if you think that there's a TBI. I think I may not have time to go through this. There's a very nice guidelines on management of pediatric severe traumatic brain injury. There's a very good executive summary that you can actually look into it. But I just want to highlight that, of course, you cannot run away with neuroimaging. Other things that's probably more into ED is we go for hyperosmolar therapy, and this is where hypertonic saline is probably more advocated compared to mannitol, just because the evidence-based medicine points to there are more evidence towards the hypertonic saline. Of course, analgesia, we cannot forget about it after intubation, and all the other ICP kind of management strategies that I've mentioned. And there are also a lot of the ICU care kind of thing. Now I'm coming to one topic that I just want to touch about for us, because I was talking about severe TBI. Now we have a huge population of pediatric patients who have bumps in the head and they are minor trauma. And this is where in the ED we have to actually decide on whether to image them or not. There are many rules. I'm going to talk mainly on the PCAN rule. There's the other rules that you probably have heard of: CATCH, CHELIS, Nexus 2, and also probably the physician's preference. So this is just a very nice historical way of showing how difficult it was and is still now for us to decide who we need to do a CT scan, especially in the mild traumatic brain injury. So I like PCAN, and I'll talk about it a bit more. Okay, why is it so difficult compared to adults? You can just CT them, no issues. It is because in children we are worried of radiation risk. It may be very small on paper that you see that there could be one fatal malignancy after a CT scan for every 1,000 CT scans performed in children. But if you put yourself in the family of that child who gets brain cancer or a blood malignancy because they have a CT scan, that wouldn't be a best thing to do at all. So just to kind of share with you, there's this study that's the latest of world clinical decision tools, which is Nexus 2. And this is where it found that, well, Nexus 2 sounds quite good, but it actually increased the rate of CT scans using this tool. What about physicians' practice? Say I don't want to use any of these tools. It's very tedious. It finds that actually physicians' preference, the sensitivity is actually fairly high. However, caution to the junior ones. These needs to be somebody who is already experienced enough to make this kind of judgment without using any tools. So here I would like to talk about, so when should we CT? I like to use PCAN rule. for the as a ruled out tool, just because rule in is very easy. You see someone who has some neurological signs and symptoms like the mechanisms of injury and so on and so forth. Nobody in their sane mind will say, I do not want to do a CT. However, to do a CT just because a kid fell off a chair and have a a small bruise on the head is quite difficult. So this PCAN is actually very sensitive for children who is less than 2 years old. It's actually 100% sensitive, and for more than 2 years old, it's about 96.8%. And it actually brings out of all tools, the usage of CT is about 35%, which is the lowest. And the clinical important TBI that is missed is very small. It's about 0.2%. What do I mean by clinical important? Means that those that we have to get you to go into the OT or even going into the ICU or resulting in death. So PCAN is actually one of our rules. So if you hear us talk to you while we are doing referrals, you know that we are actually using this rule. And this is just a very short summary of how this rule comes about. But mind you, we only can use PCAN rule if the child presents within 24 hours of the injury. So if someone comes in with 3 days after the injury with some symptoms, then we can't use this tool for the assessment. Okay, hopefully I'm on time. This is a take-home message. I think the most important thing here is to recognize and promptly manage and prevent secondary injury. I just want to highlight for children and adults, the management is the same for severe TBI. Okay, thank you.
Thank you, Dr. Yap. Before we take a few questions, I would just like to remind everybody, if you have a question, please type it into the Q&A box. There are a few of you all who have raised your hands. We don't have that function here. So if you could type your question, it would be good. So we'll take the first question, Dr. Yap. Matron Norliana Nordin asks, hi, Dr. Yap, how do you prevent hypothermia in a pediatric patient with TBI and ED? Especially neonate patient. Thank you.
Okay, thank you, Matron. So in neonates age group, especially the young infants, they have a very high risk of getting hypothermia. So I think most EDs, we will have the infant radiant warmer for the infants or children who's less than 2 months old. You can always use that, and they actually have a temperature probe so that you do not actually overheat them as well. For the older children, if you have things like a bear hugger, you can actually always use it on them, provided you manage and measure the temperature properly. Secondly is that you can always use warm blankets. Remember to use warm saline. These are all principles of ATLS. So this is how we actually do, like cover them up, making sure that once we expose them to look for other injuries, we cover them up. Our problems here that we lead to hypothermia is that we leave them exposed. I hope it answered your question.
Thank you, Dr. Okay, we will go on to the next speaker, and we will take other questions at the end of this session. Sorry for that. Okay, what we will do is, thank you, Dr. Yap, for that wonderful speech, and I truly enjoyed it. It was such a good overview. I would like to invite the next speaker. The next speaker is Dr. Intan Zarina. Dr. Intan is a consultant pediatrician anesthetist. She works closely in the ICU setting, and her real vast experience is in the pediatric ICU, which makes her an asset towards this community. Welcome, Dr. Intan.
Thank you, Priya. Assalamualaikum and a very good morning. Can you see my slides? I would like to start for the next 20 to 25 minutes on the anesthetic considerations for pediatrics neurotrauma, since this is a neurotrauma sessions. But I won't be covering the spinal cord or cervical spine injury. Can you see I'll share my slide.
Yes, we
Yes,
can
at the
see.
entire we can see your slide.
I try to move the slide, but it can't move. Okay. I have problems of moving my slides. Okay, let me try to share again.
Maybe you stop the presentation and try to share again.
Okay, I'll stop the presentation.
Yep.
I have a new share now. Okay. Okay, the content will be an introduction, pathophysio management strategies in the perioperative setting and summary. I'm a pediatric anesthetist, so basically most of the time I'll see the patients in the theater. As Dr. Yap have mentioned earlier, traumatic brain injury is a global health problem and it can vary. And most of the time, it's about 80% of TBI is mild TBI and less than 10% required surgical interventions. The pathophysiology is because injury to the brain tissues that results from both primary and secondary insults. We can prevent the secondary insults, but most of the time, the primary is due to the preventive measures. The next question is why they are prone to traumatic brain injury? Because they have large head to torso ratios and disproportionately greater weight of the head and till cavarium. Because the pliability of the skull, the less volume of cerebrospinal fluid, fever myelinated neural tissue and higher cerebral metabolic rate and narrow autoregulatory curve, there's increased vulnerability to the damage. Okay, the management strategies is by, as Dr. Yap had mentioned earlier, rapid diagnosis, aggressive initial resuscitation, prevention of secondary insults in terms of hypotension, hypoxemia, hyper or hypocarbia, or hyper or hypoglycemia. So most of the child who's going for surgery, the diagnosis is by CT scan, and we will see they come is either with extradural hemorrhage or acute subdural hemorrhage or bifrontal contusion or subarachnoid hemorrhage, depending. Only about less than 10% require surgical intervention. The goal of the anesthetic management is to provide adequate anesthesia and analgesia at the same time, optimizing the surgical condition and avoid the secondary insults by maintaining optimal cerebral perfusion pressure and avoiding the increase in intracranial pressure. After the initial stabilization in terms of airway, breathing, and circulation, the anesthetist has limited times to get all this history of allergies, the medication, previous illnesses, last meal, and events of the trauma, apart from having to rule out either chest, abdominal, or pelvis injury. This ability is very important in terms of the GCS and papillary reaction. So if the child comes to the OT or during our pre-op assessment, most of the time the GCS is the first one that we will ask or assess. In the pre-operative evaluation, full blood count after the history and physical examination, the blood investigation in terms of fluid blood count and coagulation profile. This is very useful in critically injured child because, as we all know, trauma and traumatic brain injury itself will predispose the patients to coagulopathy, blood group cross-match, and if the child has an ABG, it will be quite valuable in terms of oxygenation and acid-base status. And family members or close relatives should be informed and consent for surgery and anesthesia, and the management post-operatively need to inform to the family members. In terms of airway, because you know that you are worried about cerebral edema or in terms of hypoxemia, if the child has a GCS less than 8, the child usually needs an urgent intubation. And most of the time, they are what we call a full trauma, in which we need to intubate the patient in terms of rapid sequence induction. The challenges in this patient is there's possibility of associated cervical spine injury, because most of the traumatic brain injury, you need to rule out the cervical spine injury. and then they may have a blood or vomitus in the mouth because increase in ICP or facial injury. So video laryngoscopy with manual inline stabilization is usually we do if you can't rule out this cervical spine injury. And we need to remember it has to be a smooth and gentle intubation, because you want to prevent hemodynamic changes that can cause secondary insults to the brain. If the child is not intubated, you need to examine in terms of respiratory patterns, rates, and oxygen saturations, because you will need to know whether they can protect the airway or not. And sometimes you need to intubate the patients if they have hypoxemia, hyper or hypercapnia. In terms of circulation, hypotension, it needs to actively sought and treated. Most of the time, we use normal saline, fluid of choice for initial resuscitation. You need to give 10 mL per kilo of initial bolus. If they are still hypotensive, you need to look for other extracranial causes of blood loss. So in terms of monitoring intraoperatively, basic monitoring in terms of ECG, pulse oximeter, and tidal CO2, temperature, and invasive arterial monitoring is helpful, because for patients requiring immediate surgical decompression, if you have an arterial line, rapidly identify, and it can help in identify the episodes of hypotension and frequent blood takings. In terms of central venous line, it may be indicated if you need a vascular access for a vasopressor, or if the child has difficult airway access. But bear in mind, rapidly increasing ICP or impending herniation, the placement of invasive monitoring line should not delay the surgical intervention. Another thing, the most important intraoperatively cerebral perfusion pressure. As we all know, cerebral perfusion pressure is the difference between the mean arterial pressure and intracranial pressure. Cerebral perfusion pressure is basically the effective blood pressure that perfuses the brain. In children, there's no optimal CPP in children with TBI has not been established, but a lower limit of 40 millimeter mercury is recommended. The ICP in neonates usually about 2 to 6, and in children is usually less than 15. And their mean arterial pressure varies with age. For cerebral perfusion pressure and hemodynamic targets, Chamber et al. Propose an age-stratified critical level of CPP. If the child is less than 6 years old, you try to maintain the CPP above 40. And if the child is 7 to 10, it's about 54. And if the child is more than 10 years old, it's more than 58. Cerebral perfusion pressure, there's various studies that single perioperative hypotension episodes after TBI can adversely affect the outcome. And the data from the Traumatic Coma Data Bank says association between hypotension and increased mortality rate in children with TBI. And after resuscitation, vasopressors that is good to optimize blood pressure intraoperatively is noradrenaline and phenylephrine. The anesthetics drugs that we use, it has to have a preservation of cerebral autoregulation in terms of stable hemodynamic. The important criteria for selecting appropriate anesthetic agent is there's no single ideal anesthetic agent is suitable, and there's no evidence to support superiority of one induction agents over another in terms of TIWA or volatile agents. The most important thing is to ensure optimal cerebral dynamic while minimizing adverse effect. The induction agents that most of us use is either thiopentone intermediate, rarely intermediate. Most of the time is thiopentone and propofol. It reduces the cerebral blood flow and ICP, but at the same time, you have to remember it causes reduction in cerebral perfusion pressure in terms of systemic hypotension. Ketamine usage in pediatrics. Okay, there's 5 adults and 2 pediatric studies that shows there's no increase in ICP. So there's an overall ketamine reduced ICP in 3 studies and increased CPP and MAP in 2 studies. But in these studies, there's no data outcomes were poorly reported. So, and most of the ketamine that that was used is usually in sedated and ventilated severe TBI patients. Volatile anesthetic agents in terms of isoflurane, sevoflurane, and desflurane, it has a dose-dependent manner of cerebral vasodilatation. So most of the time, if you use an inhalational agent, we use is less than 1 minimal alveolar ventilation concentration, because you want to reduce the dose-dependent manners of cerebral vasodilatation. And most of the time, the anesthetists won't be using the nitrous oxide because it can increase cerebral blood flow, cerebral metabolic rate, oxygen consumption, and intracranial pressure. How about neuromuscular blocking drugs? Whether to use suxametonium or rocuronium for an AV management in terms of intubation. Suxametonium and rocuronium provide optimal intubating conditions, but suxametonium or succinylcholine causes a transient increase in intracranial pressure. In children, you have to remember, if you're using a second dose of suxametonium, it can cause bradycardia, and it has a lot of contraindications in terms of hyperkalemia, patient with history of muscular dystrophy, of patients with extensive crush injuries in terms of rhabdomyolysis, of patients with afterburns or acute spinal cord injury, which is about 48 to 72 hours. Because of this contraindication, most of us move away from using suxametonium to rocuronium because this is an alternative drug. But the problems with rocuronium, it has a longer duration of action. So sometimes we might scared in patients we anticipate difficult airway. But the good things about rocuronium is you have a reversal agents, which is sugammadex, that can reverse the action of these neuromuscular blocking agents. In terms of oxygenation, hypoxemia should be avoided. So intraoperatively, we may have to make sure that there's no hypoxemia. So there's a lot of study using positive and expiratory pressure PEEP intraoperatively to recruit collapse of alveoli and improve oxygenation. In adults TBI, it was noticed that higher PEEP can attenuate the intracranial pressure. But Politano et al. Studies in 21 pediatric patients undergoing surgery for intracranial neoplasm and did not show any significant difference in ICP even after increasing PEEP from 0 to 8 centimeter water. But the current literature recommends if the patient has hypoxemia, it is good to augment oxygenation by increasing FiO2 and inspiratory time rather than increasing PEEP. Apart from oxygenation, the ventilatory strategies in terms of maintaining pneumocapnia, which is we try to keep the CO2 between 35 to 45 millimeter mercury, because we know worst perioperative outcome, both hypercapnia and hypocapnia, because hypocapnia reduces cerebral blood flow and there's a risk of cerebral ischemia. So hyperventilation is only for a short-term control of ICP and to facilitate of surgical exposure during craniotomy, and prophylactic hyperventilation is not recommended within the first 48 hours of TBI. So if you are managing patient intraoperatively, fluid and blood component is very important because the perioperative fluid management after TBI has an impact on the perioperative outcome. So the anesthetist or whoever is going to give fluids to the patients need to choose the types of fluids, whether it is a crystalloid or colloid, the osmolarity of the fluid, whether to use it liberally or restrictive. The basic concept is we need to use iso-osmolar crystalloid, which is recommended. Most of the time 0.19% normal saline, but bear in mind, in children, the large usage of normal saline can cause hyperchloremic metabolic acidosis. So we have a choice to use a balanced salt solution. For example, sterophendine, which the osmolarity is about 295 milliosmol as an alternative to normal saline. Regalactates or Hartmann's, it is a hypoosmolar fluid. And in patients who need a large volume of resuscitation, colloids or blood transfusion can be used to restrict the volume of crystalloid. Anemia can aggravate brain injury, and acute traumatic coagulopathy is common in isolated TBI. The risk factor for acute traumatic coagulopathy in children is a severe TBI, increasing age, or patient with higher severity of illness score, or brain contusion or laceration. So what is the optimal transfusion practice in pediatrics TBI? Most of us take the transfusion trigger of 8 grams per deciliter, but this is for children, not for neonates. Neonates, because of the small, large volume, usually they deteriorate very fast. Usually when the HB is about 10, we start to warm the blood and give it to the patient. Intraoperatively, glycemic control is very important. Intra-op glucose monitoring, because hyperglycemia can worsen the neurological outcome in both adults and pediatrics. And intraoperatively, we avoid dextrose-containing fluid except in cases of established hypoglycemia, which is neonates. And we need to monitor the blood glucose concentration regularly. Most of the patients, sometimes they need to be positioned in the prone position. So transient disconnection of invasive vascular or tracheal tube during position can be allowed, but we need to monitor at least the pulse oximeter and blood pressure. And care should be taken to avoid extreme flexion, extension, and rotation of the head to ensure optimal cerebral venous drainage. And if it is a prone position, we need to make sure there's a free movement of the abdominal wall, because most of the time the common complications with positionings are swelling of the face, neck, and airway that can cause airway obstruction later on, pressure sores, and peripheral nerve damage. Temperature management is very important. Intraoperatively, we try to maintain normothermia, and moderate hypothermia is only as a rescue therapy for an ICP control, and try to avoid hypothermia prophylactically in severe TBI. Intra-op management of intracranial hypertension, whether to use mannitol or hypertonic saline, because both of these solution, it has a plasma expansion that reduces the blood viscosity and reduction in cerebral blood volume, and the osmotic effect draws the cerebral edema fluid from the brain tissue into the circulation. And most of us likes to use hypertonic saline because this has a more favorable cerebral hemodynamic and faster resolution of intracranial hypertension. And most of us use 3% hypertonic solution to give over 10 to 20 minutes. And decompressive craniectomy is only to treat neurologic deteriorations, herniation, or intracranial hypertension, which is refractory to medical management. All TBI patients should receive broad-spectrum antibiotic prophylaxis. And in conclusion, TBI in children continues to increase as a cause of fatality worldwide, and children have unique injury patterns and response to injury. And the most important thing is to prevent the secondary insults. It needs a communication and multidisciplinary approach in terms of with the ED, anesthetists, surgeons, and ICU. With that, I would like to thank.
Thank you, Dr. Intan. That was a very comprehensive and detailed presentation. Without further ado, I'd like to pass my baton to Dr. Ma. He will introduce the next two speakers. Thanks.
Good morning, everyone, and welcome. Next, we'll move on to our third topic of the session. Before that, allow me to introduce our speaker, who is going to talk to us about non-accidental injury. She is Dr. Ng Wei Pin, a very good friend of mine and a very dedicated consultant neurosurgeon. She obtained her Master of Neurosurgery training from University of Science Malaysia in 2016. Following that, she has actively participated in multiple pediatric seminars, both locally and internationally. After that, she also have multiple publications under her name. Currently, she is working in Hospital Kuala Lumpur, as well as Women and Children Hospital Kuala Lumpur. With her wide experience in managing pediatric cases, I'm sure she's the right person to talk to us about non-accidental injury, while highlighting the red alert and also the approach in managing NAIs. Without further ado, Dr. Ng, the floor is yours.
Okay, can you hear me? Okay, thank you, Mr. Ma, for the kind introduction. So my topic today is non-accidental head injury, what we call NAHI, or abusive head trauma, AHT. Okay, this is the outline of my presentation, consists of terminology, facts, risk factor, mechanism of injury, anatomy and physiology pertaining to pediatric, sign and symptom, assessment, management, and prognosis. Okay, we look at terminology. According to Child Act 2001, child abuse is an injury to a children, basically physical, sexual, psychological abuse or neglect by parent or caregiver. Child Act 2001 define child is less than 18 years old. For non-accidental injury is a general term for inflicted physical injury to a child. Whereas shaken baby syndrome is a specific type of non-accidental head injury, and it implies a specific mechanism of which is shaking. So from the literature search, you can see a whole list of what we call terminology regarding child abuse. So our topic today is NAHI or AHT, of which is, according to American Academy of Pediatrics 2009, non-accidental head injury means that it's an injury to intracranial content or skull of infant or children under 5 years old that resulting from a variety of biomechanical forces like shaking, blunt impact, strangulation, or suffocation. The incident in US stated that what they call the peak incident of NAHI basically is at 6 months old, of which 1/4 of the fatal cases happen in 1 to 2 months old. According to Ang, in his publication, brain injury remains the most common traumatic death in children less than 2 years old. Okay, what are the risk factors of NAHI? Basically, it can be from the children, it can be from the family. In a children level, a premature birth, increased siblings of increased number of siblings, somehow male, inconsolable crying, and kids with a chronic medical illness always are the victims of this child abuse, or what I call abusive head trauma injury. In a family level, a low socioeconomic status, low education level, single or young parents, a divorcee, a substance abuse or lack of prenatal or child care experience in a parents cause are the basically trigger factors. So basically, stressed parents, an inconsolable crying child are the trigger factor for abusive head trauma. So always the perpetrator are from the caregiver. Somehow the babysitter are the commonest perpetrator, and followed by stepfather or mother boyfriend. Okay, what are the mechanism of injury in NAHI? Shaking basically causes attribute to 46 to 100% of the mechanism of injury. Repetitive shaking by causing alternative acceleration, deceleration, and rotation of the brain within the cranium, which cause the shearing of the parenchyma, blood vessel, and meninges, subsequently resulting in diffuse axonal injury and generalized cerebral edema. So other mechanism of injury can be attributed by blunt impact, of which is less common, or sort of dropping infant. So for infant, always mechanism of injury is non-accidental head injury. So what are the what are the uniqueness of anatomy and physiological of children? So just now Dr. Intan already mentioned few. So basically there are 10 actually biomechanical property of children, and causing them actually more prone to get injury. At birth, the baby head is 25% of the adult head, whereas the body of the baby is only 5% of the adult body. And inside this head, actually 89% are water. So infant or neonate, they always have a large head, of which the neck is muscle is weak. That's why their coordination are very poor. They also have a very prominent forehead, what we call protrusion with a high cranium face ratio. That's why the force easily transmit into the cranium. And the frontal and middle skull base are flat. Therefore, the rotational motion easily happen. The thin pliable covariance of which is only 2 to 4 millimeter, causing a easily deformation of a skull without fracture. Large anterior fontanelle enable the infant or neonate to actually slowly buffer the modest increase in intracranial volume, and therefore they will get an increase in intracranial COH rather than they deteriorate. But sudden increase in a small volume of 10 to 50 ml will cause them to deteriorate very fast. With the open suture, they can get a diastasis. The dura is adhered tightly to the inner skull. Therefore, the incidence of extradural hematoma is relatively low, but the thin arachnoid can be tear easily and therefore resulting in subdural effusion. So the thin bridging wing will cause what we call acute subdural hematoma in a longitudinal trauma. Sinus. Children only start to develop their sinus at the age of 5 months old, of it started from the maxillary sinus. And therefore, the poorly aerated sinus with a thin cortex and also poor myelinated axon, causing the children to get easily diffuse brain injury and also axonal injury. So what are the uniqueness about the physiology? Remember, kids are not little adult. So the underdeveloped brain barrier and also high vascular permeability resulting in cerebral edema easily occur. The high cerebral blood flow with a narrow cerebral perfusion pressure and low autoregulatory reserve, resulting them to vulnerable to get an ischemic. Underdeveloped myelination with immature suppression of the system, causing them to get easily convulsion in a shearing injury. And a lot of time, the frequency vomiting may not reflect the severity of the injury itself due to the underdeveloped of the vomiting center. And with a small blood volume, the child prone to get shocked. Okay, so what are the red flags of NAHI or abusive head injury? So the symptom can range from very non-specific to very severe. The child may come with irritability, poor feeding, vomiting, lethargy. All this can happen in any of the medical conditions of children that presented to emergency department. And apnea, respiratory distress until the very severe alarming reduced consciousness. Most of the time, the seizure are the most common causes that happen in 65% of the child that presented to emergency department. So what are the signs of NAHI? Bulging anterior fontanelle, subdural cerebral atrophy. In emergency department, one have to look for retinal hemorrhage and frenulum injury. Bruises are consist of 80% of the abusive head trauma injury. So therefore, there is a term what we call 10-4 bruising rules. So the bruising of all this area over the torso, the ear, and the neck, one has to specifically look into at the for the children that age 4 years or younger. Whereas in any infant, any bruisings that happen in anywhere of the body must alert us that regarding abusive head injury. So, okay, 1/4 of the children with severe abusive injury actually presented with sentinel injury that missed by physician. And a study stated that up to 3 times a children were brought by parents to emergency department, then only abusive head trauma came into the picture. What are the eye findings? So because of the acceleration, deceleration, rotational force transmit into the eye. Therefore, even though what I call a tightly adhered of the vitreous to the retina, because of the shearing force, all that, it can cause traction in vitreoretinal traction. And therefore, the children can develop a retinal hemorrhage and it occur until 53 to 80%. Most of the time, the retinal hemorrhage are bilateral. It involves multiple layer of the retinal layer and it extends until the ora serrata, of which the periphery. So a severe form of retinal hemorrhage can even causing an acute splitting of the retina layer, of which the blood accumulate in the macula beneath the internal limiting membrane, what we call a traumatic retinocytosis. So what are the cutaneous injury that we are commonly seeing? 80% will presented with ecchymosis, of which they actually presented with different area, different ages of healing over the padded area, over the face, behind the ear, over the neck, or behind the torso. So remember, 10 bruising, 10 region, of which children under 4 look at the torso, the ear, and the neck. And any region, if let's say the children is under 4 months of old. So of course, there are also other manifestation of cutaneous injury include burns, bites marks, and also marks from instrument and scar. So these are the appearance of bruises. Start from the initial first 2 days, the bruises can appear as red color because of the hemoglobin level up till at more than 2 weeks when the bruises start to resolve. The color can change from red to blue, purple to green, yellow, brown, based on the breakdown of hemoglobin to bilirubin to bilirubin. However, this progression may not be consistent. Okay, so basically the classic triads that we used to hear: abusive head trauma, acute encephalopathy, subdural hemorrhage, retinal hemorrhage may not always present. And in fact, a misleading history, a non-specific presentation with or without physical sign of injury always cause a diagnostic challenges to the treating physician. Okay, lack of specificity can lead to underdiagnosed, delayed diagnosed, and also misdiagnosed up to 31%. In a paper that published by our local neurosurgeon, there are characteristics of the abusive traumatic head injury, of which 80.4% of child presented with seizure, and up to 52.2% actually do not have history of trauma. In Malaysia, somehow male and Malay are more commonly involved, of which 93.5% of children always presented with retinal hemorrhage. And most common finding on the imaging will be subdural hematoma, of which consists 84.8%, and cerebral atrophy and subdural effusion present in the pre-existing. Okay, so therefore it is important to avoid underdiagnosed, delayed diagnosed, or even misdiagnosed. A high index of suspicion with evidence-based diagnostic criteria and targeted imaging are very important. Okay, so there is a tool what we call predictive abusive head trauma tool, PRET-HT tool. So this tool is actually developed by Cowley in 2011 to help the clinician to distinguish between abusive head trauma versus accidental head trauma. So if 3 or below of the 6 points here present, non-accidental head injury, NAHI or AHT is likely to present. Apnea, seizure, retinal hemorrhage, head or neck bruising, rib fracture, or long bone fracture. Remember, 3 out of these 6 that once present, NAHI or HT should be suspect. Okay, so mistakenly, of course, if you treat or you over-diagnose or mistakenly characterize any injury as a NAHI or AHT, it will be disastrous for a family or for the children. Therefore, always consider there are things what we call vascular abnormalities, sinus thrombosis, metabolic, connective disorder, bleeding disorder, coagulopathy, some bony abnormality like osteogenetic imperfecta, osteopenia of prematurity. All that can also presented as the clinical feature and symptom that I mentioned before. So the assessment part, okay, clinical evaluation consists of a comprehensive history, include the child developmental history, the family history, the occupation of the parents, the financial status of the family, all that must be asked. Then once you look for the sign and symptom, a complete neurological examination plus head to toe detailed examination. So always ask yourself, shall I need to act now and view what I do is going to change the patient outcome? So the GCS has been discussed by the first speaker, of which I will skip it. So there is a modified verbal score for infants. So the GCS will provide a quick neurological assessment and in terms of prognosis and also ability of the child to maintain a good airway. And it's significant when the total score reduced by 2 points or motor score reduced by 1 point. Okay, the indicator for workup. So in emergency department, if let's say you look at the inappropriate reaction of a caretaker or the children appears to be afraid of the caretaker, then yes, you have to further work up. So find the history, basically presence of risk factor, inconsistent carer history, unwitnessed injury, delay injury, prior multiple visit to emergency department, domestic violence at home, and chronic medical condition of the child are the history that we need to take up when we work out for abusive head trauma. For physical examination, once to look for failure to thrive, the torn frenulum, then bruises region. Okay, so remember in a non-ambulating child, if you don't close, basically you don't bruise. So the other cutaneous changes like burn, bites, scar, all that, and multiple injuries at various ages. All this from the history and physical examination, if you find all these features, yes, it's an indicator for further workup. So investigation consists of laboratory and imaging baseline investigation like complete blood cell count, coagulation profile, liver function test with or without toxicology. So for imaging wise, in a unexplained trauma patient, in an unexplained trauma child of less than 2 years old, a skeletal survey is mandatory. So followed by a cranial CT with or without MRI brain and spine. Do remember that occult fracture occur can up to 42%, and even though in a proven Nahi case, up to 50% there is normal finding. So there are also other imaging factors. So fractures can occur in the ribs or long bone. Squeezing of the infant child wall basically can cause multiple rib fracture and it detected from the skeletal survey. A shearing or torsion strain of the metaphyseal, basically pulling down the bone, causing a bucket handle fracture or spiral fracture of long bone, and commonly affected area will be proximal and distal tibia, proximal humerus and distal humerus. So imaging skull fracture. Skull fracture in abusive head trauma always complex, multiple, stellate, involving more than one bone, and there is also a diastatic and closing suture happen. Whereas subdural hematoma that occur in Nahi will be bilateral, most of the time, different ages or mixed blood density, and the location will be interhemispheric convexity or sometimes post fossa. And it tends to associated with very severe or cerebral edema, causing very bad midline shift, early ischemia, or even the infarction. So parenchyma injury also happen. Basically, the parenchyma involvement consists of parenchymal laceration, means that the subcortical contusion, the hypotensity within the subcortical involvement, basically the white matter injury. And cortical contusion happen. Okay, hypoxic ischemic injury can also happen basically when you see a hyperdense on a CT scan. The late sequelae include the white matter necrosis, encephalomalacia changes, and also cerebral atrophy. So big brain basically is particular to acute subdural in infant. So you can see the whole CT scan, basically there is poor grade white already. The decompensation of this happened because of the decompensation of the hemispheric cerebral perfusion metabolic demand. So the both hemispheres can appear hypotensity and resulting in high mortality of up to 46%. So physiological stresses include hypoxia, hypotension, hypocapnia, and also seizure. So modified grading of the radiological finding, and actually the AHT injury severity can be graded according to the CT scan finding, of which grade 1 there is no intracranial injury, grade 2A and 2B with intracranial injury but doesn't require intervention. 2B will be when brain infarction happen, whereas 3A and 3B, the intracranial injury will require surgical intervention, with 3B brain infarction happen. MRI not widely practiced because a lot of time we need sedation, but it's very sensitive to detect a acute subdural hemorrhage and also small subdural hematoma. So you can detect from the DWI sequence and also the SRW sequence, it detects the acute ischemic changes and also microhemorrhages that predicts the prognosis. So a term called lollipop sign or tadpole sign is indicate a bridging vein thrombosis. What you can see here is the bridging vein and ends abruptly in a clot. This support also a traumatic causes in a GRE sequence. So for forensic pathology in 2007 to 2009, in a publication by Malaysia, 33 infants that brought to ED brought in that basically only 40% had a post-mortem time. Therefore, even though we quote that the general mortality is only 50%, probably is even higher. In autopsy, one specifically have to look for subdural hematoma, what I call and also subarachnoid hemorrhage, and subdural hematoma with multiple fracture found up to 90 to 98%. In a chronic subdural, the iron stain appears at what I call brown color. So management guideline for Malaysia, we have one-stop crisis center, of which a 24-hour one-stop crisis center will be parked in emergency department provide for all these entry point of child abuse cases to hospital. And cases that suspect child abuse or abusive head trauma will be actually subsequently referred to a SCAN team, what we call a suspected child abuse and neglect team, and consists of multidisciplinary team hospital staff. So these are the flow chart of admission a child into the hospital. So it always remains a challenges to diagnose abusive head injury with limited history examination and underestimate injury. The role of treatment basically no different from any other injury. It's important to identify at risk of children, treat the mass effect, and prevent secondary insult. So surgery only indicated if significant mass effect, bilateral subdural drainage, or a craniotomy or craniotomy for subdural hematoma. So the prognosis only 1/3 with good prognosis. We reported death up to 33%, and a lot of time the child will end up severe disability, blindness, attention deficit, sensory impairment, motor dysfunction, intractable seizure, and cognitive impairment. So long-term plan, remember, child protection is priority in abusive head trauma. Assess the safety of the children to return home. Arrange follow-up, regular home visits, psychotherapy, and also play therapy for children. So the take-home message, remember, there's a diagnosis called abusive head trauma, from the history to physical examination to imaging. So NAHI or abusive head trauma is preventable. So if you see something, you want to say something, do something so you keep our children safe. Thank you.
Thank you, Dr. Ng, for the very informative and interesting presentation. For those who are just joining us now, welcome again. Next, we'll move on to the last presenter of the session. Our next speaker is Dr. Prabhu Rao, who will be presenting about trauma in the far reaches. Dr. Prabhu Rao is a living inspiration for many young neurosurgeons in this country for his educational strength as well as his working ethics. Dr. Prabhu completed both his undergraduate as well as his neurosurgical training, both in University Science Malaysia and with distinction. Following that, he also pursued his fellowship in pediatric neurosurgery, as well as fellowship in open and endoscopic skull-based neurosurgery from Oxford University Hospital. Dr. Prabhu spent most of his career in the east of Malaysia in the state of Sabah. Currently, he serves as a neurosurgeon in Queen Elizabeth Hospital, as well as the Women and Children Hospital Sabah as the head of department. With his invaluable experience, he will definitely able to enlighten us about the challenges a neurosurgeon would face in the rural area. Without further ado, I would like to welcome Dr. Prabhu for his next presentation.
Prabhu, you have to unmute. You have to unmute first. Your presentation slide is okay, but you have to unmute your microphone. Yes, perfect.
All right. Good morning. Thank you, Ma, for the kind words. I really appreciate. So I'm going to talk today about trauma in the far outreach. I mean, it is a very important topic, especially in the place that I'm working in Sabah, which is one part of Borneo. I'll explain to you why it is more crucial in this area. What I'm going to talk today is more about our experience and how we deliver neurosurgical expertise to these outreach areas, especially the rural areas in Sabah, where it has a poor access to healthcare. I mean, not really healthcare per se, but for neurosurgical service in specific. So let me start with my outline. So I'm going to talk about objective and challenges that we face in achieving that delivering of these services, and how we overcome these challenges in Sabah. And of course, the way forward, always we should aim for the future. So this is where I work. This is at Kota Kinabalu. We have 3 neurosurgical centers all centered in Kota Kinabalu, full-fledged neurosurgery services. This is Queen 1 Hospital, Queen 2, and Sabah Women and Children Hospital. So this video is what is going to show you to briefly make you understand why this services of outreach neurosurgical services is important in Sabah. So, and this is where Kota Kinabalu is, where the neurosurgical service is concentrated. And this is my hospital, Queen Elizabeth. And in entire Sabah, if you see here, this is the road networks in Sabah. So that makes you obvious that these are the hospitals available. The reach of the healthcare from the districts to the neurosurgical centers in Kota Kinabalu is pretty much challenging because of the transportation itself. So these are the other specialist hospitals in Sabah. If you see here, this is Kota Kinabalu, where the neurosurgical center is located. And we have other specialist hospitals where there are general surgeons, but no neurosurgical services, like Labuan, Keningau, Tawau, Lahadatu, and Sandakan. All are pretty much scattered to cover most of the area. And you see most of the other centers only have CT. And MRI here is just upcoming, is still in construction actually. So we have covering about 3.9 million of population. So why is trauma and the outreach is important? This is the framework for an access of surgical care as outlined in the global surgery. So if you see, there are a few factors that determines the access to services, to surgical services. One is the time, capacity of the center, the safety that the center can afford, and the affordability in terms of cost. So, and what are we doing here from the neurosurgery point of view? We are trying to fasten or trying to expedite in the factors that we can help to allow the patients in those rural areas to achieve or to enjoy the neurosurgical services as much as safely as how people in urban can expect. So of course, you know, in neurosurgery, time is of importance, because always as we quote, time is neuron. In animal lab studies, injured neurons were apparent as early as 3 hours post-injury through immunostaining. And delays for mild and moderate TBI patients were associated with high mortality, and this proven on multiple studies. This also suggests that quality improvement interventions should target the current triage practices to allow us to select the patients and how are we going to deliver those patients from the rural, deliver the neurosurgery services to those patients in the rural area, and in methods that we have experienced in. So we are of a center with 7 neurosurgeons, and together we're working hard in trying to deliver this neurosurgical services to the rural areas, to the district hospitals, I would say, with specialist services. As you know, neurosurgery is always costly. So this is a prospective study done in Uganda. It's a very interesting study that looked into delays in treatment in TBI patients. And we see there's a 4 time intervals here in this study they've constructed. And in between this 5 time points, which is an injury, the arrival of the patient to the hospital, the evaluation of the by a neurosurgeon, CT results, and definitive surgery. Of course, this might not completely translate to what we're doing here, because quite often the CT should be done first before it has been evaluated by a neurosurgeon. And what this study they found is the duration from injury to surgery varied considerably across TBI severity, with the largest gap seen between mild TBI and severe TBI. So even in severe TBI, if you can see the time from injury to surgery, it almost spans to 3 days. Of course, the challenges what they're facing in Uganda and might differ slightly, but again, the aim is still the same. We are trying to cater for the neurosurgery in trauma and to make sure the patients get an timely access to these neurosurgery services. So this study there in Uganda, they also found there's a significant association between delays along the neurosurgical care continuum and mortality, particularly even for mild and moderate TBI patients. So you might think that the timely access is only important for severe TBI, but clearly this study, they also found that it does affect even in mild and moderate TBI patients. So this is where we strongly believe that the triage or case selection in delivering the care is important. In global surgery, they have come up with a 3 delays framework, particularly, especially in the surgical care in general. And the first delay is delay in seeking care, where the patient should decide on when the patient to seek care. And you'll be surprising that you will realize, you might think that this delay is insignificant, but in patients where there is some cultural differences, this delay could be very significant, even in trauma patients. All right. And the second delay is the delay in reaching the care. So once the patient's decided, or the patient or the family decided to bring the patient to the healthcare, and the time taken to reach the healthcare is also of crucial importance. And the third delay in receiving care once patient is in the hospital. So the first and second, if you can see, as quite understandably, is what is beyond our control as a neurosurgeon. But what we're trying to do is to minimize the third delay, but to make sure the patient receives the care and timely and safely manner. So what are the challenges we face in our aim to deliver this service? So one is the geographical factor, as you can see, as I have highlighted earlier. The transportation, the road network in Sabah is definitely of significant limitation. The longest travel time from a district hospital to a neurosurgery center could span up to 8 to 10 hours. That is even with an ambulance siren coming from those hospitals. This is also partly because of the infrastructure, the road condition, and also in terms of the hospital factor, the facilities. So not all district hospitals have CT and MRI. So a patient might present to a district hospital without a specialist, and they have to be transferred to the nearest hospital with CT. And if there is evidence of head injury, then they will be discussed with the neurosurgeon in the neurosurgical center. So all these are contribution factors for the delay in treatment. But of course, and then the other one is MRI, especially if they were suspecting of spinal cord injury. The MRI is only available in the neurosurgical center. And the facilities in the OT, as you all know, the cost equipments of neurosurgery are definitely not cheap. And to station these equipments in all these operating theaters are definitely as a limiting factor. But we have tried to station some of the basic equipments, I'll probably mention that in one of my slides later. And of course, the presence of specialists. So we are banking a lot on these hospitals with the expertise of a general surgeon who in part of their training has had an attachment with a neurosurgeon and are able to deliver some of the life-threatening surgeries safely to those patients in order to cut time and also cost of transportation this patient. And limited local resources. The other factor, which I would like to importantly talk about, is patient factor. Like I said, there is a significant cultural differences if you see from these patients in the rural. There is always a delay in seeking treatment. And even when they are in the hospital for some complaint, and when you offer treatment, there is quite often we see there's treatment refusal or denial. And that's also partly because of intention to seek a traditional treatment. Even in trauma, if you don't believe me, even in trauma, we do see this refusal. So sometimes they tend to come very late. It's probably even if initially a mild head injury, but which deteriorated later. They might even spend a few hours or days before they decided to seek the treatment. And again, as time is neuron, all these things does significantly affect the outcome. Poor socioeconomic status. So for these patients to come to a neurosurgical center, which is almost 8 to 10 hours away by road, is definitely costly for them. Not only for the transportation, for their lodging, for the family to take care in a city where they don't have relatives. So this are probably things that sometimes we might not be in our mind, but you'll be surprised that these are the things that will actually affect the outcome, or does affect the outcome. And another one is uncommon mechanisms. We do often see mechanisms of injury that is not commonly we see in urban areas. So in fact, so in Malaysia, gunshot wounds are not that often, not that common, but we do on and off see referrals from gunshot wounds from these district hospitals. And have a picture of swordfish there. That is to highlight a case that I had about a few years ago, a child who was swimming and was struck by a swordfish. The bill of a swordfish penetrated his upper cervical, injuring his spinal cord, and presented with a Brown-Sequard syndrome. So it is a bit of interesting cases for us that we see, an uncommon mechanisms, and they are challenging to treat. And that child, we managed to remove the bill that was stuck on his spinal cord, and he is under rehabilitation. He has improved his neurology. Good for him. He's not completely hemiplegic, but he's recovering from hemiparesis. So how do we manage these challenges? So the key here, like I said earlier, is triaging. It's triaging this patient to select the patients that need urgent intervention, or I would say emergent intervention first, followed by urgent, or those who can wait a few days before a neurosurgical intervention can happen. Of course, we do understand not all patients need neurosurgical intervention, as in particularly in pediatric, as quoted by Dr. Yap earlier. So, and it's only about 10% of these patients will need surgical intervention, neurosurgical intervention, 10% of TBI patients. And second is understanding the limitations that they have in these district hospitals. Limitations in terms of facilities, in terms of managing the patients, and also the equipments in OT, like ICU bed. So even if you want to manage a patient with manage ICP in a patient without neurosurgically, medically, you would need an ICU bed. So of course, these district hospitals, they do have an ICU backup with an anesthetist on the site, but they have limited beds there. Third is we are managing this by expediting the management in various ways that I'm going to talk about in my slides later. Just take one point here, where indicated we should initiate medical management of ICP as early as possible, regardless of location. If the patient in a neurosurgical center, or even the patient is in ED, the moment you suspect there is an intracranial pressure, severe TBI with a high ICP, medical management of the ICP should be started as early as possible. As again, come back to the same dictum, time is neuron. So how do we manage the time here, manage the transportation of these patients and deliver our services to this? One is through Medivac Air Ambulance. So what is Medivac Air Ambulance? It's a service led by emergency department. It's an ambulance service. So like I said, the road transport is quite limited. So we use Medivac Air Ambulance to shorten the transfer time. To cost, it's a bit costly. I would not say it's cheaper because to activate the ambulance, and it's also a bit of weather sensitive, and we reserve them for urgent surgeries. So this is the emergency department team. That's the plane that they use, if you can see in the picture. So it's definitely not more comfortable than an road ambulance. You can see the space is very limited and how the escort team has been sitting. But yeah, these pictures are courtesy of the Medivac team from Sabah Women and Children Hospital. So the second is a satellite neurosurgery center. So here surgery is done by a general surgeon or trained and credentialed medical officers who have been trained in a neurosurgical center. So in these centers, the decision of a neurosurgery is made by a neurosurgeon remotely after discussion with him through various methods, WhatsApp, phone, and email. And the progress is of the patient's progress after that is updated on daily basis to the neurosurgeon. So the neurosurgeon sometimes do micromanage, but again, remotely with the help of an anesthetist on site who's managing the patient ICU, the general surgeon on site, and also our medical officers. So we have a basic cranial trauma equipments, and these are reserved for surgeries with their time is of essence. No delay in treatment for transfer in this. And again, this is for the only purpose is to save lives. And we also have a scheduled monthly visiting clinic attended by neurosurgeon in these district hospitals for follow-up the patients. So we have a pictures of intraoperative pictures, a courtesy of Dr. Shiva and Dr. Tan Hui King, two of our officers who are stationed in the district hospitals. So these are the cases they're done under supervision of a general surgeon in the district hospital who are also trained in neurosurgery as part of the general surgery training. So we have done depressed skull fractures, decompressive craniectomies, and also sometimes they do modify anesthetic ultrasound if they find difficult to identify the clot. But this picture is definitely for an abscess. Here, if you can see, that's aspirating an abscess. So here they're modifying an anesthetic ultrasound covering with a sterile cover. So extradural hemorrhage, no doubt, time is of essence. We are rushing time here. So sometimes they can do a very good, not sometimes, actually, most of the time they do a very good outcome in surgery and they do save lives here. So we have, so the second question will be running in your mind, is there a difference in the outcome of these patients in the district hospital and with us in the neurosurgery center? So we have one of our master students, Zulfadli. He's part of his dissertation of during his master's, he's been doing a study and comparing this outcome of these patients in this neurosurgical center and a district hospital, which is not a neurosurgical center. So it's a retrospective study. It's awaiting publication. We are very keen to look into his outcome, results and conclusion. So the last is flying neurosurgeon. So it's a bit interesting. So flying neurosurgeon, we reserve these cases, for the cases that could wait for 1 or 2 days. It's reduced cost of transfer. Only the surgeon moves. Better logistics for patient and family in their hometown. Reduced bed congestion in tertiary neurosurgical center. Definitely not for emergent cases because we fly on a commercial airplane. So these are the stationed equipments we have in this district hospitals. So we do a cranioplasties, titanium mesh, autologous, or skull reconstruction for a depressed skull fracture. And you see, this is a patient with a challenging cranioplasty that we have to do a few years ago because the general surgeon first did a U-flap trauma and then extended it for decompressive craniectomy. And then imagine doing a cranioplasty and raising the flap there within the cranial defect. So we also do a complex reconstruction. So this is a teenager which has a complex frontal orbital fracture, depressed, and this was him pre and post surgery. Yeah, these are all different patients and scans. Of course, this is the picture. We travel on a commercial airplane. We take turns. Like I said, we have 7 neurosurgeons. We take turns in going to these places and deliver the services. And yeah, this is the glimpse I get. That's Mount Kinabalu, which caught while I was on a plane. It's definitely not a holiday. It's a journey full of stress. I don't know how your patient is doing, how your patient is going to wait for you when you reach there. And when you come back, you worry about how the patient is done post-op. And the general surgeons and our officers there has been very helpful, guiding us, updating us, and helping us to manage post-operatively. So what is the way forward here? Continuous education for these patients, for our colleagues in the district hospitals, and surgical training, either our officers or general surgeons. This is where apprenticeship is important. So we want to train them so that they can go to the places and save lives. End of the day, that's what is our aim of. is to save lives and to build up the facility in the district hospitals. And finally, it's all for one main reason: to provide improved and equitable surgical care, in this case, neurosurgical trauma care, across the boundaries without compromising quality. So sometimes in surgical training, you teach them while you're doing the surgery, and sometimes you do have to let them do and observe and guide them step by step. And this is the BTF guidelines on the neurosurgical trauma. But mind you, besides all this, there's always more to neurosurgery than neurosurgery itself in delivering the accurate neurosurgical care: time, safety, and also affordability. All things need to be considered in managing a neurosurgery patients. This is my references, and thank you, everyone. I think that's the end of my talk. Glad to be here. It's my honor. Thank you very much to everyone.
Thank you, Dr. Prabhu, for your very interesting presentation. I'm sure now the audience have a very clear picture on the difficulties and limitation that most neurosurgeons would face, especially they are covering a wide state, big state like Sabah. All right, ladies and gentlemen, now we have come to the question and answer session. Again, participants who have questions for the speakers, you can type it down under the Q&A chat box. Write down your question and who is the question is for, and we will try our best to forward the question to all the presenter and speakers. I'm sure they are pleased and more than happy to answer your questions. Okay, let us now start off with the first question.
I believe there was an answered question by Dr. Yap just now. It was in the question box on anti-epileptic. Just to share with everybody, Dr. Turgai had asked about prevention of seizures, whether Dr. Yap would start anti-epileptic earlier or when they suspect an increase in ICP or any symptoms to relate to that. So she had appropriately answered this question. She said that the initiation of an anti-epileptic for severe TBI and definitely would raise ICP. Timing should be after stabilization and life-threatening injuries that do not require the weight of the imaging. Okay, so that was her answer.
Perhaps if Dr. Yap can answer live also okay, and for example, what type of anti-epileptic drug that you commonly use in ED for pediatric patient. Maybe if you can join us back, Dr. Yap. Okay, all right.
I don't know.
Hi. Sorry. We commonly still use phenytoin. I think a lot of studies are going towards using levetiracetam as the choice in the latest evidence. However, there are also studies that shows that phenytoin is still at best to prevent early post-traumatic seizures. And that's widely available in all the EDs in Malaysia compared to levetiracetam, which especially in my center is still controlled in terms of budget by the neuromedical team. Of course, there are also thoughts about using fosphenytoin. We do have some limited budget in the ED, so do not feel that it's weird if you see that we actually also prescribe fosphenytoin for this group of patients. Thank you.
Okay, Dr. Yap, thank you for your comment. I have a question for Dr. Prabhu. Earlier in your presentation, you did mention that certain credentialed general surgeon or medical officer, you allow them to perform certain neurosurgical procedure in the rural or district hospital. Can I know what kind of procedure that they are normally done or performed in the district hospital?
Hi. So for these cases, we do reserve for surgeries which is a time of essence, where the we can't wait for the patient to be transferred 8 hours through the road journey to a neurosurgical center, nor can we wait for a neurosurgeon to fly there on a commercial airplane, probably the next day, most earliest that we could get to do the surgery. So these cases are like extradural hematomas for obvious reasons. We know decompressive craniectomy with refractory ICP if needed in a TBI. And then, of course, simple surgeries like tolerant suturing of laceration wound and some simple elevation of a skull fracture, also, which they could do. Probably not the one involving skull base, not with the one with the CSF leak. Usually we would fly in and do that, or we'll get the patient transferred to neurosurgery center. But commonly they do is EDH and then decompressive craniectomy.
Okay, I totally know where you're coming from and the challenges that you are facing. Besides that, is there any checking mechanism or any guidelines where all these general surgeons are following right now?
So in terms of management decision on when to operate and even in post-operative care, they are all discussed. Every single case of them are discussed with the neurosurgeon in the remotely. So the decision for surgery is made by the neurosurgeon. So they, in terms of guideline intraoperatively, these surgeons, they have trained with the neurosurgeon as part of their general surgery training. And before they are being independent in a district hospital, they are qualified general surgeon. So it is part of their training to go through a neurosurgical training as a neurosurgical attachment as well. So, and in terms of our officers, they are trained with us, and they are only sent to district hospitals when they are credentialed and privileged to do these surgeries. And they do this under the supervision of the general surgeon.
Okay, thank you, Dr. Prabhu, for your comment.
We have another question. It's also for Dr. Prabhu. Hi, Dr. Prabhu. What is the preparation for transfer patient using air ambulance or road at rural area to prevent increased ICP? This question comes from a Saraline Ahong.
So if in a severe TBI patients with ICP problems, so if we decided to transfer this patient through air ambulance, we do initiate, like I said, initiating medical management of ICP is crucial, and that is initiated as early as possible in the emergency department as well. So the challenges we do have here is to activate the air ambulance. It does take some time because it does involve a lot of other departments and airport, and of course, like I said, it's weather sensitive. So while waiting this time, the ICP management is started initially as early as possible. And in where the ICP is high, we suspect the ICP is high, either from scan or clinically, we would give mannitol, or hypertonic saline, depending on the availability in the district hospital, during the transfer, and they'll be intubated, propped up as much as possible. Sometimes in the medevac ambulance, they are not able to prop up, which is a significant challenge as well in the ICP. And those with unequal people, sometimes they're even mildly hyperventilated and during the transfer.
Perhaps I have a question to Dr. Intan Zarina, pertaining to the anesthesiology role in emergency pediatric cases for trauma and tumor. Sometimes we do a tumor surgery and emergency as the child deteriorated. So is there any different in terms of preparation or challenges that you face based on your experience working with our team or in other center as well?
Thank you, Mr. Azmi. Most of the time, if it's a tumor cases, we have a lot of times to prepare the patient in terms of venous access and monitoring. So most of the time, if it's a tumor cases, we need to put a central lines and intra-arterial blood pressure monitoring. Whereas in trauma patients, sometimes we don't have the times to do that in patients with impending herniation. But if the patient is stable enough, preferably big lines and intra-arterial blood pressure monitoring is advocate. But and another thing is in trauma patient, since we are managing most of the time, if it's a neonate and infants, they have smaller blood volumes. So the anesthetists need to anticipate the blood loss and coagulopathy earlier if you compare to the tumor patients which we had prepared earlier.
Okay, thank you very much for your support and for joining us. So
Thank you.
one question to Dr. Ng Wai Peng, pertaining to the report when you have a non-accidental injury, is there any problem with the doctors to report or any resistance from the family, especially if the perpetrator is suspected to be the parents themselves? Can you unmute?
Supposingly, if let's say follow the child abuse guideline in Malaysia, there is a proper guidance on how we actually diagnose, how we actually fill up all the history, the physical examination finding into the form, and also we submit subsequently to the respective department. And regarding reporting the case, so far there is no issue, but then one must be what I call get a very comprehensive history, because a lot of time the perpetrator or the parents, they actually deny, but somehow with a clinical finding, the history and also the imaging, no matter how, we still cannot run away from diagnosis NAHI or AHD.
Okay, thank you very much. I think we had a very good first session. So I request everybody to on their video, because we are going to take a group photo. Can we, especially the speaker and whoever in the panelists, we're going to take a first group photo. Every session, we take some group photo to document that our present. Prabhu, can you on your video? Yep, if possible. Nadia, Prof. Daminlai, you're here. Thank you very much for joining us. Prof. Wantiu, thank you again for joining us. Okay, can the technical team ready you to take a shot?
Yes. Yes, yeah. Ready.
Okay. You just make the count, then we smile.
Okay, on my count, yeah?
Invisible.
Okay.
Are you ready?
Yes. Okay, so ready, yeah? 1, 2, 3. Okay. Excellent.
Okay, back to the moderators. You can wrap up and we move to the next session.
Okay, ladies and gentlemen, finally we have come to the end of the session. We would like again to extend our gratitude to all the invited speakers for their time and informative talk, and also not forgetting the participants for all their active involvement. Hopefully, we hope that this webinar will be beneficial to everybody. Thank you once again, and now I'll pass back the session to Dr. Nadia and Dr. Louis. Thank you.
Thank you.
Thank you, Dr. Priya and Dr. Ma. We will now proceed to the next session. Next, we have our second session with the umbrella topic of spine. I invite Dr. Ravindran Bashu and Dr. Lau Bik Liang as the moderators for this session. Dr. Ravi and Dr. Lau, the floor is yours.
Very good morning. Welcome everyone to the joint AASNS educational course and second neurosurgical emergency. We are moving on to the second session, which is the spinal segment. It comprises of 4 talks, starting with Dr. Albert Wong, Professor Abdul Hafiq Bajamal, Professor Daming Lai, and Professor Krish Nair. So to begin the talk, we will introduce the first speaker. my moderator, Dr. Bik Liang, and I will be conducting this session as moderators. And I invite Dr. Bik Liang to introduce the first speaker. Thank you.
Thank you, Dr. Ravi. Thank you, the organizer. I'm Dr. Lau from Sarawak General Hospital. So I'd like to invite our first speaker, Dr. Albert Wong from Sarawak General Hospital. He is our consultant head of departments of neurosurgery in Sarawak General Hospital. He got his FRICS in Australia, subsequently completed the spine fellowship in University of Toronto, Canada. He's have several special interests, including spines, cerebral vascular diseases, and he's also actively in doing teachings in University Malaysia Sarawak. One of the examiner for master in neurosurgery USM, and also the MRCS examiner. Not to forget that he has done multiple presentations in different conferences as well. And he's also actively publishing papers, more than 30 papers in a lot of different journals. With this, I would like to invite Dr. Albert Wong to give his presentation. Dr. Albert, please.
Hi, hello, everyone. Are you able to see or hear me?
Yes.
Yeah, okay. Thank you.
Yes.
I'd like firstly to thank the organizing committee and particularly Dr. Asmi, and obviously the AASNS and the KL Hospital Group for this kind invitation. And thanks for the kind introduction from the chairman. My talk today will be on the early management of spinal cord injury. I think in tandem with today's topic for neurosurgical emergency, and I think I'm obviously mainly deal with adult patients, but I maybe better mention also pediatric spinal injury related things. Let me see. Okay, the way I proceed from here will be firstly on how to assess patient that comes to us with obviously trauma and acute situation. How to immobilize this patient in terms of cervical spine injury, for example, even the thoracolumbar spine. How to diagnose this patient so that we don't miss the diagnosis, and hence leading to further instability and neurological damage from spinal cord compression. And then reduction, in particular to spine, cervical spine injury, medical management, and obviously a little bit on definitive surgical management. The assessment of spinal injury is very important. We need to know that they are stable or not, and the level that the injury happened, and in fact there can be multiple levels, and how to at least assess them neurologically, and some sort of scoring that we use to document in terms of progress and further assessment. I think first and foremost is as a neurosurgeon, I think dealing with spine, or for that matter, Dr. White in Punjabi has very simplistically, mentioned before, is how the spine is able to withstand under physiological load, further trauma or irritation to spinal cord, nerve roots, and to prevent any deformity and pain due to structural damage. So it's very simple. As long as there's some neurological problem, to me and to the neurosurgeon, I think we should treat it very seriously, including instability. Now, firstly, who's with X-rays? I mean, spine injury is slightly different from a cranial injury, where I think skull X-ray is not really that telling. But X-ray for spine is very important. Okay, and what X-ray views should we do, and whether we need CT scan? Firstly, the level of injury, we must firstly define what is the level, because rather than thinking that this most level had to be 0 out of 5, but in fact, by definition, it should be the most caudal level with at least 3 out of 5 motor power with pain and temperature sensation being present. And also, invariably, we come to hear like terms like complete and incomplete injuries, or any incomplete injuries defined as any residual motor or sensory function, 3 segments below the level of injury that you just defined from what I said earlier slide. In order to document things like GCS, I suppose, for head injuries, I think the American Spine Injury Association impairment scale, or some people may even use a Frankel scale, I'll give you a sort of pretty easy way to document and to categorize this injury group. A being obviously zero power, zero sensation. E is normal power, normal sensation. C is the middle one, which is having power of less than grade 3, but in between B and D easily can be remembered. There's a chart for that. I think for initial admission, initial documentation is a good way to document it, but subsequently it's better to have a summarized form of the daily neurological assessment, because otherwise, of course, you will go into many pages. But nonetheless, that would be the baseline to start off. Immobilization is very, very important. For those who treat trauma cases, like the patient kind of head injury, invariably we need to clear the C-spine, okay? So about 20% of spine injury occur even after the initial trauma, during the transfer. And it's very hard renting to see patient injury could move. And seeing it over, I mean, my career at least, that patient initially move after missed cervical spine injury, become quadriplegic the day after. So nowadays happen less often. There will be about 20 years ago, 15 years ago. So really we need to be on the balls and I mean, on our toes, sorry, and to be able to diagnose it early. And 20% of these patients have multiple levels involvement, and hence may need spinal immobilization for a start, and then maybe even fixation in OT. Spine immobilization, suffice to say, cervical collar and spine board during transfer is paramount. Now, different types of collar being used and whatnot, I think maybe some idea, but actually at the end of the day, in terms of significance, doesn't quite matter. Rigid collar is the preferred, and obviously soft collar will provide less protection. But obviously, if you put a patient on collar, you need to also quickly clear the C-spine, for example. You don't want to like leave it on for days on ends. So quick review the patient and get it out if there's no injury, because spine injury can also, I mean, the collar being put on to protect the spine can itself have some problem like raising ICP to a certain degree, but that significance is still debatable, but certainly it's not without a problem. It can also lead to pressure sore and also respiratory limitations. So I think we should quickly clear it, get it out of the collar. If there's something wrong, then to proceed to the next step, not to leave it on and hang on for a long time. Now, radiologic assessment for cervical spine, like I mentioned before, X-ray is very important. In the asymptomatic patient, then in the trauma setting, we don't need to do X-ray if it's normal neurologically. The patient, there's no intoxication, no pain, and no destructive injury, painful injury. So X-ray itself, I think, is class 1 studies that shows its negative predictive value of a normal 3-view cervical spine X-rays, AP, lateral, open mouth, can go up to 98%. So it's pretty good, negative predictive value just for X-ray alone. So that should be used to the max, and because it's easily available both in district hospital, like CT scan, and in the general hospital, obviously. And if in doubt, flexion extension view should be used, and it's very safe in the conscious patients. It's been proven in the literature. In symptomatic patient, means that the patient actually have pain in the neck, then you have incidence about 6% of a significant spine injury. All right, so we really need to make sure we have adequate X-rays that done in an adequate manner to be able to rule out any serious cervical spine injury. So a 3-view spine X-ray series and a CT scan, for example, at the cervical thoracic junction is very important. And with that combination, then you have a almost clear almost all patients. I suppose medicine start to say everything's 100%. With a very good class 2 evidence there. So for example, an X-ray like that, you will not say it's clear because it's hardly reached C5-6. And this one on the right-hand side shows that it's obviously good cervical spine exposure down to, for X-ray, C7-T1. So this is a case, for example, so it's a bit blurred here. I'm not sure you can see very well, but I mark it here is a C7 upper body. So you can't see C7-T1. And this one actually can go all the way. You can see the subluxation or dislocation of C7 on T1. Again, you really do not want to make cervical spine injury more complex, so should avoid delay in getting the injury sorted out. A patient came in about 6 months later with a 4-5 subluxation. Initially, the X-ray in this A&E shows that actually it was pretty normal, but the fact that the patient has pain in the back of the neck, and I think it's really make one to be vigilant that in future, when the spasm has resolved, he will need a follow-up and not just leaving out in the call for the next 6 months and to come back whenever there's a problem. And this is what actually happened in this case. Okay, so you should probably do another repeat X-ray, flexion extension view, and then review in 1 or 2 weeks time. By then, you probably will have shown some subluxation, and not wait until 6 months when the later on almost like 50% of the C4-5 sublux. Again, whiplash injury often diagnosed on symptomatic ground, but in X-ray from the initial stage may avoid some delay. Whereby then, if you want to fix the orthodontoid with a screw, for example, which maintain most physiological function, is already, I suppose, missed because you can't do that anymore. You have to do a posterior fixation in this case because of the sclerotic margin and delay diagnosis. Another important aspect of the X-ray would be a flexion extension view. You can see the atlantoaxial interval is so much widened when the patient flex forward on the left upper X-ray, and the one on line, just normal neutral X-ray, you won't be able to pick it up. But the patient complains of severe neck pain every time he moves or there's something wrong. I suppose you won't wait for that to happen if you can't have it being diagnosed in the first place. Another example of possibly you may miss a diagnosis, occipital cervical dislocation. You can see on the left-hand side, the condyle is outside where the C1 lateral mass is. And then obviously the MRI scan shows a severe compression of the cord at the cervical, cranial cervical junction. Okay, there's a powers ratio for the trainees to be able to work it out. If BC over OA is less than 0.9, you should be very careful, and this patient may have a atlantoaxial dislocation. It's very rare. This is when the problem starts because we will not normally think about it. But again, here's just a reminder. So subaxial cervical facet dislocation, by definition, if you have more than 50%, it's bilateral. If you want to achieve reduction, if you have traction on them, about a quarter will fail and only a quarter will maintain reduction. So this is a situation where if you can't reduce them, you then may have to proceed to emergent surgery. But if you have, then you have more time, you can do MRI scan done and so forth. Example of a left side is a unilateral, less than 50%. The right is almost the whole spine is dislocated anteriorly, 6-7. So this is a bilateral on the right side. Well, as I mentioned before, Skiwara is it's more initially diagnosed as a pediatric type of spinal injury, but actually nowadays I think you have seen that term being used even for adult, even for OPLL, etc. But basically, it's defined as a spinal cord injury without radiological abnormality. Popularized first by Dr. Pang in the States, published in Neurosurgery in 1982. It's mainly due to pediatric spinal column obviously be more lax, and hence you can have instability, but because the laxity is go back to its normal alignment. So on X-rays, you won't be able to actually see the subluxation or dislocation if there is or there was. So basically, mainly based on X-rays and CT scan in those days. But in fact, nowadays, if you scan this patient MRI scan, the definition of Skiwara, maybe if you leave the MRI outside the equation, then probably is still correct. But once you have MRI being part of so-called X-ray sort of armamentarium, then maybe it won't be called Skiwara now. But nonetheless, by definition and what it is, treatments mainly by bracing. But most of the time, I think in our center, we mainly do adult rather than a pediatric, just a mention of this entity. So indication for surgical treatment, obviously, if you're not able to reduce it and the facet instability is present, especially just ligamentous injury, you're more inclined to fix it than to use non-operative intervention. Certain amount of, I suppose, parameters they may use, like kyphoid deformity, compression, subluxation of 40%, 20% may be used to guide you. But in general, I think if there is instability in terms of the amount of degree or a lot of pain involved or any neurological injury, I will go and fix the spine to prevent further neurological damage. So initially, we close reduction, which is usually done in awake patient, and it's about 3 pounds per superior injured level. For example, in 5-6, you use 15 pounds. And approximately, I think a fair number could be reduced, but not all, I mentioned earlier on. Depends on which series you look at. Traction of this case of 7-1 dislocation, the traction 25 pounds managed to put in alignment on the right hand side, though not very clear, but the arrow points where the realignment actually got the spine dislocation back to the normal alignment. And a milder subluxation, traction 10 pounds, get it back in the alignment also before the fixation. So obviously you need to track patients, and if you put them on traction, once it's aligned, that you have to fix them with the, nowadays we use more screws and rods rather than a plaiting system, but whichever way you have to fix it with a fusion superimposed. In terms of medical therapy, it is just like the head injury side. You maintain good blood pressure, and it's found that if you have mean arterial pressure of about 90 mmHg, just like our head injury protocol, for 7 days, it improves neurologic outcome. So metapenisolone, okay, I think it's always been used and discussed and debated around. Basically, theoretically, supposed to help. It's why it's written like influence at the biochemical level. In fact, the use of metapenisolone is very controversial. Okay, it's actually first obviously published in the 1990s, in 1990, New England Journal, where the North American Spinal Cord Injury Society managed to put up this trial and concluded that if it's injuries within 12 hours, then you can give metaprep and it helps to improve outcome. All right, so the controversy comes along. I think it's because the subgroup analysis initially started for 8-7 patients with the doses that you already probably used to, and it's found that there is a significance for motor improvement after 6 months and a year. But in fact, the overall group of the 487 patients, if you analyze them, there were no significant change. But in the subgroup analysis of the 67 patients, there were change, and that was supposed significant. So the result based on the subgroup analysis were then proposed and carried on by most people. There's a reason for metaprep, but in fact, with the no significant change in the whole group, overall led to this current controversy. So timing, obviously, the earlier you fix it, maybe better. In the old days, in fact, for spine injury, you got to leave it around for a while. In fact, the earlier study shows that if you operate early, it has detrimental results. But then animal models with spacer compression, with piston and with nylon bands tying around, whatever in the animal models and racks and so forth, and they found that actually the earlier you release those compression, better they are. So then it's become a bit like difference in sort of result. Once that was the case with animal studies, and people also then started to look into early decompression, and small amount numbers or literature was coming out in the 80s, show that actually complete recovery could even be achieved if you actually align them early on. And then this is when early surgery became an issue. So like the Starkist trial by Prof. Billing has put up that if prospective multi-center trial, then maybe an early surgery is not detrimental. In fact, initially it was thought historically to be worse off, but they also found that if in early surgery, it's not only that it's not worse off, but it's actually sometimes helpful. Criteria are there, but you can look it up in this publication. Basically, it's found that for grade 2 Asia injury score improvement is about 2.8 times more in the early surgery than the late surgery group. So I think by now most people know that I think earlier intervention for compression of a spinal cord is definitely not worse, but slightly better off. Right, this is another graphical diagrammaric representation of his result in a grade 2 and grade 3 recovery, the significant benefit of early surgery. Just an example, a man who came in Asia A, but this is actually a patient with ankylosing spondylitis. He got a basically fracture of bamboo spine at C4 and also an EDH underlying. He came in Asia A, means that there's zero power, zero sensation. Can see the series of a CT scan showing the fracture, just basically a Chinese fracture through the C4 upper part of the body, and he was quadriplegic. MRI scan done show extensive extradural hematoma. Just be reminded that ankylosing spondylitis got fracture. Do MR and do early, because you will not want to miss an extradural hematoma and thinking that this is a spinal cord injury and recovery, because being Asia A is like very poor and hence nothing to rush to get it sorted out. So this case, because we MRI'd it and obviously the extradural need to come out and the fixation was also done. At the end of the day, from Asia A, he's basically leading a normal life and doing his normal job. So in this context, I think we should be reminded again, spinal cord injury, like brain injury, we should act fast, okay? And MRI won't be needed, okay? In the old days where we don't have access to MRI scan, we always think that because the tetraplegic patient had not such a good outcome, it probably would be a grave error, for example, in this case, because if later on you found that extradural, will be a bad outcome for the patient. Another thing that we need to mention, I need to mention, is thoracolumbar fracture. Of course, I'm neurosurgery, I think head injury. The nearest spine segment is cervical spine, but do not forget about the thoracolumbar spine fracture. And it's found to be also a delayed diagnosis in about 20% of cases. And then they will develop neurological deficit if again missed, just like the cervical spine. But one of the things is usually the thoracic or thoracolumbar area is assessed as a secondary survey, not the primary, where the primary survey usually is about cervical spine. But I think in the algorithm of things is pretty similar. So you must remember that you have to have if patient having altered level of consciousness and have another distracting pain, one should be very suspicious just to assume that is normal when there is no, for example, neurological deficit at the time. So it's really a whole spine series of scan need to be done for any patient coming with trauma, like vehicular accident. This is an example of a case, 22-year-old motorcyclist accident, came in GCS 14. So obviously it's not a full GCS. And he also had fractured ribs and pneumothorax. So obviously there are very good reason for distracting painful injury. But he moved all 4 limbs, so people thought it was not too bad. So it was locked roll, he got good anatomy. So that's it, So no X-ray was done because I think a lot of concentration was on the head and the cervical spine. But 6 hours later in the emergency department, he was noted to have paraplegism and paraplegia from 4 out of 5. So obviously, rush, scan was done, sure, T7, T8, T10 fracture with retrolisthesis, compression of spinal cord of T7, T8. So obviously, it is a delay and now resulted in neurological deficit severe. So no doubt we had to take him back, take him to OR and operation. So decompress like T8 and fix T6 to down to T10. But obviously, as we know, most of the time, an injury that resulted in zero power, unlikely that he will recover. There's a post-op, just an X-ray, not very clear, shows all the fixation in situ and reduction achieved to a CT scan. But unfortunately, patient obviously didn't do well because the deficit of the paraplegic continues on. So the best is to avoid further deterioration. I mentioned earlier on, including like the cervical spine. So in conclusion, there's class 1 evidence that we need to be basically not need to X-ray everyone, but nonetheless, we have to be very careful that they don't have a distracting painful injury or the GCS is actually poor. In that case, we need to rule out spine injury by at least 2 X-rays. of the relevant, in fact, if it's patient in coma, they may do cervical, including thoracolumbar. Or during all these processes, you have to make sure the spine is immobilized because if you have an unstable spine, it can lead to further deterioration or even paraplegia or quadriplegia. Use of metaprep, I still use it, although it's class 3 evidence. Early reduction definitely is advocated, and early surgery, no doubt, is recommended in the current state of management for spinal injury. And this criteria of what we do applies to thoracolumbar spine when patients do come in with a problem. So bear that in mind. Thank you very much. I think I'm finishing my time here.
That was excellent. Thank you very much, Mr. Albert. That was an honor.
Thank you.
Thank you very much. Any questions from the floor? At the moment, we don't have. May I, in that case, ask, can you please share if there's any challenges you face in terms of providing services to remote areas within your state where, as we know, as you mentioned correctly, the time is spine in this case, the challenges faced in transfer, etc., and how we sometimes can lose time, and that can affect the outcome of patients.
Sorry, you're asking me, is it?
Yes, sorry, Mr. Albert. Can
sorry.
you just share
Okay.
your challenges you faced in providing these services in remote areas where some of these patients can have spinal cord injury, but they're not immediately in your hospital, and this may be a unique feature in places like Sarawak.
Yeah. I think Sarawak. I think at the moment, from our perspective, we have if you say district hospital, again, X-rays are very important because it's definitely much more useful than skull X-ray. So that will be a good starting point compared to the earlier speaker on the head injury side. Secondly, it needs to be immobilized, which I've described earlier on. But I think for at least in our state here in Sarawak, located in North Borneo, we have 2 other neurosurgery centers now in the middle of Sarawak and in the northern Sarawak. At the moment, we're pretty well linked. In the old days, it's a problem if you have to transfer from Cebu or Miri because we need transport through air, just like the other states that I think other speakers are talking about. But because our 2 centers have been very established now, and our guys there are trained to definitely manage acute spinal injury, we probably have not much issue with that. But I still ask them to start metaprep, although there's a lot of controversy on it, and maybe people don't believe it. But I think it's no harm if you can get it improved. But it has to be according to what the criteria is, and not unnecessarily use it. But we have to inform the people who are managing this patient for a start that all these processes to put in place. I think importantly is to develop neurosurgery service as close towards the population that we serve, where they can have quick entry points at wherever place. Of course, depends on where you are, what country you are, and maybe sometime the situation will allow you or not. So yeah, all right. Thank you.
In the interest of time, and we will there are no other questions so far. And if there are any questions, please put it on the question and answer box, and we will try to address the speakers at the end of this spinal segment. Thank you very much, Mr. Albert, for your excellent talk. That's most appreciated.
Thank you, Ravin.
Thank you. And we'll move on to the next speaker, and I'm very pleased to introduce Professor Abdul Hafid Bajamal, and his topic will be pitfalls of traumatic thoracolumbar junction fractures, and he will be introduced by my co-moderator, Dr. Pik Liang.
Hi, so we'd like to move on to the second speaker. We'll be pleasure to have one of our very senior neurosurgeons from Indonesia, Professor Abdul Hafid from Airlangga University Hospital. So he is one of earlier consultants in Indonesia, currently holding the post of professor in Erlangga Universities. He's past president of 11 AASNS Congress, and currently is president of Indonesian Neurosurgical Society. He has been actively involved in multiple neurosurgical society, including WFNS, Asian Neurosurgical Association, member of Indonesian Neurosurgical Society, and also editorial board of Indonesian Journal of Neurosurgery. With that, we'd like to invite Professor Adu to give his lectures. Prof, please.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Ravindran and Dr. Bikliang. Thank you. First of all, I would like to express my appreciation to Professor Azmi Ilyas and Professor Sewantio for this extraordinary event. And also thank you, Dr. Albert Wong, for the beautiful presentation. I would like to present a pitfall in surgical management of thoracolumbar junction fracture. Can you see my slide?
Yes, we can see you, bro.
Okay, thank you. Now, TL junction, especially in T11 and L2, is the transition between the rigid thoracic spine and mobile lumbar spine, especially vulnerable during the spine trauma. The L1 vertebra is the most often injured, about 30%, and the most common type is a burst fracture, is nearly 40%. And the goal of surgery is restoration of anatomy, and then restoration of function, and prevent complication. The surgical outcome influenced by the clinical factors, especially the admission ACS scale. This is the most sensitive predictor, and also the time, type of surgery, the age of the patient, osteoporosis of the bone, BMI, and major comorbidity. It can cause of malunion, and also the imaging factors. Now, the standard imaging evaluation is X-ray, and the CT scan is very important, and it should be a routine procedure in the TL fracture. It characterizes the fracture better than another. The MRI can identify other lesion if you do whole spine. Now, let's discuss the classification in short. This is AO classification, type C, translation, displacement, type B, distraction, injury. Both type B and type C both require surgery. The use of posterolateral fusion depend on classification of McCormack. You can decide whether the anterior or only posterior approach. And type A, there's an A0 minor, you can do conservative. Type A1 sometimes is very difficult then to decide, and the type A2 requires surgery because the bone healing is impossible. And type A3 requires surgery. It depends on the anterior bone height and load sharing classification. And you can decide anterior or posterior. And the E4 is complete burst. Complete burst is depend on McCormack classification. If the classification grade is 6 or lower, then you can do only posterior approach. If more than 7, then you have to do combined anterior and posterior approach. The McCormack classification is very important to predict especially the screw breakage. This is the McCormack classification. This is the angle. This is the body height combination, and this is the apposition of the fracture. The Danish three-column classification is very important, and the anterior column is the most important. Imaging factor which can affect surgical outcome, vertebral body height, spinal alignment, displacement, dislocation, spinal canal diameter, and posterior ligament complex. But the most important is the anterior vertebral body height and sagittal alignment, because this can determine decision for deformity correction, proper reduction, stabilization with or without fusion, and also to evaluation the outcome. Anterior vertebral body height, how to measure? This is the anterior. A is normal height, C is normal height, this is the fracture side, B, and you can use the Santiago measurement to measure the percent of vertebral height loss. So the anterior vertebral body height loss more than 50% is a risk of kyphosis. And also the sagittal alignment is very important. This is the blue one. This is a cup angle, a regional cup angle. This is very important and to do in every fracture of TL fracture. The prevent kyphosis and the target reasonable correction acceptable alignment according to Schultz that Kopp's angle lower than 7 is reasonable for the functional outcome. But if the Kopp angle more than 10.5 after surgery, this is unfavorable outcome. This usually in the future need revision surgery. So insufficient correction can give progression of kyphosis and depend on the condition of the bone, and also if the Kopp angle not treated more than 20 grade, that is a correction loss, and usually the patient got severe back pain. Now, this is the algorithm. You can see the AO type 1 or 3. This is type 3. It depends on anterior vertebral and the Kopp angle. Sometimes is the vertebral body height is still good, then you can use a short segment fixation. In an osteoporotic, you can use short segment with CBT, cortical bone trajectory. But if the A3, if the anterior body height is lower than 50%, then you have to do an anterior and with a long segment fusion. If there is a combination osteoporosis, then you have to do cement and long segment fusion. This is type BC, usually need anterior transpedicular cage with a long segment fusion. Let's discuss short segment about short segment fixation. This is short segment fixation. You see the 1 year post-op, and then this is instrument failure, and then this is after correction with cage here. So we always have to consider the bone collapse because necrosis impair growth, malunion, and inadequate before the surgery. You see, this is also a short segment fixation with burst fracture. You see the instrument failure here in the after 2 years. So this is another case with compressed fracture with type I1. The body height is still good. You can use 6 screws fixation like this, and other 6 fixation screw like this is usually better than short fixation with 4 screws. Now, this is another technique, distraction compression technique with 6 screws. This is result. This is result is after 27 months. It's very good, but not always like that. You see, this is 6 screws, but it also can be get instrument failure later after 6 months. because of the bone growth. So this is also the 6 screws fixation. There is also instrument failure here 2 years later. There is a collapse of vertebral column in previous location. So pre-operative evaluation of post-vertebral condition with CT scan imaging is very useful. Now, it is another technique, 2 screws above, 1 screws below with vertebroplasty. Let's see, is it better? This is one of the literature compare. There is a 4 technique, 4 screw with crosslink, 6 screw with constructs, and 4 screw with crosslink and vertebroplasty, and 6 screw with vertebroplasty. And this is the best method and strongest fixation according to the author. Now let's see another pitfall, especially in a 50% loss of vertebral height. And if you usually use a cage, but for fracture dislocation or burst fractures with subjected to axial spinal loading post-operatively, should not consider short segment fusion, because you can see the breakage of the cage here. Now, how about vertebroplasty and kyphoplasty? This is one segment compression fracture with A3 incomplete. Vertebral head loss is not so much. We can do vertebroplasty in case the one level and simple one. But sometimes you need to think about to add a short segment fusion or to add a distraction compression technique on this condition in a young patient. Now, what about kyphoplasty? Kyphoplasty is intracorporeal injection. Kyphoplasty by vertebral expansion using stent of balloon. Actually, important is pain relief immediately in 85% of the patient. But according to the literature, the vertebroplasty, kyphoplasty for osteoporotic failure at risk of malunion and developing kyphosis. In vertebroplasty is no vertebral expansion, it's the only cement packing. There's a perpetuate the local kyphosis. The kyphoplasty reduced the fracture due to vertebral expansion, but lack of reduction and insufficient reduction and sometimes loss of correction are common. So this is a case with osteoporotic vertebral collapse. So most features are expected to heal conservatively. However, in some cases, fracture vertebra lead to insufficient union and acquired intravertebral instability like this. This is the OVC. You have to do this in a vertebroplasty, whereas the final follow-up and correction loss was superior in a long segment group fusion. So long segment fusion for this is important. TL compression fractures must be distinguishable from Kummel's disease. Yeah, this is osteoporotic compression fracture. Usually, this is a post-traumatic delayed collapse with delay of healing because of osteonecrosis. Usually, there is asymptomatic period after initial trauma, and the treatments usually conservative. If there is pain, then you have to give a vertebral kyphoplasty. If sometimes in a very selected cases, you need pedicle screw and expandable cage like this. Now, what about cortical bone trajectory for osteoporotic bone? This is a traditional screw placement, but this is different with cortical bone trajectory, and the screw used should be 5.5 and 3.5 millimeter length. This is the trajectory above and to lateral side, but this the trajectory to the medial side. Now, this is CBT is demonstrated superior fixation strength for each individual sufficient stiffness, inflection, and extension, and especially is very good for the osteoporotic patient. How about the long segment fixation? This is a patient with A4 complete and body height loss more than 50%, the canal encroachment, alignment is about 50 grade. Then you have to see the McCormick classification. This condition, this you can sometimes you can still doing a long segment fixation, but sometimes you have to do combined anterior and posterior. This is type C fracture, but the body height is still good. According to algorithm, you can do long segment fixation, but it depends on the anterior vertebral body height. If you reduce than 50%, you have to do combination. This is the anterior vertebral body height. It is still good. So you can still do long segment fixation like this. Now, this is important one. This is a compression fracture. You can see the opposition here, the spreading of the fracture according to McCormick, and the combination is more than 60%. Then usually you need, this kyphotic correction is more than 60. This is load sharing classification is about 8, so very high. So usually you need the posterior and anterior fixation. Now, but in this case, because of the patient is elderly patient and risk of complication of surgery, so we do osteoporotic bone injectable hollow pedicle screw. In this case, multiple pedicle screw and PMM injection and long segment fixation. Now, what about this patient with fall from head, multiple fractures? You can see this is type C, and the height loss not more than 50%. This is, you can still use long segment fusion. And what about this? This is very unstable. PLC also injury, spinal cord injury, very unstable. The area of type B2 should be anterior posterior correction because there is head loss more than 50%. If you do long segment in this case like this, then later this risk of breakage will happen. Thus the best one is to do like this cage, anterior cage, transpedicular cage, and long segment fusion. And what about this? This is actually, CT scan can clearly depict the damage. You can see the damage anterior and posterior. The head is lower than 50%. You can see the damage, fracture here, fracture here. This is a fracture. It's very clear, but the surgeon is still using long segment fusion. This is a very good surgery, but it doesn't take into account the result of CT. Anterior vertebral body head is very decreased. Posterior wall fracture, type C fracture dislocation, PLC injury. The risk for the future instrument failure may occur in this case. The malunion, the latest presentation of TL injury is important because inadequate primary treatment, usually 45% inadequate, late presentation 38%, and miss often 70%. This is malunion remain causes incorrect assessment at the first time, poorly conducted initial treatment, how to deal with the malunion. Usually you need to restore vertebral head and sagittal balance. Sometimes you need osteotomy. There is two types of osteotomy like this. And the conclusion of my presentation is, first is CT scan is the most important diagnostic should be routine doing on every TL fracture junction. Burst fracture with anterior vertebral height loss more than 50% is the risk for collapse and causing kyphotic. Consider an anterior column correction. A cup angle more than 10.5 grade after surgery may lead to unfavorable radiological results. Cortical bone correction should be considered in osteoporotic bone or in corrective surgery. Instrument failure influenced by surgical technique, bone condition, instability, anterior column condition. Thank you very much.
Thank you, Prof. There are two questions from the floor. Maybe we can quickly let Prof to answer. First, after inserting cement in fracture segment of vertebra, can you not insert screws? Second question is, do you perform anterior and posterior fixation in same anesthesia setting? Yeah, Prof, please.
Yes, the first one is according to what I have presented, that I think I can, sorry. I will share to you the You see, according to this, you can see that this is the best one. This is the best one. If you do like this, screw like this, then it's sometimes enough. But the best one is you have to put the screw. The next question is about the. Usually you can do in a two-step anesthesia. You can do in one, and sometimes you can do in. This is the prefer of the surgeon and the team. That's my question.
Okay, thank you, Prof. I think due to the time's limitations, we have to move on to the next presentation. I would like to invite Professor Daming Lai from Taiwan, National Taiwan University. He is Neurosurgical Division Chief, Department of Surgery in NTU, Vice President of Asian Australian Society of Neurosurgical Surgeons, and also the previous President of Taiwan Neurosurgical Spine Society. There's a lot of other titles that I'd like to introduce as well, but he's like to say his special interest and specialties was in cerebrovascular surgery, skull-base surgery, and as also the spinal surgery. With this, I would like to invite Professor Lai to give his presentation with the topic of high cervical spine injury, posterior fixation technique. Professor
Yes.
Lai, ready? Yep.
Yes, ready.
Over to you. Thank you.
Show this. Can you see my slide? Can
yes,
you see?
Prof. Yes, Prof. I can see your slide. I can see you as well.
Okay. Thank you, Professor Liang. And I want to thank AASNS and want to for allowing me to speak in this wonderful meeting. Today my title is high cervical spine injury posterior fixation technique. This is a fracture only diagnosed by CT scan. This is the fracture line. Each injury is enough and does need surgery. And also for this young patient fracture, so after traction and external mobilization, the patient is healing very well. However, in this kind of fracture is indicated. And right now, the indication for C12 stabilization is like this. And for so many years, many posterior fixation technique has evolved. Wiring in interlaminar clamp, and then transarticular screw, and then C1 lateral mass C2 pedicle screw, or C1 lateral mass C2 translaminar screw by near right. And this is the transarticular rod caterpillar like of fixed years wiring, and interlaminar clamp has been obsolete. It's rarely used because the fusion rate is not high enough. And if the patient is not feels well, then operation become very difficult. And transarticular screw, translaminar pedicle screw, or C2 part screw. These two are quite similar, only that the C screw is shorter before entering the vertebral canal. And we can use all of these depending on patient's condition. Because biomechanical study, in conclusion, by meta-analysis, these four kinds of fixation has quite similar biomechanical stability. And actually, in real world patient, after 3 months of external immobilization and surgery, every one of my cases fused. So no one need to be reoperated. However, transarticular screw has the potential of very popular. From the technical consideration, the C2 entry side is said to be 3 to 4 millimeter lateral and 3 to 4 millimeters superior to the inferior medial edge of the C2-3 facet joint. And this is the underfloor guide. We do the caping and then put in the cancelled screw. And this is the place that screw is inserted from, according to the literature. And this is the medial inferior edge of the facet joint. Traditionally, anatomical studies show that maybe the length will be 34 to 43 millimeter, and sagittal angle. However, these are normal person. It's not the patient. So this paper, in my mind, is not very useful. We usually encounter patients like this with substantial dislocation and fracture line, and even if patient is old, we still need to do the fixation. For fixation, for the screw to put in, actually from the CT scan, we can see these screw pads. So before the operation, actually, we need to see this film and these two, and also this, to see whether it's still enough space for the screw to put in. I also do the C1 lateral mass and C2 pedicle screw in some of my patients, and the screw can be very long. However, it needs 4 screws to put in. This is the size of the screw. So that will cause a lot of problems in bleeding and also in neck pain, suboccipital pain. Someone do C2 root sacrifice, and then there are a lot of anesthesia pain in the back of the head. C2 root can be preserved in 90% according to the literature. However, there are still a lot of neuralgia, dysesthesia, and paresthesia. And also, because we need to put 4 screws, there are much more bleeding than the transarticular screw. So if we can put in the transarticular screw safely, that will be better for the patient, I think. Throughout this year, I use intraoperative fluoroscope to put in the screw with any direction I like. And from my experience, early experience, occasionally we can see the screw is not perfectly placed. Why? It's because the intraoperative fluoroscope is not directly lateral. So if there are rotation, we think the screw length is appropriate, but after surgery it became too long or too deviated. How about vertebral artery injury? I have one experience, and this was put in by one of my fellow. And everyone has a different direction of mind. He thinks he's going straight forward. However, the screw is going lateral. And it's not injury the vertebral artery in the C2, but through the C1. So that's the only vertebral artery injury I encountered. So how do we avoid these kinds of complications? And this we do a TAE, and for the other side of that patient, I do the C1 pedicle and C2 translaminar screw. And this transarticular screw was removed, and the patient turned out to be fine. And also, these are deviation of the screw, not very good. And this one is okay. There's no vertebral. This is partial volume effect. So, what is the optimal trajectory and the entry site for the screw? Is that this one or anywhere? I will give the answer later. And for transarticular screw, in my mind, the most important part is preoperative planning for the screw to place, because according to the literature, direction, screw length, and misplaced or vertebral artery is the major issue. And dural tear rarely happen, or venous plexus bleeding is rarely happen. So most of the problem encountered here. One question is helpful in planning, and how much change with the preoperative CT or the position of the patient during the surgery, and what is the optimal length, insertion angle of the screw. So we use a 3-dimensional image for surgical planning, and I will show 2 cases. One is like this. After traction, we do the phantom and choose the side to entry the screw, and then to see whether the screw will violate the vertebral artery. And this is planning, and this is the final position, and this is the final side of the screw. And this is the end result of the screw. As you can see, this is very similar to our planning. And this is the patient. It seems like a textbook picture. However, in some cases, this is a 74-year-old female with sedation, and this is the final. This is the planning, and this is the final position of the screw. This is vertebral formant. We only put 1 screw. the other one is too narrow to put in the screw. So this is the image, this is the other side, and this is the screw. So in my mind, the insertion side can be more medial or upper, then we can avoid the vertebral canal safely. Sorry, this is Chinese, but I mean that we do the planning and then we evaluate the operated image to see whether it's correlation. And accidentally, we found that by putting the cancer screw, our original image and the final image after mapping the bony characteristic, we found that after the screw put in, the C1, the atlas can be reduced by the thread of the screw. So this is one benefit of transarticular screw. And there is an ideal match. This is the planning by the CT scan beforehand. And this is using software to do artificial lateral view of the X-ray. And this is final. There is a very good correlation. And this is during the surgery. Only slight deviation was seen by putting two images together. And there's only slight. And in this case, I do not use the navigation at all. By gathering many of the patient direction, either going laterally or medially, it depends upon the characteristic of the dislocation. And this is like the textbook, and actually to put the screw laterally, the safety entry point is the most medial part. So we think preoperative CT can be used for surgical planning. Vertebral artery route can be predicted, and we can evaluate insertion and screw length. And actually, the most important part is a good software to use for planning. And volumetric CT scan is very useful. The one that I used was developed in my country, and that is for to put the tooth. And the good thing is that he can show the bony man very well. And other thing to improve surgical precision, we have all tried. We have used template by homemade beforehand, 1 week before, and we have used navigation. However, I don't think it's necessary, and it's cumbersome, and the wound need to be larger. And I also tried hybrid OR by the software accompanied with the Pheno, and it's quite similar. So transarticular screw, in my mind, is a very good weapon for us, and I advocate it. However, in some cases, transarticular screw does not work. That is part of C1. This needs to be here because the angle is not suitable. And so this is need another solution. Thank you. Thank you for your attention.
Thank you very much, Professor Daming. That was an excellent talk, and specifically I can see that you have focused on Michael's transarticular screw. At the moment, we do not have any questions from the floor, I would like to ask a couple of questions. As we know, I mean, transarticular screw may not be suitable for all the cases. In fact, I think the studies show about 40 or 50% only. But also, it probably has the strongest biomechanical construct compared to all other C1, C2 fixations. But I'm just curious to know why you have chosen this as your first option when you have other options like Goels or Harms, because not many people have the experience you have with transarticular these days, I believe.
Okay. The reason, if we can do the transarticular screw safely, it saves a lot of time and it's the strongest, and it can get rid of the suboccipital pain that are usually encountered by the Gore technique, and it only needs 2 screws. Actually, 1 screw is about 5 to 10 minutes. So, and it's bloodless. It does not cause bleeding. And that is the reason that I do. And for those cases that cannot be, that can, the width of the C2 is too narrow, we can put the screw higher up or immediately. And that's, we can have a lot of success. However, if it's still not workable, actually 1 screw is enough in my mind. 1 screw, and then with SOMI, and then good bone graft, it can last for 3 months or 6 months, and it does not break. The one problem that the screw will break is external mobilization is not. I have patient is fighting or does not wear collar is not enough in my mind. It do not wear SOMI, so it will finally break. And that's my answer. Thank you.
Thank you, Prof. We have a question from Dr. Albert Wong, and this is also an important question because your topic was on posterior high cervical injury. So he asked, Prof. Dar, do you wire the C1, C2 arch to prevent fracture? So that makes it a 3-point fixation. I believe we're talking about posterior wiring techniques such as Brooks or Sontag or Gallies. I believe that is the question about. Do you use posterior cervical wiring?
Yes, I used to use that, and I use wiring, but for maybe for 5 or 10 years, I switched to mini plate. The reason is that sometimes I some cancer bone of lateral muscle ring of C1, and then I can still put bone graft on the lateral side by mini plate. Only C2 mini plate is enough because I have tried C1, C2 putting together, but actually for 3 months duration, C2 plate with bone graft with autograft is enough for all my patients. Thank you. And the wiring, I do not use it anymore because there's maybe there's still rotation or some rotation or the not twisted hard enough is one issue, so I do not use it.
Okay, so since we're talking about the transarticular, I just would like to know, so you use a handrail all the way up to the anterior cortex of C1? Or do you use...
I use electric power drill and all the way to the, but not through the C1, most anterior part. When because it's if we put it too far ahead, when the screw go to the C1, the taping will advance along with it. So I usually a little bit short, and then the self-tapping of the screw is strong enough. That is one tip. Yeah, thank you for bringing it up.
Thank you, Prof. I think that was excellent. I think that's very good for now. I think we are keeping good time. Thank you again. I think we will move on to the last speaker, Dr. Girish Nair. And if there are no other further questions, we'll move on to Dr. Girish Nair. I think Dr. Bikliang, I'll hand the floor to you. Thank you very much.
We'll move on to our last lectures in this session. I'd like to invite Professor Girish Nair from Australia. He's undergoing basic training in Kallara, further qualified as neurosurgeon in Australia, subspecialized and fellowship trained in minimal invasive spine surgery and functional neurosurgery in DBS and neuromodulations for pain. Currently, he is working as Director of Functional Neurosurgery at Royal Melbourne Hospital and Head of Neurosurgery at Western Health. I think he's very famous in his DBS work, especially world first stem cell implantations trial in humans for Parkinson's disease. Currently, he works including structuring study to look at use of AI in Parkinson's disease and modification in utilizations of neural navigation to optimize minimal invasive spine surgery. So it's our pleasure to invite Professor Girish Nair to give his lecture on today's events on acute traumatic central cord syndromes. Do we have a verdict? Professor Girish Nair, over to you.
Thank you very much for the kind introduction. And I'd like to thank Dr. Rosman and my friends, Dr. Azmin and Wan Chu for the kind invite. It's a shame that we all can't be at one venue and actually be shaking hands, but I guess we'll have to wait for that. Today, I'll be speaking about acute traumatic central cord syndrome. And all of us who deal with the trauma scenario are quite familiar that this is sort of one of those areas which is very controversial and very hard to sort of rationalize or fit into a protocol. There are many other spine conditions where you have protocols and you have templates and you can put two and two together and get an answer. But unfortunately, central cord syndrome is not one of them. We owe initial mentions of about central cord syndrome to Sir William Thornburn, who was a general surgeon and had noticed a pattern of spinal cord injury and neurological findings. But the official understanding, the way we know about it now, is something we owe to Dr. Richard Schneider. So what is central cord syndrome? Well, it is a syndrome where there is a disproportionately higher percentage of involvement of the upper limbs when compared to the lower limbs. And there might be a varying degree of bladder involvement and certainly a sensory loss that is also quite variable. The epidemiology of this is quite interesting in that it is the commonest sort of partial or incomplete spinal cord injury, and it accounts for about 9% of all the traumatic spinal cord injuries. It accounts for about 11,000 cases per year, and it is important to know, like was mentioned by one of the speakers earlier, this would probably be a counterpart of the Skivora, where there might be no structural impairment to the spinal column, but still a neurological syndrome. So it also has a bimodal age pattern, and the difference is the younger group, sort of, which is usually the under 30s. The injury is usually a high energy one, where there is no underlying pathology in the spine, whereas in the older group, it is usually a low velocity injury, and the common cause being simple falls. But the underlying problem is the hyperextension. It is quite a different entity to the other incomplete spinal cord injuries. This picture that I put up is actually from the initial article from Schneider. And you'll see down the line that why this is so impressive, that he has drawn the bulging ligamentum flavum as being one of the causes for the spinal cord syndrome. And you will see in my later slides as to how visionary this was. So we know that the spinal cord is a tightly packed bundle of fibers, which has all the gray matter, as well as the tightly packed white matter tracts, which are ascending and descending. And depending on where the injury to the spinal cord is and what the underlying cause is, we have quite a few types, which is the common ones are the anterior cord syndrome, the Brown-Séquard syndrome, and the central cord syndrome. The posterior cord syndrome is quite rare. So in the central cord, you will see that in addition to the gray matter, when we talk about the part which affects or is affected in the central cord syndrome, it is mainly the lateral sort of corticospinal tract and the lateral spinothalamic tract in addition to the central gray matter. And this then leads to the disproportionate affliction onto the arms and the trunk, and of course a variable sensory and bowel and bladder impairment. It is an extreme hyperextension injury. And as you can see that it is sort of results in impingement onto the cord, resulting in this syndrome. There is an anteroposterior sort of pincer-like effect on the cord. And in the older population, this is generally in the setting of a pre-existing narrowing, which might be a result of a disc prolapse. It might be from OPLL or osteophytes or from ligamentum flavum hypertrophy. The impact of this injury is usually centered around the C4, 5, and 6, because that is where you have the maximum lordosis, and hence you get more of the buckling of the ligamentum coming in. So as I mentioned above, maximal central compression, and usually it is a spectrum. So it is not like a certain degree of impairment is seen consistently. It is usually varying degrees of motor and sensory impairment, usually reflecting the underlying severity of injury. So in Schneider's initial account, and the way this name came to be, and also our understanding, it was that the injury is all centered around the middle, and like I showed in the images before, affecting the spinothalamic and the lateral corticospinal tract. But this was based on the assumption that the motor tracts are configured or have a somatotopic representation of the upper limbs and lower limbs, like we see in the gracile and cuneatus fasciculus. However, later studies, we are now aware that in the lateral funiculi, the fibers for the upper limb and lower limb are not quite well demarcated, and it is more a diffuse distribution. And later studies correlating the MRI scan appearances and also pathological studies, especially highlighted in this paper by Quinza, shows that it is not so much the central gray matter, it is more a diffuse sort of involvement of the lateral columns of the white matter, and hence probably the central cord syndrome might itself be a misnomer, but it is still in use. So this is a very interesting paper because there has always been a little bit of question about the underlying biomechanics which leads to the central cord syndrome. In this paper, they had 4 scenarios. One where there is a normal disc, second one there is only a disc, and third one where there is only a hypertrophied flavum, and a fourth one where there is both the disc bulge and the hypertrophic flavum. And they subjected in this study to varying degrees of extension, and then analyzed as to where most of the cord compression came and how much that correlated with what we understand as central cord syndrome. And the conclusion of this study, and as you can see, this is a fairly recent study, 2020, It has taken us all these years to confirm what Schneider drew in his picture in 1954, which is that the hypertrophied ligamentum flavum is the main contributing factor to the peak stress and strain, which then affects the columns that then manifest as a central cord syndrome. Pretty amazing, isn't it? So initial management, it is a standard management of trauma, and the resuscitation is as per standard trauma protocols. But of course, in every spinal injury, immobilization is key, and the importance of this is to prevent secondary injury. Management of hemodynamics is important, and there was a lot of controversy, but the current recommendation is that there should be an attempt to maintain the mean arterial pressure between 85 to 90 for the first 5 to 7 days post-injury. And this is sort of to prevent the secondary free radical type injury, and also to increase the vascular supply in the region, so that the penumbra of the cord is not affected, or rather the spread does not go wider. We mentioned in one of the earlier talks about the role of methylprednisolone. There were main 2 trials which looked into this, but the consensus at the moment, at least in the setting of a central cord syndrome, is that there is no recommendation or indication for the role of methylprednisolone in the management of central cord syndrome. This is because those studies which were unfortunately not well constructed or interpreted, and the subgroup analysis also showed not only that there was not much of an improvement in the medium to long term, but they also caused a significant adverse outcome with regards to significantly higher infection rates, etc. There is certainly a lot of work going on at the moment to look at the use of newer agents, and these are sort of agents that try to minimize injury due to secondary causes such as free radical injury, and there is investigations into looking into the role of colony stimulating factors, the impact of using techniques such as hypothermia and hyperbaric oxygen. But that is all still work in progress. So after the initial resuscitation, patients and immobilization, patients have to be assessed as per the ASIA scoring, where, as you can see, from ASIA D on ASIA B onwards, you have sort of a fairly severe injury, and generally most papers that will sort of comment on strategies to look at offering different managements, ASIA C and above. So this is sort of a classical picture you would see in the setting of central cord syndrome. The reason why I put this up, and this was published in the New England neurosurgery clinics, is to highlight that this entity can happen even in the setting of a significant disc bulge or a ligamentous hypertrophy. You can see that on the sagittal sequences, there is no large disc bulge, there is no big ligamentous hypertrophy, but there's already a cord signal change. And the importance of this is that the presence of cord signal change, not just the presence, but the extent, does have some prognostic value in predicting the outcome. So the big question, though, which haunts all trauma surgeons and spine surgeons, is how to manage this. If you go back into history till sort of many years ago, it was a clear, everyone following what was quoted in Schneider's recommendation, which was that this has a path to self-resolution. The results of intervention are generally poor, and hence the management should be conservative unless there is an associated instability. Now, then we have to take a step backwards and to consider as to what was the management of these type of conditions in the time when this was initially described. So when you look into that in a bit more detail, the practice of surgery and the techniques used at that time are significantly different to what we do now. So previously it used to, even for a decompression, it would involve sort of significant handling of the spinal cord, And in the initial papers, there is a description of performing myelotomies to achieve decompression. We certainly don't do any of that now, and hence we probably have to take a step back and look at all of that. There might be subsets where there might be a strong argument to intervene. But then comes the next question as to when do you intervene? Do you intervene early, and does that give us better results in terms of medium to long-term outcome? Or is it better to manage the initial period, say for 4 to 7 days or up to 2 weeks, so that there is maximal self-improvement? And at that point, if there is still a role for intervention due to, say, progressive worsening or presence of a compressive pathology, do you intervene then? So it's a question about do you, and if you do, when do you intervene? And there are innumerable papers over time. So I sort of found this table, which was published in this article by Nivi et al., quite interesting. So like I mentioned before, I think the sort of part that is up here is probably not that useful for us to look in terms of recommendation, because this is the part where it reflects our practice at the moment. And if you look through this, it is a fairly heterogeneous group wherein patients with instability have been put in together in patients who do not have any instability. There is no question about surgical management or not when there is instability. The indication is there because you have to stabilize the spine. But overall, unfortunately, despite many publications, there is no clear consensus as to whether surgery is indicated or not. People have tried to identify subsets that are, but if you look at sort of even the largest group here, which is from this paper here, it says that there is no benefit for surgery in the absence of instability, and that patients who are younger than 18 have an improved outcome. So say you have a subset where you have to intervene. When do you intervene? And people have looked at this various options. Do you intervene in less than 24? Do you intervene within 24 to 48 hours? Or do you wait for longer, say 4 days and above? And if you look at these papers, say, for example, Lenehan's paper, which was a systematic review, it says that it compares sort of the intervention 24 hours and after. And even there, it comes to saying it is reasonable and that it is safe to intervene in patients who have a profound neurological deficit, that is AASC and worse, in the presence of compression. Feelings paper, unfortunately, was sort of a mixed cohort. So there was not a lot of information that could come from that. And there was also a subsequent systematic review, but the quality of evidence that was put forward did not lend itself for us to make any interpretations from that. So after all of this, where we stand now in terms of the questions that were asked, this is where it looks like in terms of level of evidence. Surgery is favored when there is spinal column instability or if there is persistent spinal compression in patients who do not progress to improvement. So in patients who present with a certain level of neurological deficit and there is no compressive pathology, at the moment, we do not have enough evidence to say that, well, you should go and operate on them. Methylprednisolone, unfortunately, is not recommended anymore in the treatment of central cord syndrome. In patients that, with regards to intervention, well, there is no clear evidence at this point to show that early surgery translates into better outcome. There are papers out there that have looked at subsets, and there seems to be, say, a patient who has sort of fluctuating neurology in the presence of a young patient who's otherwise fit and well without medical comorbidities. There might be a role to intervene in terms of shortening hospital stay and prevention of other complications, not specifically to treat the neurological deficit. And even in those papers, when you look at 12 to 24-month outcome, there is no difference between the operated and the non-operated subsets. This is from the spine trauma study group. And it's actually a very good paper to look into in my colleagues or amongst yourselves who want to get a sort of a comprehensive view on where the literature stands. And what I'd like to highlight is that despite looking into all the literature that is currently available, this paper concludes by saying that until the time that there is a clear decision that is available, which we do not have at the moment, the decision making to intervene and when to intervene is now left to the judgment of the physician, and taking into account the pros and cons of intervention and also involving a well-informed patient. That doesn't really help us much. And as you can see, so many years since the initial description of the central cord syndrome, we haven't really gone much further in terms of decision making. What further is being done? Well, to look into this, there were randomized controlled trials designed. One was the COSMIC trial and the other is the AASNS trial. Unfortunately, the COSMIC trial had to come to a stop because of the lack of numbers for recruitment. The AASNS trial, which is based in Japan, multi-center trial, I think the recruitment stopped in December 2020, so they've completed recruitment, but I could not find any data or publications talking about what the outcome is. So that is something that I think all of us would be quite interested to know. This is an interesting paper because generally, you know how we talk, when we talk about central cord syndrome, the conversation is always about these things normally improve by themselves. And over time, you know, spinal cord injuries do tend to get better in the absence of instability. But this paper compares two different subsets of spinal cord injury, with and without central cord syndrome. And it was interesting to note that patients who have central cord syndrome related spinal damage have poor self-care ability. There are these prognostic factors. Age and presence of comorbidities is one. Poor motor score at the start is a poor prognostic factor. Presence of cord signal change and the length is, of course, unfortunately, a poor prognostic factor. And absence of spasticity is a good prognostic factor. So in summary, I'd say that it is a unique clinical syndrome, very diverse presentation. We have a better understanding now of the underlying cause of the problem, but unfortunately, the jury is still out with regards to decision making. The guidelines and treatment options are evolving, and until that time, it is for the clinician to take the best decision which they think is in interest of the patient. Thank you for your attention.
Thank you very much, Dr. Nair. That was excellent. I think it was a very suitable talk. It's one of those controversies and equipoise that exist in spinal surgery, central cord syndrome being the most common incomplete spinal cord injury. At the moment, there are no questions from the participants. In that case, I would like to...
There is a question on dexamethasone, Ravindra.
So the question is, do you use DEXA in central cord syndrome? I think you've answered the question, or what is your opinion about use of steroids in central cord syndrome?
I think, you know, as treating surgeons and clinicians, I think we sort of sometimes desperate to do something for the patient. And in our desperation, you know, we know that steroids do reduce edema, and we think that they provide some amount of membrane stabilization, which in turn hopefully prevents the secondary injury and the free radical based injury. That was the foundation of use of steroids. But studies have been done, and as I mentioned before, high dose miltefosine, prednisolone and steroids really don't contribute to any improvement. So no, there is not much of a role for that.
Thank you. I think you mentioned about stasis that highlights the an unexpected finding where Dr. Fillings concluded one of the best outcomes are for this group. But I think you also mentioned that the decision will largely depend on stability and also if there is continuous compression. Could we conclude that these are the important factors in deciding surgery for central cord syndrome?
So the way things stand at the moment, with sort of the literature that we have at the moment, where it stands and where I think it is rational, is that in the presence of instability or a structural damage to the spine or a compressive pathology contributing to a spinal cord compression, surgery is valid. And in that setting, early surgery is indicated. The controversy is all in the domain of when there is no structural damage and, like, say, for example, the scan that I just put up, where there is no large disc prolapse, there is no large ligamentum flavum hypertrophy. What do you do then? And in that spectrum, at the moment, there is no strong evidence. So in my practice, what I do is, if I have a patient who, say, has a borderline canal stenosis, has sort of a fluctuating neurology, and is otherwise quite fit and well, and is not making progress, for me, then it is a discussion with the patient. And I have an open discussion and say that, look, I'm not sure if this is going to make you better. It is quite likely that it can give you some improvement to a level where it'll shorten your hospital stay. It'll help me get you to rehab quicker, and it'll help me sort of have the confidence to start you on blood thinners, DVT prophylaxis, and all of that. And then, then it sort of, that discussion leads to what the treatment plan is. But as such, I don't operate unless there is a compressive element to be decompressed.
So is it fair to say that the management is still conservative unless there is a instability or continuous compression?
I think that is what the conclusion is, unless, of course, you're making that statement in the presence of feelings in the audience, then you're in trouble.
Okay, thank you very much, Prof. Dr. Nair. I think we have one more question. I would like to invite all 4 speakers to come on video. And I think there's one more question from Dr. Go from Sarawak. If Prof. Darming Lai is available, the question is, would you combine a wiring technique if one transarticular screw is inserted instead of 2? Dr. Prof. Darming Lai, are you here? Okay, we don't have Dr. Darming Lai. Any other questions from the floor?
I can take that if you want.
Yes, please.
So generally, you want to put 2 transarticular screws, because if you put one, you will sort of get some amount of rotatory malalignment, and you don't want that. But otherwise, if you are in a position where you sort of cannot put 2 screws in purely because of anatomical factors, then you should consider decorticating the interlaminar space and sort of putting some bone graft and wiring. In situations where, and Darming was mentioning about not using wiring now, what I do is I don't use the wires either, but I normally put a wedge of bone graft, and you can actually steal some of these mini plates that our maxillofacial colleagues use. And you can put a bone graft and fix it between the lamina using those mini plates that the maxillofacial surgeons use. It's pretty robust, and it'll hold your bone graft between the corticated laminar edges, and it fuses quite well.
Thank you. And I may want to ask the last question to Professor Bajamal. Prof, you did mention about thoracolumbar junctional fractures. I noticed, do you follow the 2 level up, 2 level down general rule for junctional thoracolumbar fractures? Because some of your construct was single level above and single level below. And the other question is, from the classical Dennis type classification in fractures and seatbelt type chance fractures, now we've moved into a more objective classification such as AO classification. Has that translated to a different way of understanding and management in your practice? Because I'm sure you have seen your career would have spanned across these 2 eras, pre-AO and AO.
Thank you, Dr. Ravindran. This is an important question. So, I already told you that the important thing is the anterovertebral height. This is the most important one. So we have to make a good CT scan to predict the possibility of the good growing of the anterior. And then how much is the anterior height, the crease, this is the first one. And the second is the most important, that short segment fixation is in a burst fracture is usually fail in the long term, usually after 12 months. So you have to think that in a burst fracture, don't use a short segment screw. That is what I can answer your question.
And the one on AO?
What do you mean with the AO?
I mean, we are using AO classification more and more, and from classical, in the past we were using more conventional 3-column injury and seatbelt type injury and chance fractures. Has adopting this new classification translated to a different practice?
Yeah, I always think this variable, the AO classification, McCormick classification, I have to combine that and using the result of the imaging of CT scan. Then the McCormick classification, we have to see the point and combine with the EO, and then discuss how we treat this patient, with short segment, long segment, or combined with cementoplasty or not. We use different kind of classification.
Thank you very much. May I invite all the speakers? I think we have Prof. Darming Lai and Dr. Nair. Is Mr. Albert available? Mr. Albert, is that okay? Okay, we're just going to take our traditional group selfie to mark attendance. Mr. Azmi, on to you, please.
Okay, we have, I think, Nadia or Nazrin. Okay.
Yes, we are ready. We will now have a quick photo session. I would like to invite the moderators, speakers, and panelists. Please switch on your video.
And the rest can join too.
It'll be on my count, 1, 2, 3. Okay, 1, 2, 3.
Is that done?
Yes.
I cannot thank enough all the speakers for your excellent contribution and talks. I think that made a lot of difference to our spine section. I hand it over to the organizer, Mr. Azmi and team. Thank you very much. And thank you, Dr. Lau Bik Liang as well.
Thank you.
Thank you.
Thank you, Dr. Ravi and Dr. Lau. Let us now move on to the third session on neurotrauma and rehabilitation. We have as our moderators for this session, Dr. Lai Chuang Chi and Dr. Nelson Yap Kok Ling. Dr. Lai and Dr. Nelson, the floor is yours.
Okay, good morning to all the participants. Now we move on to session 3, which is our neurotrauma and rehabilitation sessions. I would like to introduce our first speaker, which is our renowned professor, Professor Virendra Dao Singha from India. Professor Virendra is a senior professor in Department of Neurosurgery, SMS Medical College, Jaipur in India. He is also a chairman of WFNS Neuro Rehabilitation and Reconstruction Neurosurgery Committee. He is also a chairman in AASNS Neurotrauma Committee, members of WFNS Neurotrauma Committee, executive member in AASNS, and corresponding member of EMN. He was an ex-president in National Skull-Base Society of India and was ex-president in Neurotrauma Society of India. Today, Professor is going to deliver on 2 topics. First is the prognostic factor in cranial cerebral penetrating injuries, And second topic will be dilemmas and consensus for post-traumatic cranioplasty using 3D printers and polymetal metal acrylic implants. Without further ado, I would like to pass the mic to Professor Videndra.
Prof, we can't hear you.
Professor?
Prof Sinha, we can't hear you. Can you test your mic?
Professor?
We can't hear you.
Hello, Professor. We can't really hear.
Okay, I will start from my other.
Okay, now better.
Now we
Now
can
we can hear you.
Okay. Now can you hear me?
Yes, clear.
It's okay. Okay, now I share my presentation. Sorry for.
No worries. Take your time.
Yeah. Just a minute. Can you hear me?
Yes, Professor. We can hear
Okay. First, thanks to Dr. Azmi for hosting this excellent meeting. So my topic of presentation is prognostic factor in craniocerebral penetrating injuries. We know that penetrating injuries are so common in warfare, and gunshot penetrating injury, they are very common in wartime and developed countries. While low velocity penetrating injuries, they are more common in developing and underdeveloped countries. In other words, most of the underdeveloped countries and developing countries, we see such type of penetrating injuries. And I am residing in a state where we have a lot of sand dunes. So people use this type of weapons for assault or interpersonal assault. And sometimes the patient comes with this instrument in situ. So the penetrating injuries are very responsible for significant number of the morbidity and mortality, and it is increasing day by day. So it is very important to know this in detail. I think a lot of juniors are here, so I have covered slightly the basics of penetrating injury as well, and we must know about the pathophysiology as well before we understand the management. So cause of penetrating head injury can be by all the sharp objects like nail, stick, pencils, and in urban conflicts and terrorism, gunshot, industrial blast, they are all causes of the common penetrating injuries. Type of penetrating injuries can be low velocity and high velocity. Low velocity fall or hitting head against the sharp object, assault by sharp weapon, and high velocity usually because of the gunshot or missile injuries. As far as this destruction of the brain by the penetrating injury, the velocity is a very critical factor. In low velocity, usually the injury is less than 2,500 feet per second, while in high velocity they are supersonic, where there is a more than 300, and in subsonic there is a more than 300 in this injury. So low velocity injury, there is an absence of significant impact force, so usually patient has very good result. While in high velocity injury, there is a cavitation and shock waves are there. So usually there is a more damage to cerebral and poor outcome. If we see the pathophysiology, it is a primary impact or secondary impact. Primary impact is because of direct injury by penetrating object, and here we see three types of waves. Primary wave, that is because of direct crush injury by projectile resulting in a permanent cylindrical cavity. While secondary waves cause because of the stress injury to the brain, and there is cyclical radial expansion and contraction, which can lead to the temporary cavitation. And during this, there can be negative pressure up to the 4 atmospheric that withdraw the surface material and responsible for the infections. Tertiary wave, they are very severe waves and pressure goes up to the 100 atmospheric pressure. But because of brevity of these waves is only for 2 microseconds. So there is no much damage by these waves. Primary impact injury is very important, which cause lot of cerebrovascular injury, either a direct or by indirect means. Just is a demonstration by picture. This is a penetrating, this is a permanent cavity, and this is the temporary cavity, which cause more destruction. Second impact we know can cause raised ICP, cerebral edema, which start in 6 hours, goes maximum in 48 hours, and persist up to the 7 days. Cardiopulmonary changes because of the rostropodal migration or pressure difference across the foramen magnum cause immediate death. This is just a small video. This is loss, absence of shearing forces, so less deleterious effect over the brain in low velocity we generally see. In high velocity or bullet injuries, we can have a high velocity or low velocity injury. In high velocity, there is a entry and exit wound, and because of this, there is a great pressure difference across the tendon and foramen magnum, and patient can cause immediate death. While in low velocity bullet injury, it is gradual, but there are loss of a lot of harmful effect over the brain in form of hemorrhage and cavitation and all, but the results are comparatively better than high velocity bullet injuries. This is just a video diagram. How this is hemorrhage, recoil of the bullet, and causing the this harmful effect over the brain. Coagulopathies are very important because there is systemic change in coagulation because of the brain thromboplastin. Is a cause platelet number and aggregate decreases, which start in 2 hours and persist for 6 hours. And in a study, it has been seen that 71% of survival and 94% of non-survival have some form of the coagulation impairment. Now we come to the prognostic factor. Prognostic factor can be general and they can be specific. Specific factors, weapon related and radiological factors are there. General factor we all understand, as usual in other trauma cases. Age is a very important factor. GCS, C25 associated with the poor prognosis, hypotension or admission, this is very important, and oxygen level or airway at the time of admission. Then pupillary coagulopathy, I already mentioned. High ICP, which start within 2 to 3 hours and associated with the poor prognosis. Major vascular injury, as I told, because of the primary wave, which is very important and responsible for the vascular injury, cause pseudoaneurysm, and other vascular injury cause poor outcome. Now here I want to just tell that multilobar, this is multilobar involvement, and in this eloquent area, which is associated poor GCS and poor outcome of the patient. We see, we observe that when there is a penetrating injury, patient usually fall. So because of fall, there can be associated injury, most commonly spine, but patient can chest and abdomen injury, which sign of the poor prognosis. Suicidal attempt because of the close proximity of the entry wound, there is a poor prognosis seen. Other general factors are this improper dural closure, wound descent, CSF leak, or any penetration to the air sinuses can cause the poor outcome. Or the retained palate, which can cause infection later on, is usually have a poor prognostic signs. Other general prognostic factor, seizure. Seizure, in 50% of cases we see in the penetrating injury, but so we must start anti-epileptic drug in all penetrating injury. We must continue for some time, but delayed this or prolonged use of this anti-epileptic is not very much documented. Delayed and effective resuscitation is important because it can cause poor prognosis. In children, the recovery is usually better compared to adult. And any patient reaching before 6 hours, there is no exit wound, they usually have good outcome. Ballistic is very important. You know, there is an internal ballistic, external ballistic, and most important is wound ballistic, because missile with greater yaw. Yaw means when a bullet or an object out from the this gun, there is a yaw, rotation along the long axis. That is very important factor for fragmentation and deformation of the brain. So that's why the close injury, they have a poor outcome. Velocity is not only the one critical factor which I mentioned before, but because of the yaw, deformation, fragmentation, and overall kinetic energy are the major determinant for type of wound or injury. Trajectory is another important factor, weapon related. Projectile passing through eloquent area have poor prognosis, I mentioned before. Trajectory passing through the skull in temporal bone, sinuses have more grave injury and complications. Strikes as 90-degree cause maximum injury. Sometimes we see the tangential wound or gutter wound, where the striking object is just reflected. So there is an injury over the dura or superficial brain, but the outcome is usually better because transmission of energy to the brain is less. Sometimes we see or notice the unexploded missiles. Their removal is very necessary because they can cause toxicity or delayed detonation can be seen. Then migratory projectile. It can be seen in ventricle system, ventricles, or it can stay in the brain and cause necrotic changes, pus or hematoma, and after some time, because of its pressure, it dissects the white matter and migrate to the other side or different side. It can cause hydrocephalus and abscess formation, which we see in this type of injuries. This is the weapon related factor. This is the pellet is on the left side. Then after some time, it was migrated to the right side and patient developed hydrocephalus. We did the V-patient in this patient. Weapon impacted or not. Weapon impacted should not be removed at the site of the scene, because when we remove it is the in zigzag fashion, it only should be removed in the operation theater, which is very safe and should be removed in the same direction of trajectory where it has entered. Radiological factor, we all understand, as in other trauma, bihemispheric, multi-lobar dominant hemisphere, ventricular injury with hemorrhage, compressed or obliterated cisterns. Radiological factor, other are ICH, SCH, all they are associated cause poor outcome. Vascular injury, as I mentioned, in form of pseudoaneurysm or other vascular injury, have a poor outcome. But if patient or penetrating injury is not ciliary fissure or eloquent area, or there is a, then usually the outcome is better. If there is a penetration of the this object laterally, it is more harmful compared to anterolateral. So the outcome is better with the anterolateral penetration. Sometimes we see trim track sign if there is a hypodense in the center surrounded by the hyperdense. So this, if there is a trim track sign is there, the sign of the poor outcome. Few factors I want to tell finally, that size, shape and depth of penetration is very important, and assailant, if remove the weapon or object at the site of injury, usually have poor outcome. Then vascular injury we see in 30% of cases with 17% mortality. The vascular injury through the transorbital is usually 50%, and mortality is also very high, 30%. And usually we see these injuries more common in children because of the fragile orbit. This is a pseudoaneurysm. Now I want to share few of my patients. This patient was assaulted by battle axe. See, there's a this wooden part. This is wooden part. It is X inside, and we couldn't do the CT scan because of the long handle of the wood. And this is the X-ray was done. This is showing the this is AP anteroposterior injury. This we are removing. This wooden part we holding with the hand so it doesn't fall suddenly. And this is after surgery. Patient has mild weakness, is a gliosis, and now patient married and with 2 children. This is another patient of injury by the assault X. And as I told, this low velocity penetrating injury has better outcome because there is absence of this injury, much injury over the brain. This is a assault by the sickle, and this is an injury over the cortical injury, patient after surgery. This sometimes self-inflicted penetrating injuries are very much seen, especially in some psychiatric disorder. And here we can see the suicide by seizure. He hammered this seizure over vertex. And CT scan was done, scanogram showing the superior sagittal sinus injury. Seizure was removed. This is after surgery, and we could stop the bleeding with the usual manners. Sometimes weapon seen in children, which is uncommon, but we usually see. This is a assault by caliper in the school. It was not showing any vascular injury, so we just remove it. Sometimes conservative approach can be used. So this child fall over the metal strip, so all nails they went inside. We had a serial scans, and patient was discharged without any surgery. Injury by metal fragment we see, so they are removed operatively, and they are usually low velocity, so patient has good outcome. Injury by a wood piece is very important because if you go for CT scan, they just give a air bubble appearance. So if we suspect a injury by wood, we must go for MRI scan, and that will delineate the foreign body. So here this was wood, and it was removed, and this is after surgery, and patient improved. Then we usually see commonly in the this type of fall of a stone. It's a stone here, is fall and removed. This is another case where a stone was there, removed, and patient improved. Now we come to the high velocity penetrating injury. The outcome of high velocity penetrating injury was very poor, but when patient mentioned or improved by using the wound dusted with sulfur powder, rapid evacuation, food anesthesia, antibiotic, and very important, plastic surgery principle to scalp and dural closure, no CSFD, and radical debridement. This improved the mortality from 54 to 28%. So this is a case where there is a bullet inside, but patient was not having any neurological deficit or problem, so we just treat conservatively. This is another problem we see commonly, retained splinter. So management is observed, treat meningitis if there, shunt hydrocephalus, as I mentioned in my previous case, patient are hydrocephalus, so we shunted the patient, and there is CSF leak, we have to treat CSF leak. Now I want to show or share another interesting case where pellets were seen in both the orbit. Patient was assaulted by this pellet, and when we did the lateral view of his skull, it was 1. It shows identical impaction of this pellet at the same site. Patient was not having any vision, so it was treated conservatively. Now I want to show vascular injury. This girl was fall, and the handle of this cycle penetrated through the left orbit. After 2 days, this patient came to us, unconsciousness state and deterioration of the neurological level, and patient before that was having severe headache and vomiting. We did the CT scan and found this bone spicule and hematoma. So we suspected it may be the vascular injury. So this is the vascular injury we see here. This is the aneurysm, pseudoaneurysm here, and which can be seen in the angiography. And this is a bone spicule. See, this is a bone spicule, very nicely related with this aneurysm, and we consulted with our intervention people about the management. Should go with intervention, neurological surgical intervention, or surgery. So we decided to operate this patient by surgery because this is the bony free fragment which can get infected later on. So surgery was the option. So this is our video. I want to share this. This is the artery, and this is the bone spicule here. So we could find the aneurysm here with bone spicule, and but while we were manipulating, the aneurysm dislodged and there was bleeding. There was a hole in the artery. We tried to coagulate it, but we couldn't do it. So we applied a clip, and hemostasis was there, and the hole was closed. So this is bone spicule. This is a pseudoaneurysm part which was dislodged during surgery, and this is after angiogram patient surgery, showing clip in position and good distal circulation, and patient improved and discharged on 7th day. So just to close, closing remark, I want to tell the penetrating injuries are increasing every day because of the change in the systems or social habits. Everybody want to violence, and there are a lot of problems nowadays, even in developing countries, and we must understand these, and we must manage them timely. Nowadays, after the this Afghan, Iran, and Israel war, it has been proved that radical debridement is not very important. Conservative debridement of the brain gives us good results. So radical debridement should not be done. Thank you very much for listening.
Thank you, Prof. It's a very nice, very wonderful collections of series of penetrating head injury, which is very rarely seen here. Since we are running short of time, is there any question we can put to the last at the question and answer session? So then our next topic by Professor Virendra will be the dilemmas and consensus for post-traumatic cranioplasty. Okay, Prof.
Okay, can you hear me?
Yes, yes, Prof. We can hear you.
Good. So again, thanks. And my next topic is dilemmas and concerns for the post-traumatic cranioplasty. And we use 3D technique and PAMA for cranioplasty. We know that the cranioplasty or bone defect repair is not a new surgery. It has been used in 1565 by Petronius using gold plates, and number of bones were used. And even in 1890 outer table of the skull was used to repair bone defect. Then after the era of metal came, there aluminum, platinum and titanium was there. Even the methyl acrylate, which we do nowadays, was used first time in 1940. The causes of the cranial defect, we all know. Trauma, decompensated craniotomy, which is very common nowadays because of increased RTA, infection, craniocerebral reconstruction, neoplasm, and congenital deformities. Then other indications: aesthetic, protective, and discomfort. Protective for seizure disorder, sports and army personnel, syndrome of shrunken skin flap. As per the Grant and Norcross, severe headache, epilepsy, danger of trauma, and cosmetic, they are the indications. We all know the syndrome of Trefine was first coined by Yamura and Mikano in 1977, where after decompensated craniotomy, we see such type of picture. Because of this, there's a mental derangement or function derangement, hemiparesis, and generally they can be recovered with this cranioplasty. So we don't do, if there's a less than 2 centimeter over convexity or below the occipital or temporal muscle, we don't do the cranioplasty, and children less than 6 years. A contraindication, we all understand: infection, immunocompromised state, hydrocephalus, this associated with the sinus continuity and comorbidities. After the Brain Trauma Foundation guideline, we have seen there's a marked improvement in the head injury patient after DC. But till now, there's no guidelines for post-traumatic cranioplasty about the timing, material, and complication. So in Naples, ICRAN was held, and Dr. Corredo managed a meeting where the consensus were made and published in this journal of the, and now I think it will help for the management of these patients. As for the timing of reconstruction, it all depends on individual patient. Previously, it was assumed that if we do late cranioplasty, would do better result, but nowadays the early is better for recovery and less hospital stay. Time of cranioplasty in our institute, 2 to 6 months after compound wound, 1 year after wound infection, 3 months with autograft, and as per age materially used, and in benign tumor we use in the same sitting. Then cranioplasty can be done by the autologous and alloplastic material. You know, autologous is difficult for precision and durability, but definitely the osseous integration, growth factor, donor side morbidity, and cost is very favoring. While in alloplastic, these two factors, precision and durability, is very good, but all these factors, they have a poor values. As for the material, autologous, in adult, we can use the split cranial bone graft, rib, iliac crest, and tibia. And for vascularized flap, if you want to use the flap, you can use the rib, iliac crest, or scapula. But in pediatric cases, the rib may cause the deformities, iliac crest growth disturbances, and it is very challenging to use vascular flap in the children. Children, we know that because of the unique physiology, developing anatomy, and dynamic growth, should not be done less than 6 years. And what is the best? It is the autogenous cranial bone graft, which is gold standard, and exchange cranioplasty because of the high osteogenic potential. We should not use the alloplastic material before 8 hours because it can be dislodged and growth retardation. So many problems in the children. As far as the preservation of these flaps is concerned, the color preservation is very commonly used in US, but it is require bone storage system, transfer of the and lot of logistics they are there, but in low income countries, developing countries, it is not possible. Other different method, freezing method, radiation, but autoclaving was done when I was studying or getting my training, but is usually called devitalization of the fragment. So we should not do the autoclaving. So main problem of storage is high resorption rate, which is seen 50% in children and 6.5 in adults. Subcutaneous storage, give good place because nourishing osteophytes are there, good environment, but it causes bone resorption and infection. And in children, there is no enough space, and in adults also it causes a lot of comfort, extrusion, bone descent, and second morbidity of the surgical site is there. So when we generally keep in wound this bone flap in the abdomen, but resorption, as I mentioned, is a very great problem. So it was when chloroplasty 1, there was a lot of space there. We can see the defect here, which is a very big problem. So there is no statistical difference seen in outcome in the storage method. The other methods of the chloroplasty, exchange chloroplasty method, which is highly effective, but it's difficult in children. It gives good outcome. The vascularized flap, which we can use the rib, latissimus dorsi, scapulon, and iliac crest. And indication, if there is a patient exposed to radiation, infection, or there is a lot of scar tissue, and sometimes we can use the 2-BMP2, which we don't use. Literature says helps in the osteogenesis. Hydroxyapatite is very good material, available in limited amount at oviate donor side morbidity. Its clinical composition or chemical composition is almost equal to the bone, and potential for post-fracture cell repair is there, and osseointegration is 60 to 80%, and it should be avoided near the paranasal sinuses. There is no harmful effect, but delayed immune mediated inflammatory reactions can be seen. Then carbonated calcium phosphate paste, CCPP, is had more strength than hydroxyapatite, but problem is because of dual pulsation, it interferes with the crystallization, so microfragmentation of material is seen, and it bind very tightly. So when we want to remove, it is very difficult task. Titanium, we all know that because the CAD and CAM system nowadays has given the very good result, but the disadvantage, heat conduction, radio opacity. Advantage is a good mechanical strength, infection is less, and biocompatibility is good, and especially in children, we can use it very nicely. Plastic peak material, disadvantage, seizure, post-operative implant exposure, increased seroma formation. Advantage, not osteoconductive, and elastic and energy option is almost to the bone. But these pores can be, soft tissue can grow, so sometimes when you want to remove, it's very difficult to remove it. Then this is now what is the ideal implant? We studied the literature and we found that it should be malleable, easily sterilized, light-weighted. These all things should be the repeat for the implant, but no such material currently exists in the literature. So we review, and we again found that there's no ideal implant. So we started doing customized kinoplasty PAMA using 3D technique, and here the customized kinoplasty PAMA implant using 3D printer may be useful technique for reconstructions of various cranial defect, where prefabricated implant has advantage to prevent this potential of PAMA, which we see during the surgery. why we use the PAMA? Because inert, minimal reaction, tight adherence, MRA compatible, can be prepared operatively, and good strength. The customized 3D cranoplasty advantage, cost advantage, greater aesthetic results, reduce operating time, and good biocompatibility. And disadvantage of PAMA, all these exothermia and monomer absorption during the dural vessel may cause hypotension, CV cholesterol death. This is not there because of the 3D technique. It can be used for unilateral and bilateral both. So when we do the bilateral DC, we usually save this CT scan relatively for the cranoplasty. Aim of prefabricated implant, steady implant surgery with greater possibility of achieving expected result. Both the aesthetic and functional outcome of implant considered to the patient, and because of low cost, we can do for more number of the patient. And it definitely decrease surgical time and reduce possibility of error during surgery, and we can do the counseling with the patient before surgery with showing the implant. So we are doing this technique, and we have published our lot of our patients' results, and all the DICOM images, they are converted to STL format, and we make the model of ABS and PLA. So this is the implant, this is the model. So when we were preparing this mode during surgery, there was a lot of irregularities and the approximations were not good. So it was not good. It's not good to prepare during surgery. So we are started doing the 3D technique. The most important is raising of this temporal flap, because otherwise there will be hollow in the temporal region. This is our mold. This is our implant. We refreshing the edges, and this is the final implant we have prepared and fixed. This is the pre and post of very good results. So just I want to share this small video. Patient was operated for decubitus connectomy, and this is our model, and this is the implant we are preparing. So generally it get stick to the model. So we either put saline or bone wax, so it doesn't stick, can be separated easily. This is finally prepared, refreshed, fixed on the patient. So this is another patient, small video showing there's a large defect because of the DC. See, there's a large defect. This is prepared implant, fixed, very good approximation, very regular surface, smooth surface, good approximation, very good cosmetic outcome of the patient. This is another patient, large defect, very nicely cranoplasty done. See pre and post of very good cosmetic outcome of the patient. Now, for better approximation, we have cranial defect prints out and give better approximation. But nowadays we don't prepare this implant in theater. It comes from the company. So we again reduce our surgical time. So it is very good for even difficult situation like frontal region, very good cosmetic value. And even in children, see after 2 years, this patient, no problem. So every technique has complication also, infection, granuloma, erosion of the skin. They are the usual problems, and dead space morbidity, complication like migration, you must fix, and if there is a hematoma, if there is more, you must explore and evacuate if it is large. And so we have done about 60 cases. This is a very small video. I want to show pre and post of. Pre and post, even in a very aged person, we can do it. In children. So just I want to conclude that it is a very precise compliance of processes to OCS defect was achieved. And in 2-year follow-up, we have very good aesthetic and significant results and very satisfactory result. And cost is $300 US, including the implant and everything. And titanium we use for the adults who can afford. And generally we have infection rate 0 because we use first case by senior surgeon, less surgery duration, appropriate period between connectomy and cranioplasty, and it is very economical. Thank you very much.
Okay, thank you, Prof, for the wonderful and very comprehensive lectures on the both topics. So I see the chat question and answer box there. There's actually a burning question from the participants. So this is a question from Dr. Turgai. So the question sounds, good evening, sir. Provided patient GCS full and asymptomatic, we can allow to leave the foreign body inside the brain. How about infections, reactions of brain towards the substance inside it, especially if it's metal and chemical substance? Will there develop complications later? And the second question was, those with penetrating injury with rusty materials, those excess, what were the antibiotics of choices given to them, assuming them they got their tetanus vaccines? By the way, it's a very interesting images compliment from the participants.
Thank you. Usually about the answer of the first question about the infection reaction of the brain toward the substance inside. Yeah. So generally, if it is plastic or some foreign body, definitely brain give reaction. But metals, it give less reaction. So if there is a wood or some plastic or some stone, we must remove it. But if there is a metal, we can leave it there inside. If there is not causing any neurological deficit or infection, you can leave it there. And this antibiotic, we use very simple antibiotic, ceftriaxone and this gentamicin. But if patient has some this hairs or something, very dirty wound, then we go for the higher antibiotic.
Okay, thank you, Prof, for the answers. So if there's any further question and answer, can be actually written down in the question and answer session.
Okay.
So I'll pass the floor to the next speaker. Dr. Nelson will be the moderator for the invitation of the next speaker. Thank you, Dr. Nelson.
Hi, good day, everyone. The next topic will be neurorehabilitation, which will be presented by Datin Dr. Suhaila binti Omar. She graduated in 1999 from the University of Otago and became a pediatrician in 2006. Then she became a fellow in pediatric rehabilitation in 2012 in the Royal Children's Hospital of Melbourne. She is currently working in Tunku Aziza Hospital, specializing in neurodisability and rehabilitation. She's an avid runner and hiker. Legend says that most of the patients under her care end up running and hiking with her. Without further ado, let us listen to her sermon. Datin Suhaila.
Do you see my slide?
Yes, we can see.
Yes.
All right, hang on, yeah.
Okay, perfect.
Okay, is that okay? Can you hear me?
Yes, can.
All right. So a very good afternoon. Thank you, Mr. Azmi, for inviting me for this talk. I'm actually very honored to be in this gathering of esteemed doctors and professors for the joint AASNS educational course and second KL Neurosurgical Emergencies. I'm a pediatrician by training and especially in the area of neurodisability and rehabilitation. And I hope to be able to give everyone a brief overview of rehabilitation for children after a brain injury. So this is the outline of my talk. It's basically on rehabilitation, specifically for pediatric. What's an acquired brain injury, its impact, and the importance of early rehabilitation for children. And I hope to finish with a case illustration. So pediatric rehabilitation or rehabilitation medicine per se is a branch of medicine emphasizing on prevention, diagnosis, and treatment of disorders that may produce a temporary or a permanent impairment. And it's actually mainly a process which is aimed at enabling people with disabilities to reach and maintain physical, sensory, intellectual, and social functioning. And this will also include providing them with the tools that they need to gain and maintain independence and self-determination. For children, our aims are similar. We hope to be able to improve the abilities of children and young people following major injury or trauma, whether it's surgically related or medically related, which are affecting their function. But the important thing for children is that for most of them, it's actually habilitation, as children may not have acquired the necessary skill set or reach a point of development at that point when they got their injury or their illness. So as a rehab physician or pediatrician, we need to identify all current and future impairments and provide these children with the necessary stimulation or rehabilitation to facilitate them to reach their developmental milestones and to reach their true potential. So when we look into the basis of rehab medicine, we use the framework of the International Classification of Functioning, Disability and Health, which is a framework endorsed by WHO as the international standard to describe and measure health and disability. And for children, actually, WHO has also come up with its own framework in 2007, and it's meant to guide us in establishing the rehabilitation plans and determining the patient's rehabilitation goals. And as we can see from this chart, health condition will be impacted by a series of conditions, be it whether it's an impairment of body structure or function, and how it limits or restricts a person's activity and participation, and also to take into account the environmental and personal factors which can also impact a person's quality of life. So, but for children, it's interesting because Peter Rosenbaum and Gotter in 2011 published a paper titled The F Words in Childhood Disability, where they came up with these 6 F words of disability, which are fitness, function, friends, family, fun, and future. And no one factor is more important than the other, and all these F words actually focus on a child's development. So when we look into how we think about rehabilitation for children, it's actually very important to think about their fitness, because children needs to stay fit and healthy, and therefore as part of a rehabilitation program is to look into how to keep them healthy and fit. We need to take into account that children will do things differently, and the fact that they can do them is actually very important, and we should assist them. And in terms of their participation, getting the children back to school and getting them to have friends is actually a very important aspect of social development. And not to forget the family being an essential component of their environment, and also to look into making things fun for children. Not forgetting that children will also grow up in the future, and we need to look into ways to develop their independence and to be an important member of society and the community. So I won't go very much into this because this is the forte of neurosurgeons, but we know that an injury to the brain for a child will present with a high number of challenges, because this is a highly heterogeneous population which varies in their age, nature, severity of outcomes, and the targets of rehabilitation intervention. And this will include multiple domains of the health and functioning. So I put here as myth, but sometimes it's also hopes, because when it's actually quite devastating when a child has a brain injury. But most times than not, we do hope that a brain damage in a child is actually less damaging or even less impairing. But evidence now are showing that children are getting more vulnerable to the consequences of neurotrauma than adults. And this is actually dependent on the age of onset, the severity of the injury, and pre and comorbid factors. And in fact, greater disability and morbidity are seen in the much younger age group children as compared, for example, the school-going or the adolescent age group. So the other hope that, or myth that we, try to pacify ourselves with is that children actually grow out of their deficits. And hence, when we focus our medical attention following the trauma, is basically to only identify the sequelae and time-limited treatments of the sequelae. But what is important is actually to remember that ongoing development of a child's central nervous system in the context of an injured or impaired nervous system cannot be the same as a central nervous system that develops without injury. And therefore, a child's needs and expressions of impairment and disability will change throughout the developmental continuum of that child. Myth 3, we can apply the knowledge that we have gained regarding long-term consequences in adults to children. Undoubtedly, adult data has been very helpful in helping to shed light in the long-term outcome for children, for adults, but children are not little adults. And two important challenges that children must face when they are recovering is that they must face the challenges of recovery, but also the ongoing challenges of maturing. And myth 4, minor trauma or concussion in childhood is without long-term consequences. Minor trauma can impact learning, causing attention, concentration problems, and this can happen even months following the injury. And the rate and extent of resolution of the sequelae depends on the identification and monitoring of possible deficits and its impact on the development. Okay, so when we look at the predictors of long-term outcome for children, there are so many because it can be injury related, it can be treatment related, it can also be patient related. And the contribution of these long-term outcomes will differ at the different stages of the recovery continuum. So if you're just looking at this slide, when we look into the impairments that a brain injury leads to a child, which can be, we've talked about this a lot, about neurological impairment, cognitive, educational, emotional, behavior, social, and all those things. But when we think about it in how a person does their things or a handicap, you can see the spectrum of problems that can occur, and the significance of these problems may not be realized until years after the injury, where higher level cognitive and behavioral functioning is required to meet the typical developmental, educational, and social demands of that person. So when we come to the rehabilitation of children with acquired brain injury. So actually is rehabilitation only the final act? And it's quite understandable that, rehabilitation is where patients will go to when the acute medical care hospitals have completed their typical care routines and children are found to be more stable. And at that point of time, they'll be found to have not resumed normal activity. But we hope that we can start rehabilitation early as a start for families to hope, or their first hope for fostering recovery. And from this slide, you can see that there's actually multiple stages of rehabilitation, whether it's acute, inpatient, or even outpatient or chronic rehabilitation, where the goals of this rehabilitation are different and the tasks or the plan of management are also very different at these different stages. Because we will come to this theory of neuroplasticity, which is this theory that when there is when there's the theory of neuroplasticity, where there's reorganization of the neural networks when there's actually some stimulation or when there's actually a brain injury. And this is the remarkable ability of the brain to actually undergo morphological and neurochemical changes as a result of this experience. So there's a lot of complex interplay, and there's some mechanisms of recovery. Can be reorganization in regions immediately surrounding injury. It can be recruitment of ipsilesional or contralesional areas, or it can be even shifts in inter or bihemispheric activities. So when we are planning rehabilitation, you should aim to improve functional abilities by using the approaches that I've mentioned before. Hence, rehabilitation interventions should start early, and it should extend through the developmental years, including the adolescent years for these children. And we should take into account real-world experiences. For neuroplasticity to work, you need to practice real-life tasks and activities, and it should be at high intensity, it should be repeated, it should be a continued process, and we need goals, because children need to be motivated, they need to pay attention, and these are the vital modulators in contrast to generic or passive interventions. And in the end, if we don't pay attention to this as part of our rehabilitation, it can also be harmful or non-efficacious for the patient. So to remember that pediatric rehab is a continued process. A child's needs and expressions of impairments and disability will vary across the developmental continuum. So we need to identify the impairments, we need to provide the necessary rehabilitation to maximize functional independence, and not to forget to include family from the very start. Always have goals to address, and we need to look into possibly even needing adaptive equipments, and we need to address complex behaviors that may come up as an interaction from multiple organ systems that have been involved during the injury, and we need to monitor the child's progress. So when we want to have a framework to provide acute and long-term rehabilitation, we need a team. So it needs to be a multidisciplinary team. We need a place to provide rehabilitation, whether it's actually for acute or subacute or even long-term. It must be a goal-directed rehabilitation process. And we need to involve the child's family from the very start. And we need to measure the quality of our rehabilitation services by using appropriate outcome measures. So when we look into the needs of a child in this process of rehabilitation, you can see that there's actually going to be so many people involved actually. So you've got this rehab doctor, you've got the caregiver, and you've got the occupational therapist, the counselor, the rehab nurse, the physiotherapist, clinical psychologist, the medical social worker, and each and every one of them play a very important role is interdisciplinary in providing the needs that the child will need for their rehabilitation process. So I'll go through my case. So this is an 8-year-old girl who's previously well with no medical illness. She was transferred to the neurosurgical unit in HTAKL for further management of a right parietal intracranial hemorrhage. And you can see that the timeline is actually pretty good. She had her sudden loss of consciousness and was found to have an intracranial bleed, and within the same day was transferred to our unit, and an emergency decomprehensive craniotomy and evacuation was done within the first 24 hours, and she got to our attention very soon after. And using the ICF, you can see this is a summary of her impairments. So she had a motor deficit of a left hemiparesis. She had a sensory deficit where she had loss of balance and proprioception. She had left hemineglect. She had a left upper motor neuron facial nerve palsy, and she had impaired cognition. And these were her activity limitations at that point of time. She was easily tired, she had low mood, she was even unable to just tolerate an upright position because she had dizziness and headache. She was unable to use her her upper and lower limbs normally. She was unable to even PU and BO normally, and she can't eat, and there was already risk of getting pressure injuries and all its complications. So we anticipated that she's going to have a lot of restrictions in all her activities of daily living. But the good thing is that when you look at her personal factors, she's a standard 2-year-old girl, a very jovial, happy girl, and she loves to hike. And the youngest of 3 siblings. She has a very supportive family, and her parents from the very start were very enthusiastic in her rehabilitation. So when we planned for her for her rehabilitation, you can see that the short-term goals initially was just looking into her medical needs, where we are preventing possible complications, looking into her bladder bowel management, safe swallowing, her bed mobility, and just trying to get her to sit up. And using the F words that I've mentioned before, we look into how to support her best in terms of her fitness, her function, and starting therapy gently to meet the short-term goals. And from the very start, we got the family involved to help us with the behavior and her participation in daily care and therapy. So as you can see, as time goes on for this girl, we were able to change our short-term goals consistently, where she continued to make remarkable recovery. She was already by week 2 going sitting independently, and was already able to swallow and didn't have problems with her cognition. So we are planning into looking into increasing her fitness level, thinking about how to improve her function and her activities of daily living, and start making therapy a fun and focused area of getting her back on her feet. And you can see that the family we also got the family involved, where we helped them to establish a knowledge base and to get them involved in compliance and maintenance of therapy. So these are some pictures of her involved in our rehabilitation process, in our gym. She remained very consistent in her mood and her effect throughout this whole time. And towards the end of the week 3, we can already see that she was improving remarkably, as I've mentioned before, and we started planning for her future. And this included a home plan where we hope that we can help her walk unaided for long distances, preparation for school, and started getting teachers involved in this process, and using her siblings as her motivators. And as you can see, we transitioned her into an outpatient rehabilitation program. So this is her going through some intensive therapy, where we use bimanual therapy or even mirror therapy to improve her upper limb function, and also photos of her doing her activities of daily living training. And I don't know whether I have time to show this. But this is, well, we tried to make it fun by making an obstacle plan for her. It probably doesn't look very much fun here. And of course, also gait training using a treadmill. Yes, she's not having shoes, but she forgot to bring them at that point of time. So by the time she transitioned to our outpatient program, she was already starting to start back going to school. This was 2 months after the brain injury. We've helped her to go through a staggered class. It's of course online classes because of the recent MCO, but she had no issues with behavior, fatigue, she had good sleep, and we started seeing some issues with learning. Of course, in terms of her spasticity management, we were aiming to improve her gait pattern and looking into that closely with a solid AFO and all that. And we plan for her future, where we hope that she's able to walk unaided long distance for school and to make up with her friends. And of course, she always mentioned that she wants to go back hiking. So for the future, what happens tomorrow depends on what we do today. This is her on top of Gunung Datuk, which is a mountain in Negeri Sembilan. Let me tell you, it's actually not an easy mountain to hike. There's actually a lot of boulders, and she's actually one of those children who's actually made it to the top. I think not many adults in Malaysia has actually climbed Gunung Datuk. So as a conclusion, early rehabilitation is crucial to ensure potential for best outcome in children. Rehabilitation is a process and it needs the support of the family, friends early to ensure success. We need to look into real life experiences to plan our rehabilitation and focus on the development of the child. And always remember to put in goals when we are planning our rehabilitation. So remember the 6 F words. With that, I thank you.
All right, thank you very much, Dr. Sohaila, for your enlightening presentation. So now we open the floor to all the participants for questions and answer.
Okay, from me, there's a question directed to Professor Virendra. There's one question from a participant, Dr. Ukarsh. What are the choice of material, suitability, the suitability with radiotherapy? So I think it's we regard the cranioplasty material that being used.
Yeah.
Professor? Professor, we couldn't hear you.
You have to unmute.
No. Can you?
Yes.
Now,
Okay.
for
All right,
if there is we remove malignant tumor and patient need radiotherapy, we don't do cranioplasty, frankly. But if need, then autologous material is best. You can't do the synthetic material.
All right.
Yeah.
All right, thank you. And then there is one more question for Datin Sohaila. What is the best therapy for bowel bladder function recovery in children and adults?
I can't speak for adults. Yeah, a lot of time in children, we need to see how they go on throughout the time when they are going through rehabilitation. So far, in a lot of children who have in a lot of children with a brain injury, depending on how they progress throughout their the time, you will be looking into training, getting the occupational therapists involved. If there is a spinal cord injury, for example, then we need to start by looking into CIC and whether there's a neurogenic bladder and bowel involved as well. So it's actually a long process. Sometimes we are successful during the very initial part to train bladder and bowel. But if it's not, then we need to look into what are the areas that are affecting the child. For example, is it cognition? So if it's a cognitive process and they need to go through the occupational therapist again or the psychologist to help them train bladder and bowel, that will probably be the area or the way we will go for that child.
Thank you very much, Dr. Sohaila. Is there any more questions from the floor?
Okay, there's another question actually in the other chat room directed to Professor Virendra. So in case if there's a patient happen to have hydrocephalus and a skull defect, and when you're planning for cranioplasty and a VP shunt, do you do it in the same setting? The first question.
Okay.
Do you do it on the same site or is a different site? Thank you.
Generally, if there is a hydrocephalus, I don't do VP shunt. First, I would like to do cranioplasty because after some time, the hydrocephalus resolves itself, right? Number 2, if there is a much of hydrocephalus and it is difficult to do the shunt, then I put lumbar drain, right? And so we remove the CSF and I do the cranioplasty, and then gradually I close the lumbar drain. If patient improves, I remove the lumbar drain and watch. If patient develops symptoms of high ICP, then I do shunt. But I usually avoid VP shunt in these cases. And I do on the opposite side. Depends on the size of ventricle.
Thank you, Professor, for the Great answers. Is there any further question?
I think there's one more question for Datin Dr. Sohaila from Dr. Ng Wei Ping. Will inpatient rehabilitation program be applicable to poor GCS children if the caretaker is unable to stay in?
Sorry, can you repeat the question?
Sorry, dear Datin, will inpatient rehabilitation program be applicable to poor GCS children if the caretaker is unable to stay in the hospital?
So as I've mentioned that actually to get the families involved early is actually very, very important because rehabilitation is actually a process. So yes, you can actually definitely start rehabilitation for a child who's got poor GCS in the hospital, but we need to get someone who's familiar with the child. We need some, because it doesn't just stop there. So yes, we can definitely start, but to have a person always there who understands and be part of the rehabilitation would definitely be a family member. We do have situations where we've definitely encountered situations where the environmental or the social factors are the impeding problem to ensure the success of rehabilitation. So we can start, but in the long term, whether it's going to be a successful rehabilitation, that's going to be the question.
Yeah. Thank you. So is there any more questions?
I think we proceed with a group photo. Let's everybody, moderators, speakers, and who else want to join. Then we continue with the next session immediately after this. We are just on time. Coordinator, who will in charge?
I will take the photo.
Okay, all right. So can you arrange the photo?
Sure. So the moderator, speakers, and panelists, please switch on your videos on my count. 1, 2, 3. Yeah.
Very important session.
1, 2, 3.
Yes.
All right. Thank you.
Thank you.
Thank you,
Professor
Dr. Lai and Dr. Nelson as well.
Thank you.
Thank you, Datin. In the interest of sticking to our schedule, we shall now move on to our next session under the umbrella topic of neuro-oncology. I would like to invite Dr. Donald Liu Ngan Sen and Dr. Patrick Kogiat Singh. Dr. Donald and Dr. Patrick, welcome. Floor is yours.
Good afternoon, everyone. Thank you for the organizing committee, our organizing chairman, Dr. Azmi Alias, our MC, Dr. Nadia and Dr. Lin, for inviting us to chair this session. Thank you very much. Without further delay, let us introducing our first speaker, Associate Prof. Dr. Xiao Wan Tiu, who is our president for AASNS. He also is a senior consultant neurosurgeon for National Neuroscience Institute and the KK Women and Children Hospital, Singapore. He has the subspecialty in pediatric neurosurgery and multiple publications in the pediatric brain tumor. And let us welcome Prof. Xiao with his topic of the day, tumor of suprasellar lesion in children. Welcome, Prof. Thank you.
Can you hear me? You can hear me, right?
Yes.
Okay.
Yes.
Thank you so much, Azmi, for allowing me to talk here today. And thank you for this wonderful organization. So today I'm actually just going to talk on tumors of the suprasellar region. And in the anatomy, you can see this is the sellar region. And we're talking about tumors that grow around there, right? And again, the anatomy from a lateral view, right? So the sellar, the clinal process, and then a lot of times we're looking at tumors that are around here. The vital structures that are here are of the obvious importance are the optic nerves, chiasm, the gland itself, pituitary gland, and of course the carotid artery, internal carotid arteries and its branches. And the common tumors that we see are the suprasellar this tumor in the suprasellar region in children are the craniopharyngiomas, the optic chiasmatic hypothalamic gliomas. Of course, we do see some small amount of pituitary tumors, and then occasionally you will see the Langerhans cell histiocytosis. But the three main ones that you commonly see, especially in our part of the world with germinomas, are these three tumors. And you can see on this scan, they all kind of look quite alike. And sometimes so the histology is something that you need to get to be able to treat these patients well. And radiologically, you can look at some of this, and I'll use this radiological way of looking. Although I must say that, my good friend Christian Senros has always said that radiology is not pathology. Nevertheless, right? So you see a calcified enhancing complex cyst mass distinct from pituitary, it could be a craniopharyngioma. So you see a bit of calcification, and well, here you can't see the pituitary gland because most of the time, actually the pituitary gland is actually squashed up by this tumor, especially when they go up in the sellar region. And then these are the other types of craniopharyngioma. So like this is what we call retrochiasmatic, because actually a lot of part of it is actually in the third ventricle, right? And then of course they cause hydrocephalus. Now if you see a T2 intense enhancing mass, and of course if the child has neurofibromatosis, then you probably are looking at optic pathway glioma. But you can see here, like this is a child that actually doesn't have NF1, but nevertheless, you can see T1 actually contrasts, enhances very well. And it's again in the suprasellar region. And of course, this turned out to be a optic chiasmatic glioma. Right, another one, it's even bigger. Right? So T2 hypointense. And again, these are lesions that cause hydrocephalus. Now you see a avid enhancing midnight mass, maybe contain fat, if there's dermoid or dermoid cyst. And of course, I think the very important thing is if they have diabetes insipidus, you are looking probably at a germ cell tumor, right? So again, you see, they all kind of look quite alike, maybe a little bit more variated appearance here on the T2. And this turned out to be a germinoma. And then, of course, a very classic one is actually a bipolar tumor, suprasellar tumor with a pineal region tumor. Most of these will be germinomas, although a small percentage could be the secreting type as well. And of course, we look at blood and if possible CSF. Another one, right? Another bipolar tumor here. If it's a non-enhancing ray, hypointense, and of course, if the kid gets gelastic seizure, then it's the hypothalamic hamartoma. These are relatively uncommon in our part of the world, and sometimes you also get them without gelastic seizure. And then finally, an enlarged pituitary stalk with diabetes insipidus, right? So they are talking here about Langerhans cell histiocytosis, but I think in our part of the world, if you have a thickened pituitary stalk, you need to think of germinoma. And of course, the treatment will be very different. So then, of course, in the adults, although in some children, you can see a pituitary mass extending, expansion of sella, and this would be the pituitary adenoma. The rest of the tumors, meningiomas, rachis, even aneurysms, they are much less common in children. Right, so you can see a pituitary microadenoma here, and a large microadenoma here. So I think the clinical presentation, of course, you need to look at them, visual field defects. So again, the same thing, bitemporal hemianopia is not uncommon, although in the optic chiasmatic type, you might actually get different field defects. Endocrine dysfunction, most of them will have some degree. Sometimes it's not apparent and you have to do the test. Of course, diabetes insipidus is a very serious thing, hypopituitarism, and you get very now and then a diencephalic syndrome. Of course, they also present hydrocephalus and raised ICP. There's another boy presenting with a diencephalic syndrome, right? And of course, in that case, this is what he had. This turned out to be a optic chiasmatic glioma. So the principles of treatment, I think, of course, very important to determine the endocrine status. And of course, we refer to the pediatric endocrinologist, and then they'll manage if possible. Because if you want to do surgery, you need to make sure that the hormonal levels are okay. And of course, their visual status, again, not so easy in smaller children because, it's not easy to test their visual fields. So we usually refer to the endocrine ophthalmologist, looking for visual field acuity, and sometimes they may use OCT. You need to manage the hydrocephalus, and most of the time you may have to do that first before you do anything else. So It's because the suprasellar mass will grow and then block up the foramen Monro. So in those cases, endoscopic third ventriculostomy is not the treatment of choice. In fact, you can't do it at all because the floor and the pre-poncidine cistern will be infiltrated by tumor. But I think what we do in many cases is to actually do endoscopic septostomy, because I think it's very useful to communicate the two lateral ventricles so that you need only one VP shunt instead of bilateral VP shunt. And then when you talk about surgery, I think very important is to how do you assess the tumor? What are your surgical approaches? Then are you just going to do a biopsy? Are you considering complete excision? Then of course, I think it's very important to consider safe surgery, so no or minimal destruction of surrounding tissues, vasculature. You shouldn't increase any neurological deficit. You don't want to lose function, and of course, minimum blood loss. And some of these cases, because of the location, then you may actually want to consider doing endoscopic transsphenoidal approach to actually even reduce the amount of neurological deficits. And then, so depending on what type of radiological findings, you may even want to consider doing only a biopsy. For instance, I think for germ cell tumors, a biopsy is usually sufficient. But for an optic chiasmatic hypothalamus, glioma, again, you may not be able to do a complete excision because you will actually cause visual field loss and even cause blindness. So you might just want to debulk if the tumor is big. And then of course, for craniopharyngiomas, you might actually want to do partial excision or total excision, and we'll talk about that as we go on. So the surgical approaches for suprasellar lesions, I think you can either do the peroneal or subfrontal or a frontal interhemispheric approach, depending on your how you feel, where the tumor is, and so forth. And then it's actually the peroneal or even the little bit subfrontal approach. You can get access to tumors, between the chiasm, the two optic nerves in the prechiasm area, or it can go between the optic nerve and the internal carotid artery. So actually, you have various areas that you can go to attack the tumor. And even for those that actually have prechiasmatic, you may actually want to open up the lamina terminalis to go into the third ventricle where a lot of tumors may be there. You can also consider interhemispheric approach, transcallous approach for tumors that actually go all the way up. And sometimes for very large tumors, actually you may have to do two separate approaches, either at the same time or actually at separate times. And of course, as I mentioned, you should always think of whether, this tumor, can it be done through a transsphenoidal approach, because I think that usually has a very much less morbidity. And more tumors now are actually being done in this route. The complications of surgery would include endocrine dysfunction, especially diabetes insipidus, which tends to occur in most of these cases after complete resection. You get complete electrolyte imbalances as a result, and some of these are actually quite difficult to treat even in the ICU. You can get visual loss, you can get vascular injury, hypothalamic injury, especially when you go into the third ventricle to remove the tumor. Very common in those days when we do a lot of enlarged radical resection of pituitary tumors and even death. So let's talk quickly about germ cell tumors. Right, in our part of the world, this is a fairly common brain tumor, and you say location is both pineal or suprasellar or both. Right? If it's in the suprasellar and even sometimes in the pineal, diabetes insipidus is actually quite common at presentation. For the suprasellar tumor, hydrocephalus is common, and of course, these are tumors that can be identified, especially the circulating ones, on just serum and CSF tumor markers. Right? They originate probably from the total potential cells, and in the suprasellar germ cell tumors, we tend to see a high incidence of female presenting DI, coccus puberty, diencephalic syndrome, and of course hydrocephalus. And as I mentioned, the hydrocephalus is caused by blockage of the foramen Monro as the tumor goes up. Right? So in those cases, you want to treat the hydrocephalus, you actually have to shunt them. And in the past, we used to do bilateral shunt sometimes, but now we tend to just do septostomy, shunt, and biopsy. And when you're doing the septostomy, you can actually do the biopsy. And of course, you also take the CSF or tumor markers. So like in this case where we are doing a septostomy, right? It's quite straightforward. Just go into the septum pellucidum, right? And then you can put a balloon in to make it enlarge. And then usually what happens is you can also see the tumor as you go in. And in this case, you can see it's quite easy. This is the cortex plexus, right? The tumor is peeping out to the foramen row, and you can actually just open up and take a biopsy. And this turned out to be a germinoma. So in this case, you just got to be careful because you can cause actually a hemorrhage, although the endoscopic biopsy has a much lower morbidity compared to open biopsy. Right, so you can see that they are very responsive to chemotherapy and radiotherapy. So this is a germinoma before the chemo, after 2 courses of chemo. Right, you can see the tumor is virtually melted away, and this is 2 years later. I mentioned Petri stalk because the more important thing is that you need to exclude a germinoma. And so these are cases where you will need to go and do a biopsy. And then because if you just observe thinking that these are histiocytosis and not very important, you might actually end up, with the tumor spreading, and then you may be too late. Optic chiasmatic thalamic hypogliomas, these are low-grade astrocytomas, like some cases associated with NF1. They can be very large, right? And they can be very aggressive, especially in very small children. Used to have a pyromyxoid variant, which was thought to be WHO grade 2, but now I think in the new classification, all these are placed into low-grade grade 1. Right? And many, but not all, will respond to chemotherapy. So you can get actually a pilocytic astrocytoma, or you can get a pyromyxoid, right? And so these are examples. You see, you can have cystic ones, solid ones, small ones, and sometimes you can get them also in the optic nerve as well. So look at this, the one that actually had a titillation, tilting the head when look at things, poor visual field. You can see it's quite a large tumor of hydrocephalus, right? So this actually you can, when you do this is through a Tyrrhenian approach, you can see this tumor in rising from the chiasm, right? And we actually just biopsied them, and this turned out to be a pilocytic astrocytoma. Okay. Another case where it's a huge big tumor presenting in a 1-year-old boy, right? And this was actually, I did this through a frontal interhemispheric approach, and you can see tumor below and above the optic chiasm. Chemotherapy, so most of the time we actually end up biopsying and debulking, and then you send them for chemotherapy, and it's usually a combination of vincristine and carboplatin through the low-grade glioma protocol. But I think with the molecular biology coming into play, all right, because most of them actually have some upregulation in the RES and MAP pathway. And I think it's very important to understand that actually pilocytic astrocytomas, actually the only genetic change you get mutation in them is actually this KIAA1549 BRAF rearrangement, which actually So actually they are not very, if they have this, actually they're very benign because they are also polycystic astrocytomas actually have the BRAF V600E mutation. But the more frequent is, as I mentioned, this KIAA119 BRAF mutation, right, which are more common in the posterior fossa cerebellum, but the BRAF V600E mutation actually is more likely to be seen in the supratentorial ones, right? And so you can see in this picture, right, in the KIAA1549 fusion is much more common here compared to those here, which has both the BRAF or the NF1 mutation. And so you can look at targeted therapy. I think if it's BRAF inhibitors, there are quite a lot of drugs available. The question is, how long do you keep them for? Because I think there's in many cases, we will stop them, the tumor may come back. So this is just some of the things that actually are dealing with BRAF inhibitors. In fact, in some of these BRAF inhibitors, you can actually end up with a paradoxical activation of the signaling system, causing actually accelerated growth. So actually, the newer generation of these what they call paradox breaker agents actually are designed to inhibit BRAF without causing reactivation, right? So we actually, some of these can be used for the BRAF inhibitors are actually being used for the this tumor, and then also some of these other MEK inhibitors are actually being used. I think the ones that we use here in Singapore are trimethamine because it's still very expensive. Now, for tumors that actually do not respond to chemotherapy, and they're still growing, you can go back and debulk, but sometimes they still grow and grow. And so we have quite a few cases of this that actually we end up giving fractionated radiosurgery. So we use a, so they actually, tumor over a 30-day session, up to 54 grays. And you can see that actually they respond quite well. So this was done in 2007, right, this case. And then I think even now it's actually shrunk to a very, very small size. And so they're very useful. Of course, the patient vision has slowly deteriorated over time. And but I think these are, things that you can use if you really have no choice. And of course, in many of these patients, they're hydrocephalus, right? They actually made out with shunt ascites. So you might have to then put them into a VA shunt. And then there's some reports, although we've not seen any in my cases, the secondary moya disease related to radiotherapy. And then finally, talking about craniopharyngiomas, right? They account for about 3% of intracranial tumors, solid or cystic. And the important thing is that many of them grow backwards and are intimately attached to the hypothalamus, and they can be found along anywhere on the pituitary stalk. So they are actually epithelial tumors that rise along the path of the craniopharyngeal. We have two types, the adult one and the peds, right? So the pediatric ones are the erythematous craniopharyngiomas, the adults are the papillary craniopharyngiomas, and they are classified as WHO1, but especially those in the children, they are aggressive with infiltrative behavior, which also unpredictable growth pattern, right? So for this, of course, again, the usual thing, neurological, endocrinology, ophthalmological, neuropsychologically, because of the involvement of the hypothalamus, and then, of course, radiological examination. Now, craniopharyngiomas, I think this is where the current so-called controversies. I think in the past, we used to consider, radical resection, but now, of course, we are doing less and less because we want to reduce hypothalamic injury. And most of these cases now, we think of them as a chronic disease with needing lifelong hormonal therapy, also lifelong visual neurosurgical follow-up, right? And then we talk about radical resection, right? This was previously primary treatment of choice, in associated best outcomes in terms of overall and recurrent free survival, but the quality of life in many of those cases were very poor because of hypothalamic injuries. And of course, this tumor is surgically challenging because of irregular margins, tendency to adhere to vital neural structures, and also the fact that the relationship between tumor and surrounding nervous structures and the hypothalamus, those are important. So there are two basic philosophies now when you look in the literature: aggressive approach, attempt complete resection. I also a more conservative approach with combined adjuvant radiation to treat the residual tumor. Because I think the most important thing you ask yourself is what the goal of the surgery? Is it recurrence-free survival? Because if you leave some behind, it's definitely going to come back. Or are you looking at preservation of visual function? Because if you don't do anything, most of these patients will go blind. So actually just decompressing the optic nerves and optic chiasm may actually just be the trick to do. And then you don't do anything else and treat the rest of the remnant tumor with radiotherapy. And are you looking at long-term quality of life? Because if you have hypothalamic injury, especially hyperphagia and behavioral issues, they are very, very difficult to cope with. So depending on what you want to do, there are multiple microsurgical approaches, as we mentioned earlier, for the other type of tumors, or you can combine surgical routes. You can use skull-based approaches, or even now endoscopic and endonasal transsphenoidal approaches, right? So for instance, this aggressive resection, you can remove everything. You can see the optic, even the basilar artery, everything's free here in the sellar region, right? Or you can do a subfrontal approach in this retrochiasmatic tumor where there's no space between, open up the lamina terminalis, and then have another total resection. All right. Or you can look at transsphenoidal, right? So interstellar diaphragmatic. And actually what you're seeing now is that more and more are doing that. In the past, even we say that if the cellar is not pneumatized, you can't do it. But we have actually quite aggressive surgeons who actually will do through the solid cellar in smaller children if necessary. Right? Complications are small because I think this technique has improved a lot in the years. And then the other thing to think about is preservative surgery, right? Management involving one of complete surgery to one of a multimodal approach. Aim is to control disease and improve the quality of life. And because most of the postoperative morbidity, as I mentioned, is related to hypothalamic dysfunction, and the worst form of hypothalamic dysfunction include hyperphagia, morbid obesity, and behavioral dysfunction. And I think you can see many of these children in many of our units from what else we had done in the past. So as I mentioned, right, you can even do static aspiration or reservoir. I think the other thing that people are doing is the fenestration of intracystic craniopharyngioma, and then starting to give either interferon or in the past bleomycin. So this is a case where we can do an endoscopic placement of a catheter into the craniopharyngioma through the foramen Monro. You can see here that actually this one we're using a two-hole approach, so the tube is coming to separately into the from a different hole, but being visualized in the endoscope. And you can see that here the floor is the cyst part of the tumor is still very thick, so you use a monopolar to just make a hole to burn it before you can put the catheter in. And that's why sometimes blind penetration of this craniopharyngiomas are not so easy. So now you burn a hole in the membrane and put the catheter in. And you can see, at least the last hole must be inside the tumor before you stop the process. So the visualization of your endoscope does help, right? And then this patient actually, after this, had a radial surgery done, and you can see it had stayed the same size. Now, so this is now 14 years since the surgery, and the patient still doing well. Just a bit of, still a bit tall, a bit short, fat, classic hypothalamic type features, and some degree of hormonal replacement, panhypopit, not truly panhypopit in this particular girl. So I've done 2 girls that like that. Now, if these tumors come back, then of course there's a whole list of chemotherapy that was used in the past. Even the use of for the cystic tumors, they're using intramuscular pegylated interferon-2 alpha, right? And people are starting to use BRAF and MEK inhibitors for the papillary craniopharyngiomas because they are BRAF 600V600E positive in some of those cases. Now, for the adamantomatous craniopharyngiomas, we know that the Win-B catenin signaling inhibitors, because of this mutation in the Win pathway, but it's still very early days yet. So some use of tri-vitamin MEK inhibitors. And of course, radiation is actually a adjuvant, especially for after partial excision, because craniopharyngiomas are very radiosensitive, right? You can use various modalities. More and more people now turning to proton beam, and so you can do more focused modalities, reduce damage. So basically, what you do is you decompress the optic nerve and the chiasm, whatever's left in the third ventricle, you actually just give radio surgery. And of course, once you give radiation, the recurrence rate is actually much, much lower. So in summary then, the supracellular tumors, the common ones are the craniopharyngiomas, optic-chiasmatic hypothalamic gliomas, and the germ cell tumors, right? They are hydrocephalus, they can present that, needs to be treated. And we have several surgical approaches, pteroneal, subfrontal, frontal inner hemispheric, endoscopic approaches. And aggressive surgery to remove this tumor can lead to severe morbidities and especially hypothalamic injury. And there are several options other than gross total resection, which can help to reduce morbidity and improve quality of life. And don't forget, next year, September 2022, the AASNS, which is our main meeting, will be in Jerusalem. And I hope that all of you can see us there. This will be a live face-to-face meeting, so hopefully we can get and meet. Thank you very much.
Thank you, Prof. Thank you, Prof, for the wonderful talk. Being showing us a lot of case scenario and the intraoperative complication. So regarding the question, I think we leave it until the end of the Q&A section. Is it okay? Then let us invite our second speaker, Prof. Basil Kumar Misra. He's the head of Department of Neurosurgery, Surgery, and Galvanized Radiosurgery in PD Hinduja National Hospital and MRC, Mumbai, India. He's also a worldwide well-known neurosurgeon, which has been contributed worldwide towards his work. And recently, he has been awarded with the International Lifetime Recognition Award recipient by the AASNS in 2020. Besides that, he also awarded with the recipient of the most prestigious Dr. B.C. Roy National Award in the category of eminent medical person in 2018. Without further delay, let us invite Prof. Misra with his topic, surgery of intraventricular tumor. Thank you, Prof.
Thank you. Good morning, or is it good afternoon in Malaysia? It's good morning still here in Mumbai. Nice to see you. Thank you, Asmi. Very nice meeting. You have had a galaxy of speakers, and I understand that there has been very good participation. Thank you for taking it forward. So I'm going to be, this will be complimentary for a very nice talk by our President Wan Chiu So, talked about the suprasellar. So we're a little higher up. I will skip the suprasellar lesions and the posterior third ventricle lesions. It will be primarily, there's no conflict of interest. So primarily lateral ventricle and anterior third ventricular lesions. I am not going to talk about suprasellar tumors and no posterior third ventricular tumors. So this is based on my personal series over many, many years now, about nearly 400 cases, anterior third ventricle 275, and this is a microsurgical series. This excludes endoscopic biopsies, especially in the lateral ventricle wall, like thalamus and hypothalamic lesions, where we do just endoscopic biopsy and go for adjunct treatment. It's not included in this series. So a little bit about the anatomy. The third ventricle has 5 walls. The anterior wall is the column of the fornix, here, there, and there is the anterior commissure. There is the lamina terminalis, and there is the optic recess. And the floor is the optic chiasma, infundibulum, and then the mammillary bodies, the posterior perforated surface will be there, and the tegmentum, the midbrain. And this is the lateral walls at the thalamus and the hypothalamus below, and there is hypothalamic sulcus. The roof is formed by the fornix and the telechoroidea, 2 layers, velum interpositum and choroid plexus between the telechoroidea. Lateral ventricle, there is a lure of 5. There are 5 parts: the 3 horns, the frontal, temporal, occipital, the body, and the atrium. And there are 5 critical surrounding structures in the lateral ventricle: the caudate nucleus, the thalamus, the fornix, the corpus callosum up there, and the genu of the internal capsule. So these are very critical structures, so one has to be aware of this when especially you are doing a microsurgical decompression or access to this lateral ventricle. The vascular anatomy is also important to remember. The veins are very critical: the anteroseptal vein and the anterocoroid vein. They join the thalamus-striate vein to form the IC, internal cellular vein, and that these internal cellular vein drains all the critical structures in the deep brain structure: the basal ganglia, thalamus, internal capsule, corpus callosum, septum, fornix, and centrum semioval. The arteries in that area: the anterocoroidal artery, the lateral posterior artery, and the middle posterior choroidal arteries. The approach to the lateral ventricles, the microsurgical approach, depends on where the tumor is. If it is in the frontal horn, you could go through a transcortical. I will show you examples. It could either be a transcortical or transcallosal approach from the middle frontal gyrus. For the body, it's mostly we do a transcallosal approach, especially in the bilateral ventricular lesions. But if it is a unilateral, we are more and more we are doing a transcortical approach anteriorly, coming like this. And for posterior regions, the transcortical superior parietal lobal approach or the interhemispheric approach. Posterior lesions in the occipital horn or the trigone can be approached to the occipital lobe, or if there is a glioma, you can excise the occipital lobe and excise the tumor. For the temporal horn, the transcortical temporal lobe resection, if the glioma like this in front or in the middle temporal gyrus, a cortical incision, or through a transsylvian approach, one can go through that. So more and more for the lateral ventricle, we do a transcortical access as opposed to anterior third ventricle, as you will see more interhemispheric transcallosal approach. So this is a subependymoma. This is middle frontal gyrus, anterior body and frontal horn tumor, which was excised. This middle frontal gyrus can access the frontal horn, the body, and the lateral and third ventricle both can be accessed. If there is a gross hydrocephalus before pre-surgery, there could be cortical collapse and producing the subdural hygroma or hematoma, so one has to be aware of that. Tension pneumocephalus at the end of the surgery, so we fill up the ventricle to see the artificial CSA before we close it, and whenever there is a transcortical incision, we give anticonvulsant cover to prevent seizures. Lateral temporoparietal incision for the trigone lesion. This is a meningioma in the trigone. This is a preferred site for intraventricular meningioma. It's not a suitable approach for lateral temporoparietal access for the left side, because obviously this is the dominant side, and that could be homonymous hemianopia, dysphasia. And the other problem when we go for a temporoparietal incision in a meningioma, the vascular supply is from the front. So there is bleeding. So we have to access. So what we use today, use an endoscope access to the vascular pedicle. We coagulate that and then we remove the tumor. Giant tumors, all this lateral temporoparietal incision is a good access. This is a tumor already reaching the surface. Very vascular. This child, the 1.5-year-old child, had another center one go. You can see there is one operation has been done, but they backed out because of significant bleeding. But you can still take it out, aggressive excision and complete excision. The child remains tumor free now. Is almost 12 years now. Another on the other side, again the similar approach, the giant tumor, excision, total excision, no adjunct treatment. These are all children. This is a meningioma in an adult, an aggressive, meningioma with a cystic component. Cystic meningiomas are aggressive meningioma, as you know, more common in the intraventricular location. And this is one such which was removed through the superior parietal lobe approach, and excision was achieved. Middle temporal gyrus or anterior temporal lobectomy could be done. Anterior lobectomy we usually do along with gliomas, but otherwise benign tumor we would do a middle temporal gyrus approach, which was done for this tumor, and this was excised. This approach, very useful approach for the non-dominant hemisphere. For a glioma, you can do an occipital lobectomy in the posterior part of the lateral ventricle and excise the tumor, or you can go through a transoccipital cortical incision and remove the tumor. The main problem is homonymous hemianopia if the patient doesn't have that. So we will, if the patient does not have any visual deficit, we use an interhemispheric approach for this for these tumors. Biventricular tumors like this, a neurocytoma is a common tumor in the lateral ventricle. We use a transcallosal approach so we can access both sides. And this was done such approach, which was done for this tumor, biventricular tumor, and total excision is achieved. This approach can access the frontal horn, the trigone, the body, and has a bilateral access. Theoretically, there is a risk of disconnection, especially if you're going more posterior, but none of our patients, when you have an anterior callosal excision, will have this problem. So though that is described, but it is very uncommon, and especially if you do a minimally invasive microsurgical anterior transcallosal section, it does not produce disconnection syndrome. See, another tumor in the trigone, again, was approached through a transcallosal approach. This was a choroid plexus papilloma, and this could be also excised through this. So move on to third ventricular tumors. The two main approaches for anterior third ventricle is transcallosal and transcortical. And there is this discussion whether it should be a pure endoscopic approach or a pure microsurgical approach or an endoscopic assisted microsurgical approach. I'll tell you what we do. Now, we do more often a transcallosal approach, microsurgical, and the vessels one has to be very, very careful. These are sacrosanct, the cortical veins, all we preserve. Now, today, if there is an anatomy which is not not convenient for us to go for an intrahemispheric transcallosal approach, we would not hesitate to a small transcortical incision. I was much more dogmatic about 10 years back. I would try to do every case transcallosal, but I have moved on, especially if this is because of the image guidance, endoscope assistance, you could generally will do a transcortical incisions. But if the anatomy is good, if there is venous anatomy is good, suitable for us, we prefer a transcallosal approach. One has to be aware of the cortical veins, the sagittal sinus, not too much of retraction that can produce thrombosis of the sinus, pericallosal arteries, I'll show you in the video, and the middle posterior choroidal artery, internal cerebral vein, and as you go down in the floor, the circle of Willis. So the third ventricle routes of entry, either through transcortical or transcallosal, there are four true routes of entry. One is the transforaminal approach to the foramen mondo. This is our workhorse. This is the best approach, especially in large tumors when the foramen mondo is enlarged. That's the best way to go. Least invasive approach, and this is our most common approach in my practice. The other next common approach which we have used is the subpharyngeal transchoroidal approach. Both this approach I will show you short videos. Initially in my practice, I have done about 20 odd cases through the interpharyngeal approach. We do not advocate interpharyngeal approach. This is mentioned just to be condemned unless the tumor has separated both the pharynxes and bulging up there. We do not try to dissect and go in between the two pharynxes. It doesn't matter how good you are. Once you handle both pharynxes, there would be effect, post-operative effect. So today we say we do not do it, should not be done unless the tumor has separated the pharynxes. The other approach which we have very rarely used, unless again the tumor is bulging into there, is the subchoroidal approach. The risk to the thalamus striate vein is significant, so we don't use that one. So the approaches which we have commonly used, the transforaminal and the suprachoroidal approach. I'll tell you, this is how this is in this until 2017. One of my residents had analyzed. So the commonest approach was the parapharyngeal transforaminal approach. The initial cases, interpharyngeal, and some few cases where it has separated the pharynxes, and the next common is 55 cases of subpharyngeal transchoroidal approach. So this is a short video of a classical parapharyngeal transforaminal approach. Very careful, though you don't damage any of the veins. You see a longest craniotomy. If you have a good, I'll tell you why we do that. Most of my patients are referred patients for surgery. They have already had MRI. So we need to repeat another MRV to reduce the bone window or the craniotomy size, which costs money because many of our patients are paying from their pocket. So we do not repeat an MRI. Rather, we would do a longest craniotomy, but it's a very short dural incision depending on the venous anatomy. So once you do that, this is the midline. Now this is the pericallosal artery. This could be separated to both sides, could be one side, depends on how they are disposed there. This is the corpus callosum. This is a very wide. Sometimes the cingulate gyrus are stuck together, so one may confuse. But once you have seen the texture and color of the corpus callosum once, you would not miss it. Unless until it's a very large tumor and there is adhesions or redo, that can be sometimes problem. And this is once you have reached the lateral ventricle. And so this is the choroid plexus, usually attached at the posterior wall of the lesion in the third ventricle. So we call a little bit of the choroid plexus, and then we have incised the colloid cyst. Try that the colloid cyst contents do not get extravasated into the ventricle. That can produce something like a chemical meningitis. So avoid that. Put patties around it, and we suck it out. And the last bit of the capsule we are excising. And this is a complete excision. That's the foramen mondo, large foramen mondo at the end of the surgery. You can see that. And as I said, in large ventricles, we always put artificial CSF, or you can just put ringer lactate or saline or whatever. But fill up the lateral ventricles before you close. And this is the exposure. You see, this is the so this is the incision from the sinus is 1 centimeter, is 2.5 centimeter dural incision. And the cortical the incision in the callosum is So this is the next common approach in our practice. It's called the subpharyngeal transchoroidal approach. In fact, this is the approach in the literature we described first time in the literature in 1994. We call it subpharyngeal suprachoroidal approach, but subsequently Dr. Roten described an anatomical description and he called it transchoroidal. And so this is much more well known today as the transchoroidal approach. So this is the approach actually I demonstrated in Professor Ramamurthy's one microsurgical demonstration in his unit, and this is demonstrated in 1994. When the tumor is posterior, the foramen mondo is not enlarged, or the tumor is behind the foramen mondo or bulging so that the foramen mondo is getting occluded, we access between the body of the fornix and the choroidal fissure. The thalamostriate vein is spared. This is a very good approach. We commonly use the transforaminal and combine with the transchoroidal approach to have a complete excision today for large tumors which are posteriorly situated. This is the tumor. You can see that the callosal incision now, and then we go into the usually in the lateral ventricle. Now we open up the choroidal fissure. We coagulate the choroid plexus, and we have a much more. We cut that the choroid plexus. The fornix is covered with a patty. The thalamostriate vein is laterally, which is not injured. And we open up the choroid. So we have a much bigger exposure here, as you can see in a minute or in a few seconds, actually. So you see, this is the exposure you can get it. So all sorts of tumor, the choroid plexus, papilloma, meningioma, everything you can excise through this approach. This, of course, was a choroid cyst. And then we decompress the thick material and we decompress the material, and the last bit, which is the capsule, which is attached posteriorly to the choroid plexus, we cut it to have a total excision. And at the end of this, we usually today use endoscope to see there are no clots there. You see the very clear foramen mondo there, and we see that complete excision is achieved and there is no clots. That also helps. So for the transcallosal route, our dictums are we do a curvilinear skin incision bicoronal. It's a much more cosmetic. The right pericoronal craniotomy, we do a longest bone window. I told you for what. We do a 1 centimeter or max 1.5 centimeter callosal section in the anterior callosum, never produces a disconnection syndrome. We communicate both lateral ventricles through the roof and avoid to the septum. So this avoids a isolated ventricles. We do not, very critical, that not a single cortical vein should be coagulated. The older textbooks say that you can coagulate the cortical veins anterior to the coronal suture. We don't do it. Every time you do it, you do MRI, there will be effect of that cortical vein excision. So we avoid it. As I said, if the venous anatomy is not suitable for us, we do not today hesitate to a minimally invasive transcortical approach. We do not advise incising any margins of the foramen mondo, again, something in the older textbooks. Handling both fornices, I emphasize interfornicial approach should not be used unless until the lesion is separating the fornices. We do not coagulate the ependyma that can produce adhesions and produce hydrocephalus in the later part of the patient's follow-up. Interfornicial approach only to be mentioned, to be condemned. I initial practice my early days of 87 to 89. I used this approach. I was very excited with Professor Apuzzo's description. We tried it every single patient. We had a PhD student of a psychology, clinical psychology, who had a pre-operative evaluation, full neuropsychology evaluation, and all these patients post-operative neuropsychological evaluation. Some degree of deficit was always there. This was published in 1989. So tumors like this is a giant craniopharyngioma, multi-compartment. We use a staged renal plus transcallosal approach. Professor Wantu talked about the more conservative approach today, especially in children. I think in adults, we are much more aggressive because the risks of a hypothalamic dysfunction, growth, and other problems are much less in adults. So while we are little less aggressive in children, we are much more aggressive for radical excision in adults, because the best possible the recurrence-free survival is with complete excision. And this is one such patient where 2 approaches and a complete excision was achieved. This is another pure third ventricular craniopharyngioma, which was used a transcallosal transforaminal approach. I'll skip the first part again. You see that the tumor inside, through again the transforaminal, we've opened up the choroidal fissure to have a bigger exposure, and that's the tumor there. And this is the craniopharyngioma, solid component, calcified component, and the typical fluid compartment there, which we have decompressed. And then we excise it. Now we have done a microsurgical anterior third ventriculostomy at the end of the surgery to open up the ventricle at the bottom, the base. And that's the basilar artery there. You can see that. And there was a little bit of calcified residual tumor, which was there, which were following up. And if, depending on the progress, we may go for a adjunct radiation therapy. At the end, we see that endoscope has been put, this mammillary bodies, the third ventriculostomy is seen there. So some of the rare lesions which has been operated in the third ventricle to a transcallosal approach, the SEGA, the craniopharyngioma, I showed one example, the cavernoma, choroid plexus papilloma, metastasis, cysticercus, we have some granulomas, tuberculous granulomas also. Now, this was something which I operated 30 years back through a microsurgical approach. Today, we don't do it. This is an ideal case for an endoscopic fenestration. That is what we do today. And we do endoscopic deroofing, and that's all is necessary. You don't need to do a craniotomy, a burr hole, endoscopic arachnoid cyst deroofing is all that is necessary. Neuronavigation is useful, especially in small ventricles, and through it when we are doing especially a transcortical approach. And especially in recurrent tumors and or multi-compartment tumors, the role of neuronavigation is useful. Otherwise, for intrahemispheric transcallosal typical third ventricular tumors, we don't find any use of, because anatomy is constant. What about in pure endoscopic? Most of my cases have been done through a microscopic approach with endoscope assistance. We have not used pure endoscopic approach except pure cystic lesions like arachnoid cysts. And this is the types of cases which were seen in the lateral ventricle. The commonest tumors are the neurocytoma and the oligoastrocytoma. We have 14 meningiomas and 17 ependymomas. And in the third ventricle, the benign lesion, the colloid cyst, more than 200. They're by far the commonest. Pure third ventricular craniopharyngioma, 5 cases, and these are the other lesions which were seen in the third ventricle. These are intra-third ventricular lesions. This series does not include the thalamic lesions where we have done either endoscopic or biopsy or just biopsy microsurgical. So these are the microsurgical. We have tried to decompress the malignant lesions, different malignant lesions in the third ventricle or diencephalic lesions. So post-op outcome generally in benign lesions has been very good, and we have had one death very earlier in my series of a patient who had a third ventricular ependymoma which died because of post-op meningitis. So our paradigm today, endoscope assisted total excision in all types of intraventricular benign lesions, and we do not use a shunt. In lateral ventricular tumors, we use a ventricular drain, especially in gliomas and ependymoma. We leave the ventricular drain for a few days, and malignant lesions, many of these go for a post-operative shunt because of persistent hydrocephalus. For benign lesions, mostly the shunt has not been necessary. For third ventricle, the preferred approach has been a transcallosal. The transforaminal is the workhorse. We use an endoscope as an assist. Lateral ventricle, more often we do a transcortical approach other than the patients who have biventricular lesions where we use a transcallosal approach. Benign lesions usually have very good outcome. Before I close, I would like my colleagues, you people, to invite to the 8th World Federation of Skull-Based Surgery Society meeting in Rio, which was in 2020 scheduled. Now it's been shifted, in-person meeting, March 2023 to 27, 2022. Please join us. People who are interested, and of course OneTwo has already shown this. This is our continental meeting, 6th through 8th September, Jerusalem, a place which has to be in the bucket list. If you have not gone there, do join us there in this meeting. Thank you very much for your attention.
Thank you, Prof. Thank you, Prof, for your amazing talk, your time and your experience. We've been getting a lot from this. So let us invite our third speaker, our Prof. Dharmendra, which from our lovely country, Malaysia. Prof. Dharmendra is a senior consultant neurosurgeon from University of Malaya, Kuala Lumpur, Malaysia. He has his area of expertise in complex spinal neurosurgery and the pediatric neurosurgery. He also has been involved in multiple publications, especially in the trauma, vascular, and the pediatric tumor. So let us invite Prof. Dharmendra with his topic, posterior fossa tumor in children, now temper. Thank you, Prof.
Thank you, Patrick, for the introduction. A very good day to the panelists, as well as all the audience. A significant number of you are online. I'd like to thank my colleague Azmi and his team for this invitation for me to talk on posterior fossa tumor in children, the nuances and pearls. All right, we will plunge into the topic straight away. Now, posterior fossa tumors are one of the more common sort of entities that you would see in the pediatric age group when you talk about pediatric neuro-oncology. And what is the aim really? The aim is to do maximal resection with minimal morbidity. I mean, as we all know, the posterior fossa is a small compartment, and within it, it's less forgiving than a supratentorial operation. And the reason for that is because you've got your brainstem right in the front there. So if any morbidity, even a small hematoma within the cavity can sometimes cause harmful effects to the child. So the idea really is something like what this picture mimics there. You got to bring the entire building down without actually disturbing your peripheries of where the lesion is. So maximal resection with minimal morbidity as far as possible. So that should be the main aim when you're attempting to do an operation of this nature. And today I will just touch on broadly, right, on three areas which I think it's quite important when you talk about posterior fossa tumors or even tumors as a whole. The areas will be the skills, the technical aspects of things, and the surgical adjuncts that are available on this day and age. Now, when you see a posterior fossa tumor, there are two things you're contending with really. I mean, the first is the hydrocephalus, which is, the most of the time that's the presenting feature in some of these kids. And some of them do present because of the local mass effect in the cerebellum as a result of the tumor. Now, when you see something like this, I think the first thing you want to know is this tumor within the ventricle or is it in the cerebellum? I mean, the three common lesions that you will see is medulloblastoma, which is typically, encroaches into the ventricle, and ependymoma is in the ventricle. And you have pilocytic, which most of the time is not in the ventricle, it's in the cerebellum parenchyma, and then it sort of expands. Of course, when the lesion is large, to distinguish the two might be difficult. But I think it's quite important to distinguish the two because if it's an intraventricular lesion causing hydrocephalus and a scan like this where you see periventricular signal change, and the child has got some symptoms of high pressure, it'll be sensible to tackle the hydrocephalus first before going for tumor debulking. I like to do it in two stages. Unless you're dealing with a pilocytic, then I will try to avoid diverting the CSF. And as as years have gone by, these days you avoid putting in a shunt when you see a child with a posterior fossa tumor. You tend to go for endoscopic third ventriculostomy. And if it's a ventricular lesion and the child has symptoms of increased ICP, I will do this upfront first and give the child about a couple of days, maybe 3 days to about a week. And during that time, I will perhaps do an MRI, brain and the whole spine. I mean, most post-fossa tumors, you've got to do the MRI of the whole spine. And I like to do that before any resection because you get to see the spinal drop mats more clearly before you do an operation. Because after you do an operation, the blood products sometimes can mimic leptomeningeal enhancement, and that's really confusing. For the oncologists, that piece of information is so important. I know for the neurosurgeons, you don't really think much about it, but the adjuvant treatment that the oncologists are planning hinges a lot on the entire central nervous system appearance pre-surgery. So I try to do it as far as possible before surgery, the brain scan as well, the entire spinal whole spine scans to avoid all these ambiguities after that, right? So you get a child that has got an intraventricular lesion, be it medullo or ependymoma, you will consider doing an endoscopic third ventriculostomy rather than a VP shunt. And then you'll proceed. I mean, the reason I tend to do it upfront is because inevitably after you operate, right, there will be some sort of obstruction going on in the foramen, Majandi, Lushka, there'll be some inflammation there, and that will impede the CSF circulation. If you have a diversion upfront, you can protect your wound from pseudomeningocele and leaks and so on. Because we have slowly moved away from putting EVDs. I mean, as we all know, EVDs in children has got, the infection rate is unnecessarily high, and the whole challenging process will keep the child much longer in the hospital. So this is a very important point. You've got to look into the hydrocephalus and decide whether you're going to treat it. Pilocytic astrocytomas with where I can see the ventricle is just deviated, I don't do a diversion up front. I will plan do the operation, but during the operation, if the whole pos fossa is tight, I will put an external ventricular drain to just lax the pos fossa before I operate, because you don't want the pos fossa to be tight at the back when you open it up, and that can cause more harm. So you can put a transient, a temporary external ventricular drain during surgery. Sometimes I just remove it right after surgery, rather than leaving it there. So that is only for pilocytic astrocytoma when I open it up and I find that the pos fossa is tight. Certain cases, if you give them 2-3 days with a bit of dexamethasone on board, the tightness settles, and you don't have to put an external ventricular drain. But for ependymoma and medulloblastoma, my threshold is lower. I tend to do a diversion first before I embark on the resection of the tumor itself. Now, what are the nuances when you talk about surgical resection of the tumor? Now you've sorted out the hydrocephalus. Now you're looking at this. So most pos fossa tumors, be it pilocytic, medullo, or ependymoma, you want to get most of the lesions out. Okay, that's a done deal. You want to do that, but of course you want to do it safely, because the functional outcome hinges on safe resection, whereas the oncological outcome depends on how much you resect. So you, as a surgeon, you're concerned about both these things. You're not just concerned about a beautiful scan. You want a good outcome as well, right? Now let's just quickly run through some of the so-called contentious things or nuances, as you would like to call it, when you talk about pos fossa tumors. Many years ago, I remember when we used to do the operation with pos fossa, we always take off the bone completely. We do a craniectomy. We just drill the bone out. And for many reasons, because it's a small compartment, and sometimes people say, you give some space for swelling after surgery and so on. But these days, that is like almost out of the window. We always do a craniotomy, right? We determine where the transverse sinus is. We put a burr hole on each side of the tocula, and then you do a craniotomy all the way down to the foramen magnum, and you take it off as one piece, right? You take it off as one piece, and then once the operation is done, you're going to put the bone back. I think that is almost standard these days. Nobody does a craniectomy anymore, and I like to tie the bone. So once I lift the bone up, I will use a drill and I will make at least three points where I'm going to tie the bone, and I'll run my nylon sutures inside and hold them with an artery forceps on each side. I don't like to put plates for these patients. I don't put those titanium plates because they're young kids, and they tend to sometimes submerge and get absorbed into it. So I don't put titanium plates. I tie the bone with nylon. I mean, no doubt there's absorbable plates and all, but the absorbable plates are not like the easiest thing to use, I must say. So I stay away from them also. I tie the bone in place. And we almost, for us in our facility, navigation for oncology cases are almost standard. But when you talk about pos fossa tumors, there's a catch to navigation here, because most navigations register the face, because the face has got some contour there, and you use that to to register. I mean, earlier days they used to put fiducials. Nowadays, those are not there anymore. So you got some software to help with sort of a registering the head in a prone position, but the accuracy actually is not that great. So you got to be aware of this. You can do it. If you use if you use the Mayfield clamp and you clamp the head, you lift the table up, there is a way to register and get the thing. So these, now the reason why I don't use this very much, this is because we have got an intraoperative CT and MRI. So with those machines, what you can do is you flex the head as much as you want, you pin the head, you fix the head, you put your reference arc, do the scan, and you do an automatic registration. Right? So I don't have the problem of trying to register the face anymore. But in the earlier days, before we had all these facilities, I used to register the patient with the Mayfield clamp. Sorry, I clamp the head with the Mayfield clamp, and then I will lift up the table. I will reverse Trendelenburg the table, and then I'll use certain features in the face to try to register. And you can get some sort of register. I mean, the purpose I do that is so that I get an idea of where the sinuses are, and how lateral extent the tumor goes and all. I feel more comfortable using the navigation to give me an idea, particularly in the depths of things, and some tumors that are like a bit irregular. It gives me some confidence. So navigation for me is standard. And of course, there are two types of navigation, electromagnetic and light using infrared. And for the younger kids, exim is fantastic because you don't have to clamp the head. So you can move the head a little bit as you're doing the operation as well. Now, venous sinuses is something to really be cautious about in children, particularly younger kids, less than 2 years old. They'll have this aberrant sort of venous lakes in the dura. So when you do your V or Y incision of your dura to get to the middle, to the cerebellum, you might encounter some tremendous bleeding. And a child who's like 5 kg, you lose a cup of blood, is like you probably have to call off the operation already. So venous sinuses can be tricky sometimes. You got to be vigilant. You got to be careful. Get your Liga clip standby. And sometimes what I do is, as I cut, I will use the bipolar and grasp both the leaves of the dura to sort of burn them as I go. So that is something to be wary about in the pediatric age group. These venous sinuses that are random lakes all over the dura, it sometimes can be quite daunting when you encounter one of these. So in post-facet tumors, there are actually only two approaches you can think of. They are midline approaches, transvermian and the tilo-vilo approach. And all these hinges on the kind of location of the scan. There are loads of approaches for supratentorial, infratentorial, and sometimes you got to study the scan carefully and see the dissection the tumor has done for you. So you follow that as your guide. You got to mix both a little, a bit of this, a bit of that sometimes. But the crux of it is, if you can avoid cutting the vermis, by all means avoid it, but the thing about tilo-vilo is you got to be able to flex the head sufficiently to get that view. I mean, in the early days, I used to stand on the head end of the patient and operate. That means I flex the microscope looking down. But these days, I stand on the side of the patient. I find that with that, I can get a better angle onto the apex of the tumor. So again, all this is at your comfort level. But I've moved to now standing side by side, me on one side, assistant on the other side, and we look down. No more on the head end of the patient. And I do these operations prone, almost standard. I don't do the sitting position, which some people do. Simply because I'm comfortable and I'm less concerned about who my anesthetist is going to be. Because you're doing sitting position, you better make sure your anesthetist is well versed about all these things. And if you look at many of the medulloblastoma cases and all, you can see there's always a feeder coming from the pica artery. So if you can study that MRI closely, that the fine cut FSPGR or whatever sequence they call it in your hospital, which is actually T1 fine cuts with contrast, suddenly you can pick up these few vessels coming inside, and you can coagulate those vessels and disconnect it at the early phase. It might reduce the kind of bleeding intensity in some of these tumors. As you know, many of them are soft. So as you plunge into it, right, you got to get the job done as fast as you can, because you can't really stop any bleeders there. There are huge venous pools inside there. So that's another point you can do. You can take off some of these feeders much earlier. And you need to know a bit of anatomy here. I mean, you don't want to take off the entire pica, but you want to take off the feeders from the pica. And usually those that come into that area is pretty safe to be removed. Okay. And I mean, with this day and age in our facility, we have an IMRI to assess the extent of resection. So in children who are more than 2 years old, who can take the clamp, you see, for the MRI clamp, it's a different clamp, where you got to pin the head, and the Mayfield you pin and then you position. Whereas the MRI that we have is called a Nora's clamp. You got to maneuver the head to fit the clamp. The clamp is fixed on the bed. So that's a bit annoying. And when the child is less than 2 years old, I'm a bit wary because you need to keep the head in a flex posture. And if the pin moves during your craniotomy, it messes up your navigation big time. But I like to do the MRI for children more than 2 years old. Although any child who can take the clamp, I will do the MRI because I can do an intra-op MRI to make sure I've resected reasonable amount or remove everything before I close. So we have the facility. If you don't have it, it's fine. As you go on, right, you will find that you would know once you've resected everything, because in fact we have presented a paper on the intraoperative MRI, and sometimes we will close up and do the MRI because you're so sure you've taken everything out, because the whole process takes time. You got to drape the patient, cover the patient, take the patient to the scanner. All that in a way has got some risk as well behind it. So that's a discussion for another day. And after you open the dura, I know people describe closing the dura primarily, but I find that very hard to do because many times the dura will shrink. And so what I do is I will put an onlay synthetic dura of any kind. I do not take the fascia for this because it's another morbidity for no reason. And these days, I think the synthetic dura is fairly safe, even in this age group, because the fibroblasts do grow in there. And eventually, when we redo the operation, I find that I can't distinguish which is dura, which is synthetic dura. So the materials like Lyoplan, Duragen, they all incorporate eventually with the dura. Now, we quickly move on to the next one. So when you talk about pediatric neurosurgery, I like to advocate subspecialization really, because it's a challenging area, I must say. Even now, when I do operations, I do get a bit of anxiety in pediatrics, because if you get torrential hemorrhage, it is a bit, taxing. So by subspecializing, I mean, I know we all can't. What I mean by subspecializing in the early phase is just choose an area of interest and focus on it, because as time goes on, you will get better and better. I think the days of doing everything is almost gone these days, because you can't be good in everything. You can't be good in, I mean, I know Professor Misra is really good in everything, but I think his time, he had an exposure to doing all this. But sometimes you don't get the sufficient exposure depending on where you work. So you choose an area that you want and you subspecialize. It'll give you the competence in tissue handling. You'll find that the operation becomes shorter, there'll be less blood loss because you're anticipating so many things, you're used to it. And then you're familiar with the anatomy, which is so different from adults. The venous legs, like I said earlier, smaller structure, the consistency of the brain is different. So if you apply all that, the adult thing onto the peds, suddenly you might find that your retractor went right into it, just cut it like a cake. So, and we all know, when you talk about neurosurgery, the first operation is always the best. I mean, you've seen the previous presenters showed so many interesting cases. In the first go, many of them have taken out almost everything. And sometimes that first access is probably the most important, because the planes are there, you've got your landmarks to go by, there's no scar tissue, and you can really, focus and take everything out. So I think specialization will give you this sort of confidence with time. So there's something to think about. You do your bread and butter stuff, but 60-70% you focus on an area that you're interested in. And that will help with the whole operation, your comfort level, patient outcome, and so on. Now, I just like to touch a little bit on neuronavigation. I'm a fan of neuronavigation simply because it gives me that additional comfort. I don't have to just rely on landmarks. As we all know, right, landmarks can vary. Some people have got a short posterior fossa, some people have got a wider one, some people have got a steep tent. So the navigation takes away that intensity. You keep looking at the scan to decide, and sometimes when you flex the head, the entire anatomy changes. So with the navigation, it gives you that extra assurance. You know the trajectory you're going to go in. You can outline the tumor to get an idea, and then you can see where the transverse sinus is. So when you do your burr hole, you don't plunge right into it, and also shows you where your brain stem is and so on. So you can make your opening sufficiently. You don't make a long incision going right across up to C3 to beyond the inion. You can make it depending on that particular case that you're dealing with. You know the broad principles, and then you tailor it to that particular case that you're seeing. So navigation gives you that sort of confidence when you're doing the operation, and you can use navigation to sort of plan surgeries as well. I mean, this is a case of post fossa. I like to put it. I mean, you have the software these days. You know, you make your fine cut, and then you play with it. You move it around, see where your sinuses are. Are there dominant sinuses? You know, and how much the brainstem is squeezed. Is it in the ventricle, outside the ventricle? And then look at the feeders from the pica. You know, so I like to move it left, right. So this one not so important, but more the axial scan, right? As you're going up and down, as you can see here. Okay. Right. Okay. This just look at the coronal view on the right side. So you can get a surgical view on this one. You know, so you know when you go in there with one big vessel on the right. So you sort of prepare yourself for all these eventualities, because sometimes when you go in there, you see a real huge vessel there. You wonder whether I can take this or not. But if it's a tumor vessel, you know you can take it off. You know you can take it off up front rather than waiting until it ruptures, it bleeds. So you see you can do it in all three planes. And you can appraise, you know, what needs to be done and all that during surgery. So I think, and the beauty about this is you can also turn the head to make it look like how you're going to do it, you know, so that you get an impression of it before you start your operation. And I like all this because I feel in my mind I will tell, okay, now I flex the head this much. This is where the sinus is. I like to do some measurements as well to see how deep I'm going to go, particularly cases like this, because sometimes when you're in there, you think, are you at the brainstem already? Or are you not? You know, so all these things gives you a bit of impression, and you debug the tumor sufficiently, and then you go inferiorly and peel the tumor off the medulla and start moving upwards. That's the trick, not to plunge into the brainstem, because your medulla is more superficial, your midbrain is deeper, so you must be aware of that. They are not in the same plane. So you start by taking off, you debug the tumor first, and then you elevate it off the medulla, and then you start moving down. Then you know where the brain is. You can put a patty to protect the brainstem, and then you continue with your debugging, you know. And this is another, I mean, all these are brain lab softwares. You put it there. You know where the patient's head is, and you keep moving it up and down like that. I just want to show you one more thing before I move. I know this is a bit slow, this video. There's one more thing you can do with this software, and I like this also because you're seeing the skin, and then you're moving this in and out. You can, you know, you just have a look at this before I move to the next one. It's a bit slow, this one. What I like about this is this one. You see, it's amazing. You actually get to see, like, you know, how it looks like when you're operating, and you can play with this. So you can you know, tinker with this a little bit before you start operating. And I think it's helpful. It's helpful for many neurosurgeons. Okay, and the other good thing about navigation is this thing, microscopic navigation. You can navigate with your microscope, so that cross mark is telling you where you are. So what you saw earlier was exactly here, and these days you can inject that view onto one of your eyepieces. So this is what you're seeing, and that's where it is. So you will get an idea of your depth. You don't have to move your microscope and put the wand inside. So that's another microscopic navigation, we call it. Yeah, it's a good thing. And so that's with regards to surgery. And the other important thing when you talk about pediatric neuro-oncology, post-fossa tumors, even supratentorial, is multidisciplinary team meetings. Okay, and I will take some extracts from this article that we published recently. Now, MDT meetings are very, very useful for peds oncology because this word called residue, right? In my practice, after I do an operation, I will get an MRI scan within 48 hours, right? Of course, this is those that I don't do an intra-op. I mean, most of them, after I do the resection, I will do a scan in the theater. But for any reason I can't, because I did get my theater, I did it in another theater, I will do an MRI because I like to know, you know, what is residue, what is recurrence. we got to admit sometimes we can't take everything out, so there's no need to like to be like, embarrassed or anything, because some cases you can't take everything out. So you do the scan. And I like MDTs because if I just let my radiologist report the scan, they will call it residual tumor. And I don't like that, because the report does have a bearing on many things. I mean, the family will read the report. Even though I know this is not, but it's not tumor, it's just scar tissue, or it's some hemostatic agent. But once the radiologist reported it such, it goes on to the family, the insurance will look at it and all that. So it sticks. So I like MDTs to make the decisions. In the early phase, you see an enhancement. Is it residue? Is it blood products? And when we sit in a discussion like that, we can tell them, you know what, I'm very sure I saw that brain there. It cannot be a residue. It could be something else. And you look at T1 with contrast and without contrast, you get an idea. And then the later phase, whether it's recurrence, radiation changes, if the child had radiation. You see, like this child, right? Medulloblastoma operated, and you see this sort of enhancement, and you keep seeing it there. And some oncologists will say, go and take it out. And then if you took everything out and you're not too comfortable going in again, then you can discuss and keep an eye on things like this, because some of them are not really tumor. It's depending on the location. It could be other things. So I like engagements like this with in an MDT fashion, rather than just use it in your clinic, see the patient, and then they go to oncology. Oncology, I think the neurosurgeon didn't take out everything. And the coherence, right, gives the patient the trust in the system as well. Otherwise, they will hear oncologists running down the surgeon running down the oncologist. So, it's just too complex. So, and when you see a residue, you can engage and tell them, I did not take this because, this was beyond my sight. My approach only allowed me to take this much. I have to come up with a different approach to take this out, because not every time one approach takes everything out. You have to do like two approaches in certain cases, which goes beyond the two compartments. And sometimes it's the eloquent area that stopped you from doing it. If it's attached to vertebral artery, and the accessibility of it as well, right? Is it accessible or not? Whether you take it out. So with that, whether you wait and see, you go back again and excise it, or whether just go ahead with chemo and radio. Now it's even more tricky in tumors that are non-enhancing. Some of the cases that you see, the tumor looks almost like the white matter. Now those are very, very tricky. So during surgery, you got to really keep an eye, and intraoperative findings are equally important as a scan, because the radiologist might put a question mark and say this could be tumor, and then the oncologist will be very anxious and they keep asking you, do you want to go take it out? So if you've done it and you've taken everything out for a non-enhancing tumor, it's so helpful during MDT to state all this very clearly. And I also find it expedites treatment also, because in the past, when we request for a scan, the radiologist will say, it's all full, we can't get the scan. But in the MDT, they understand the urgency of cases, and I also understand their constraint when I go for MDT, because last time I used to say, like, we're operating and you're just doing a silly scan, why can you do the scan? But actually, they've got their constraints as well. So a bit of understanding takes place when you do an MDT. So I think that's a good thing. Okay, now this cannot be ignored, anesthesia. So when you're doing a case, you want somebody who knows how to manage a pediatric neuro-oncology surgery, particularly infants and neonates. This is probably the high stress operation for me, because you've got like a narrow window and you got to capture it and do it well. Your approaches are important. You got to go periphery, devascularize. So navigation helps here, because you can go in the right corridor, devascularize it and go in. And the anesthetist has to be comfortable with the warmer, the airway. When you flex the neck, if it just goes a little bit deeper, you get unilateral ventilation, hemodynamic control, IV lines, central lines sometime, and the blood products have to go in at the right time. So all these things are important. If you just keep giving blood, it's not sufficient. You lose a lot of blood. You have to give your blood products as well, platelets, FFP, and so on. So I won't downplay this one, very important. So to conclude, right, we talk about nuances and pearls in posterior fossa operation. I think you got to study the scan very carefully to get as much information as you can before you plunge into the operation. MDTs are usually post-operative, but certain cases like pineal region and all, we do it before even we operate, because things have changed so much these days. Some of the cases don't need operation. The CSF will give you an answer, and they will say biopsy, give us a result. So sometimes it's good to engage with them as well, because things are changing at a very rapid pace when you talk about pediatric neuro-oncology. And for intraop, I would advocate some degree of subspecialization, and to hone in on certain skills that are unique to pediatric neurosurgery. Navigation for me, it's like I won't call it standard, but almost a standard for brain tumor surgery. And anesthesia. Anesthesia is very important, even though we are not dealing with it, but I find it goes hand in hand when you talk about pediatric neurosurgery. Thank you very much to the audience and to the
Thank you.
organizers.
Thank you, Prof. Dharmendra, for enlightening us with your talk. I think we are running short of time. So let's invite our next speaker, Prof. Catherine Drummond. She's the Director of Neurosurgery at the Royal Melbourne Hospital and Head of CNS Tumor of the VCCC Parkview Crisis. She has her special clinical interest in neuro-oncology for the biology and management of brain tumor. Prof has more than 150 peer-reviewed papers and more than 20 million of grant funding for his studies. And thus, without further delay, we invite Prof. Kat for his topic, quality of life in brain tumor. Welcome, Prof.
Hi, can you hear me and see my slides?
Yes.
Great. Okay. So thank you, AASNS, so much for inviting me to speak today. And I guess we've heard some really great talks on techniques in brain tumor surgery. So I'm going to talk a little bit more now about something that's as important as technique, which is the outcome in terms of the quality of life of patients after they've had the surgery. Now I'm an adult neurosurgeon, but AASNS tells me that it's fine that I'm speaking as an adult neurosurgeon in this forum. And so I'm going to talk a little bit about quality of life in brain tumours. This work, I'll just show you, this is where I work at Royal Melbourne Hospital, which is the large old falling down hospital in the middle here, surrounded by the brand new cancer centre, the Women's Hospital, the University of Melbourne's over here, and the Children's Hospital's down the road. So it's really this kind of biomedical precinct that allows this sorts of research to be undertaken. So before you understand quality of life, you need to understand the definition of health. And the WHO says it's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So probably nobody who's listening to this talk today is completely healthy. We've all got a headache or a hangnail or gallstones or something that's making us not entirely healthy. So none of us are completely healthy, but when we're talking about health-related quality of life, we're talking about the effect on your physical, emotional, and social components of quality of life associated with an illness and its treatment. And the most important thing is it's self-assessed. So it's not what the doctor thinks is happening with the patient, it's what the patient feels is happening with themselves. And it's become an important endpoint in many studies. So health-related quality of life for glioma studies, particularly also, but for things like vestibular schwannoma, for meningioma, health-related quality of life become an important endpoint. And we know that it's multifactorial. There are tumour factors, treatment factors, and patient factors, and they all impact on quality of life. So I thought there were a couple of things that informed me wanting to research health-related quality of life. The first was that most patients don't fit into the study. So most patients are not, most of the studies are, let's compare this treatment and this treatment, or let's look at this surgical technique or this surgical technique. It doesn't include people of a certain age. It doesn't include everybody. So most of the studies about quality of life don't really tell us what's happening with our patients. And another thing that I really noticed, and I'm sure all of you as neurosurgeons will have noticed, was that some patients who were surgically cured, had their acoustic neuroma removed, really felt miserable, thought their quality of life was terrible. They're dizzy, their balance is terrible, they have headache. And some patients, with pretty awful diseases like low-grade glioma were actually quite cheerful and had good health-related quality of life. So I felt I didn't really understand it. So we started in 2013 on a program of research. We've now got more than 1,000 patients in our database. And our questions were, what are the determinants of impaired health-related quality of life? And I chose meningioma, acoustic neuroma, and low-grade glioma to study because they are a mix of surgically curable tumours and also a parenchymal tumour that was not surgically curable, but all of them associated with long enough survival that we could really test out their health-related quality of life over a long period of time. So what are the determinants that impair your health-related quality of life? Are there longitudinal changes in health-related quality of life for these patients? Do they get better? Do they get worse? And what interventions might be able to improve health-related quality of life? So basically, what are the actionable determinants? I wasn't really looking to see, well, are tumours on the left side or the right side, or bigger tumours or smaller tumours associated with worse quality of life, because I can't do anything about that. It was what sort of things could we change for our patients that might improve their quality of life outcomes. So we started basically with an army of medical students who went out to the waiting room in our neuro-oncology multidisciplinary clinic. So a single centre prospective longitudinal evaluation of health-related quality of life in basically a convenience sample. All of the patients who we've operated on who are sitting in the waiting room of our clinic. And that says 7 years, but it's now 8 years that we've been following these patients. And we use 2 validated quality of life questionnaires, the QLQ-C30 and the QLQ-BN20, one a general cancer and one a brain tumour quality of life instrument. And we took a good medical and social history as well. Why did we choose the QLQ-C30? Well, largely because there's a baseline. So there's a European reference population of more than 16,000 patients who are healthy controls to tell us what health-related quality of life should be in a normal population using this instrument. And basically, it's a 30-question instrument, one looking at global quality of life, 5 functional scales, physical, role, emotional, cognitive, and social, a number of symptom scales that are common for patients with cancer. And then the BN20 really looks at other symptoms that are more common for patients with brain tumours, particularly neurological deficits, future uncertainty, stuff like that. So we started just asking, every time we saw a patient, we'd ask them to fill these out, scored by the patient 1 to 4 or 1 to 7 on a Likert scale, which was sort of, a lot to not at all. And it was transformed using a standard algorithm to a score out of 100, which for the functional scales, the lower the score, the worse the quality of life. For the symptom scales, the higher the score, the worse the symptoms, the worse the quality of life. So, and we took a medical and social history. So what did we find out? Well, we found out, and we found out some interesting things. So this is 619 patients, but the additional patients that we've added haven't changed these numbers. We found that overall, if you look here, so green is the normal population, red is all tumours, purple is acoustic neuromas, yellow meningiomas, and green low-grade gliomas. In fact, their health-related quality of life compared to the normal population for their global quality of life is not much worse than not as bad as what you might think it is. And although it's statistically significant, these small asterisks, you have to be at least 10 points different for it to be clinically meaningful. So no clinically meaningful difference there. And for physical health-related quality of life, interestingly, not much difference at all. But there is quite a difference for things like role function, emotional function, particularly cognitive function. So these patients feel that their brain is not working, and also for their social function, which I guess is probably not surprising. So both a statistically significant, but also in many cases, remembering it's about 10 points, a clinically significant difference, particularly cognitive and social function. And what did we find were the determinants of health-related quality of life? Well, poor global health-related quality of life is particularly associated with poor subjective cognition. If you think your brain's not working, you're going to feel you've got poor quality of life. And the things that were associated with it were unemployment, inability to drive, being single, having recent seizures, being female, being younger for your social quality of life, and being older for your physical quality of life, and anti-epileptic use. And your poor subjective cognition was associated with neurological deficit, obviously, but also things like fatigue, future uncertainty, which is anxiety, pain, sleep disturbance, and seizures or anti-epileptic use. And I've put in red there the things that we might be able to treat in our multidisciplinary clinic. We don't really help patients get back to work. We don't help them manage their fatigue. We're not very good at managing depression or anxiety or checking for pain or even managing their sleep disturbance. And we might not even be very good at managing their epileptic drugs or thinking, could there be a better drug or could we manage their seizures better? I don't put red there, single, because I don't think I'm going to start a dating or marriage agency in my clinic. But other than that, all of these things are things that we might be able to action as being important for these patients' quality of life. So that's what we found at baseline. But what about longitudinally? Well, if we watch these patients longitudinally, and we've published this for meningioma, we can see here, as we know, these are just the domains of quality of life, and we can see that there are reductions for patients with meningioma, including for cognitive function, even those with small 2-centimetre convexity meningiomas. But if we watch over time, these deficits stay for up to 120 months. So global quality of life, emotional quality of life, cognitive function, over 120 months that the patient still feels that their brain is not working properly, where the grey here is the normal population, the dotted line is the clinically meaningful difference, that 10-point difference, and then this is the meningioma of population, social function, and continued fatigue and sleeplessness. So this isn't just something that happens in the first 6 months. So, and we found that time since surgery was not associated in any way with their global health-related quality of life or any of their functional or symptom domains. So people don't get better over time. We've done the same study with low-grade gliomas and found the same thing. This is low-grade gliomas have slightly worse health-related quality of life, as you'd expect from meningiomas, but we've been watching these patients over 120 months on this study, where the orange is normal, the grey is the minimal clinically important difference, that 10-point difference that the patient notices, and blue are the low-grade glioma patients. Long-term changes in emotional, cognitive, social function, sleep, and fatigue. So what is it going wrong with the cognitive function here? This is a really interesting question. So we did look at the patients, what they scored themselves with cognitive function with their mini mental state test. Remembering that anything over 24 is considered normal for mini mental state. So this is the patient's own assessment of their cognitive function versus our assessment of their mini mental state exam. And we found really interesting things. So a lot of patients scored in the normal range, knowing that about 85 is what is normal for a healthy population. But we had some patients who scored themselves pretty poorly as in their cognitive function, yet were normal on an MMSE, and some patients who scored themselves as like this, scoring 0 for cognitive function and yet normal on the MMSE. So what was happening here? Clearly there's a disconnect. So we decided, well, the MMSE might not be the best of all tests that we can use. So we tried this online CogState neuropsychological battery, where we again got the patients to both do this objective neuropsychological battery and also put it against their assessment of their own cognition. And just for interest of time, I'll move on here and show you that even though we did a very good objective assessment of their cognition, this was not concordant with what the patients felt their cognition was. So here we've got what the normal score for CogState was. Everyone should get 90 to 110 within that range. So most people scored completely normally, a few people a little low. 90 is about what the reference population would score themselves. And here we've got this whole group of patients, many of whom are meningioma patients, cured surgically, who say that their cognition is terrible, and yet they score themselves in the normal range. And then we had another group of mixed patients here who, again, score themselves very poorly and yet fall within the normal range. So why do these patients think they're doing so badly? Well, when we tested them with a hospital anxiety and depression scale, we found that there was no correlation between their assessment of their own cognitive function and their objective neuropsychological score, but there was a really great correlation between their global quality of life and their cognitive function score. So we could see that. But then when we tested it against their anxiety and depression, there's a very good correlation between their perception of their cognition and their hospital anxiety and depression score, both for anxiety and for depression. So it kind of shows us that patients have poor quality of life because they feel that their brain's not working. But it's actually not that their brain's working as badly as they think. And often just letting them know that helps, but also because they have anxiety or depression, and that can be treated, and that would improve their overall quality of life and their perception of their cognition. So we've done multiple sub-studies. I've just given you a little taste of what we've done so far, but these are our conclusions so far. Of course, health-related quality of life in brain tumour patients is significantly impaired, but it can be counterintuitive to clinical expectations. Patients who are surgically cured with a small meningioma can feel they have very poor health-related quality of life. And we need to look beyond what their MRI scan looks like and whether the patient can talk and walk to decide what their quality of life is like. We need to be more nuanced than that. Impairments are clinically significant and they're sustained. They don't get better in the first 6 months or 12 months. So we need to be thinking about how can we interact early to improve these patients' quality of life over time, particularly their cognition, their sleep, their emotional functioning, their anxiety and depression, their social functioning and their fatigue, things that we don't normally treat in our clinics. Symptom burden like anxiety, depression, and we suspect fatigue and probably also epilepsy significantly affects how people feel that their brain is working. It doesn't matter whether it's objective or not, it's subjective, and it's very disabling. There are important determinants of health-related quality of life which we don't address clinically, but may significantly improve health-related quality of life, and we need to do this for our patients. But we need to rigorously test any strategies that we start, and I'm going to talk about that a little bit later in one of my other talks. And we need to find ways to identify and predict those that most need help, and I'll also mention that in one of my later talks. And one of the things that I am going to talk about is that online interventions, things that are cheap and don't involve a lot of personnel, seem quite promising. So I'll let you know later what are the next steps, because I've got another talk later. You've already heard about this Jerusalem meeting, but you must come. It's going to be a fantastic meeting, and everyone should go to Jerusalem at least once in their life, if not 2, 3, 4, or 5, maybe 7 times like me. And thank you very much for listening.
Thank you. Thank you, Prof. Catherine, for your fantastic talk. So I would like to pass the mic to Dr. Donna Liu for the Q&A session. Thank you.
Hi. This is actually a very interesting talks that we had, and I think it's very informative. And Prof. Xiao, haven't seen you for a while. Was his registrar almost 20 years ago, working in Singapore. Now, I think there's a question to Prof. Xiao first. You said in a transcranial suprasellar surgery, do you always arrange for frozen section, for most of your cases? And in case that it turns out to be germinoma, do you stop the surgery, or do you actually proceed with the tumor debulking and excision?
Okay, so we always get this this frozen section, because I think it's definitely very useful. Only maybe on a weekend, sometimes you can't get a pathologist, but usually on most elective days or semi-elective days, we will be able to get a pathologist. And yeah, I think if we get the histology comes back, it's a germinoma, we'll stop. I mean, of course, you have to, make sure that there's hemostasis, everything goes well. But I would stop just taking out any more tumor, because this tumor is going to disappear with the chemotherapy and radiotherapy.
Yeah. So there's another question. When you are talking about craniopharyngioma, I think there's a question for you. In the case of recurrent craniopharyngioma, what would be your criteria in subjecting the patient for resurgery?
I think so. So it comes back to the point: what is your aim of surgery? So I think if the patient is losing
visual field and you know there's compression or optic chiasma, you need to go and decompress. But I think if you're seeing just tumor enlarging, depends on the size. You may need to go and debulk, but I would not go and try to do a complete resection, because especially if it's the third ventricle, you know you're going to cause problems for the kid. But you might need to go and debulk it and then send a patient for radiotherapy if it's not already done so. But I think the issue will come when they have radiotherapy already, they can't get any more radiotherapy. What are you going to do?
Right.
I guess the same thing, because most of these recurrent craniopharyngiomas, actually, you may not be able to take everything out. And that's where you now start to think about, what else can you do? And I think the area where there's targeted therapy is important. Unfortunately, I think for the adenomatous craniopharyngioma, the type you see in children, I mean, there are some new target therapy, but they're not as well, utilized and therefore well reported compared to, say, the breath inhibitors that you can use for the papillary craniopharyngiomas.
Right. Okay. I think I have a few questions for Professor Misra as well. As usual, I think Prof. Misra's talk has been very informative, and it's actually inspiring for a lot of young surgeons as well. Now, Prof, when you are actually embarking on a transcortical, let's say you choose a transcortical route, do you actually see increased risk of seizures postoperatively for the patient?
Yeah, well, that's I can't give you a statistics because we have really not analyzed, but I can tell you that today the type of cortical sections we do for reaching there is about, even in a microsurgical thing, it's never more than 2 centimeters, and you avoid the veins. The critical thing to my mind is avoid veins and go not damage. You can go for a transsulcal route, or even if you take off a little bit of middle frontal gyrus. I don't think we haven't had a problem with this with epilepsy. But having said that, all these patients are covered with anti-epileptics perioperatively. So we continue with anti-epileptic for transcortical incision about 6 weeks post-surgery, and then we reduce it. And we start the anti-epileptics about a couple of days before, or load it during surgery if you're going to do a transcortical, which has not been planned before. Transcallosal, we don't give perioperative anticonvulsant. We don't use it. So that is the difference. But I don't think if you do a very minimally invasive lesion in the cortex, less than 2 centimeter, 1.5 centimeter, as long as you are not compromising in the veins, they have a problem. So as I said previously, maybe 10 years back, I was much more dogmatic because I was always trying to do transcallosal, which is sometimes extremely difficult if the venous anatomy is not, kind of suitable for that approach. But today, I'm more liberal to move over to transcortical approach if the venous anatomy is not suitable for the intravascular approach.
So for a very large, ventricular tumor, when we actually look at it, and we know that it's going to be very, very vascular with a lot of, big vessels. So what is your advice for people who are actually embarking on this sort of surgery? Would interventional will actually help in those cases?
Well, these nearly 400 cases I showed you, with not a single patient has had intervention. Endovascular intervention, I think you were talking about embolization, yes, correct? Yeah, not a single patient had endovascular. Third ventricular tumor, these are small compartments, so they're really not, except very highly malignant. Sometimes ependymoma could be vascular, and sometimes it's not the blood loss, but it is the clouding of the compartment and your difficulty getting into the compartment, blood in the ventricles. That's the problem, not because of bleeding. The problem is lateral ventricular, and especially small children. And I showed you 2 giant ependymomas. Both the patients, actually, pediatric neurosurgeons had a go at them, and they had to back out because of the blood loss. The child, they thought it was unsafe to continue with the surgery, which removed. So I think the key to lateral ventricular tumors could be risky, and you can have a major problem because of blood loss. Some of these problems, both in adults and in children. What I do is a very fast debulking. You go very rapidly. You reduce the bulk of the disease, and the faster you do it, the better it is. You try to do hemostasis at all the time, it's a miserable thing. So initial days, that was my problem when I was starting my career for a young neurosurgeon. That's a problem because every time we see bleed, and especially in a deep compartment in the ventricle, you are away from the surface. So you are worried. You are trying to achieve hemostasis and all the time. Don't do it. Biggest action: do as fast decompression as possible. Only take the large vessels, and the small vessels, don't worry about it. And one of the things which we do to prevent post-operative hydrocephalus and adhesions is, you do everywhere around the operative field, we put patties so that the blood doesn't go into the compartments. And then at the end of surgery, we use an endoscope to find out and suck out all the clots from the compartments where we cannot reach by microscope. For the trigone, the occipital horn, sometimes going into the temporal horn, we can suck it out because the clot is there, which is sitting there. It's not blood; it's just a blood clot, and that endoscope is a very useful help to prevent post-operative hydrocephalus need for shunt.
It's an excellent advice for people who are actually tackling this type of tumor. I have a question for Prof. Dharmendra from Gove, working in Sarawak here. In case of a pineal region a tumor, let's say knowing it to be a germ cell tumor, how would you advocate the approach between ETV shunt plus biopsy, followed by radiotherapy and chemotherapy versus post-fossa surgical resection, which I think most of us try to avoid shunts, and then followed by the adjuvant therapy. So what is your take on it?
When you talk about pineal region tumor, right? Whenever I see a case like that, the first thing I do is serum alpha fetoprotein beta ECG. If I get the markers to be high, the patient goes straight to the oncologist. But if those markers are normal, then I study the scan a little bit more. If there is hydrocephalus and the lesion is sort of protruding towards the third ventricle, then I would do third ventriculostomy together with a biopsy. You may have to use 2 holes, again, depending on the location of the lesion. Because if you are wanting to do it with one single burr hole, I think you're asking for trouble there because of the venous structures. And sometimes the foramen Monro is not big enough to take that manipulation of the rigid scope. So if tissue diagnosis is required, I'll never operate on a pineal region. I always do a biopsy first. And if the biopsy comes back as a pinealoblastoma, then I do a bigger operation. So if the markers are negative and the patient needs diversion, it'll be an endoscopic. I use navigation to determine the trajectory, because your points you're looking at is the skull, which is a fixed point. The next point is a foramen Monro, and the third point is a tumor. So all that must be aligned. So I may use 2 trajectories. The biopsy usually is a bit more on the frontal side, just below the hairline sometimes, but I've got no issues cutting the forehead for a biopsy because it's safer to do that rather than coming at the standard point to try to manipulate the scope. So I will do an endoscopic biopsy in a case like this with a diversion. Now, certain cases, they don't actually come to the front at all, right? And they perhaps don't even need diversion. In cases like that, I will use a stereotactic needle biopsy. I will come in from either frontal or sometimes even temporal, depending on the location, and I use the navigation as a guide to take me there. Of course, needle biopsies, you get better tissue sometimes, you get a thicker tissue, safer. Endoscopic biopsy, sometimes can be fraught with a bit of bleeding and all, but it's, you get decent amount of yield, but negative yield for an endoscopic biopsy can be 30% sometimes, whereas a stereotactic biopsy, it's almost 90 to 95%. So these are the options, either a stereotactic biopsy, endoscopic biopsy with diversion, is in a case-to-case basis. I hope that answers the question.
I think Go was asking is because I think quite a lot of the germ cell tumors in the pineal region when we actually excised and histology came back and say that it is actually quite often it is actually mixed type. So eventually you probably need surgery. So would you actually advocate that we actually go in and excise it? Because most of the time after excising it, we don't actually have to shunt the patient anyway. So would you actually advocate that, or do you still think that we'll just do a biopsy instead?
No, I cannot make a case to go and excise a lesion like that. Morbidity is just way too high. I would always advocate a biopsy first, because there's a substantial amount of cases that don't need an operation, because your risk of a bad outcome there is a bit more higher than a supratentorial tumor. So I tend to biopsy first. I wouldn't go for an excision upfront.
Okay, thanks.
Can I give an opinion on that?
Yeah,
I think for pineal tumors, we usually would do a ETV and endoscopic biopsy, but there's a possibility that, and then they go for, and most of the time actually you are going to get a geminoma, right? Because that's the one that doesn't have markers. But possible that this is actually part of a mixed germ cell tumor. So you have maybe the geminoma plus a dermoid, the dermoid cyst, or what they call teratoma. And so basically, then the patient actually goes, because you've got a biopsy, it's a germ cell tumor, it goes for the usual chemotherapy, radiotherapy, and then you look at your follow-up, and then you might see that there's a random tumor, and then it's starting to grow. And actually, then you do what we call second look surgery. And usually that's for teratoma. So you actually do that later. But I know that some of our Japanese colleagues, because I think the incidence of teratoma is actually quite high in some of those places, and they're looking at the consistency of the tumor on the MRI, and even with CT scan, if you see calcification, if you see other things that are fat and things like that, it probably is a teratoma, and they may actually go straight in and do the surgery. So I think it all depends on the radiology, and then whether you also follow the protocol or things like that.
Right.
Can I make a comment, please? This is Mr. here.
Yeah.
So for the pineal, we try to avoid stereotactic biopsy. One of the principles, you do not go breach two layers of the CSF membranes. So in fact, there are enough studies to suggest that stereotactic biopsy is higher risk of risks of bleeding and things like that. So we would do a endoscopic biopsy, and as both the Dr. Ganeshan and Dr. Wantu said, our preferred mode is endoscopic third ventriculostomy and a biopsy, endoscopic biopsy. And sometimes you may need two burr holes to do a biopsy, two-hole technique. But we have been avoiding a stereotactic biopsy for the posterior third ventricular lesions because of the risk of injury to the large vessels, venous system. And while I'm here, I just wanted to make two comments about Dr. Ganesh and talk. Very, very nice, very eloquent talk with good advice. But just for the young neurosurgeons who are in developing countries and countries where the state of the art which he has may not be available, I would like to tell them that don't get disheartened. These are good things, having a MRI, playing around with the images in the posterior fossa. I've been doing image guidance since '97, so it's almost very, very long time. But today I hardly use image guidance for posterior fossa lesions. For ependymoma, for medulloblastoma, I don't think I have used it for. I have never used it, except in pilocytic astrocytomas, which are laterally placed, sometimes small lesions in the depth. Yes, we use this. Hemangioblastoma, which is useful sometimes, small lesions, we use it. For midline lesions, the anatomy is so constant. This is a luxury which you can use it, good pictures, good slides, but I don't think it would make a huge difference. So that's one comment. Nothing to what Dr. Ganeshan said. I'm not disagreeing with that, but for the young neurosurgeons, it's not necessary for you to have a good surgical outcome. So I think that is something that they should not get disheartened. You don't have intra-op MRI, you don't have neuronavigation to high-tech things. It's still possible to do very good surgery. The one other thing which I have a little different way of doing it is what Dr. Ganeshan said about putting the endoscopic third ventriculostomy upfront, all different patients, so the posterior lesions. The problem in countries like mine and some other Asian countries is many of these patients pay for the surgery from their pocket. So when you do two surgery, it costs them a significant amount of discomfort. So routinely we don't do it. As he said, we sometimes tap the ventricle while we are doing it to relax the posterior fossa before I open the dura, and that sometimes is enough. And if there was a concern, I would leave the tube intraventricular without connecting, just keep it with a clip and be there with another dressing there in case there is a need for opening it up. Once you have opened up, especially the medulloblastoma, the ependymomas, with the need for a shunt in my practice is very, very low. But malignant tumors, of course, is the infiltration, CSF spread and all that, that's a different ball game altogether. But so these are the two things which I would like to emphasize for young neurosurgeons, especially in developing countries. Don't get disheartened. And in my practice, there are many ways of doing the same thing. So I don't do the routinely endoscopic third ventriculostomy if I think I can do a radical total excision in the posterior fossa masses. Thank you.
Thank you. For Prof. Kit Drummond, I'm actually very interested in your talk is because I think a lot of people have actually forgotten that we're treating the patients to actually return them to the best quality of life, you know. So we think that by the time that we remove the lesions and we are actually quite satisfied with ourselves, but not thinking what's wrong, you know, with the patient. I know that I'm also adult surgeons doing some pediatric work, you know, not like the those subspecialists doing it. I always have a problem with patients that have actually been treated, especially now we see a long-term survival for medulloblastoma now. I have quite a lot of my patients is now surviving more than 10 years. And the biggest issues that we have is I think they are actually frozen in time, you know. So if they came to us in when they are 7 or 8 years old, that's probably how they are going to look, you know, now in their early 20s, you know. And so we have an issue of you know, trying to see whether we can actually get the endocrinologist to actually, you know, start the patient on growth hormone and things like that, because they are very, very concerned about you know, a tumor recurrence. So what's your take on that? You know, for this sort of patients, and where do we start to actually engage, you know, those people? You know?
So I think yeah, the main thing is to pay attention. You know, most of the time we don't really think about it. So I'm very lucky in that we have what's called a late effects clinic at Peter MacCallum Cancer Hospital, and they do a fantastic job of, you know, these adult graduates of pediatric brain tumours, everything from, you know, the second tumours, the cognitive problems, the endocrine problems. So luckily, you know, they have this great, fantastic multidisciplinary clinic. But even for the patients who are less affected, you know, I think the main thing is that we need to start thinking about, it's very simple to measure someone's quality of life and to have a look at what problems they're having, and then start thinking about how you might be able to intervene. So a very simple example, fatigue is a massive problem in anyone who's been treated for any sort of a brain tumor or any sort of cancer. There are a lot of interventions that you can do for a fatigued patient or a patient who can't sleep that are validated and that don't even cost a lot of money. But if we don't ask, nobody does anything about it. So I actually think that the most important thing is to start thinking, and we didn't start all at once. We didn't suddenly have this massive clinic that we, you know, we sort of bolted on a psychologist, and then we got a bit of a psychiatrist, and then, you know, we got a care coordinator, and we got some medical students who do the testing. So it's all about just starting small and, you know, starting to think about it, pay attention, and then think what you can do about it. It's not complicated.
Right. So in terms of you know, assessing them, do you think that the you know, just looking at just mini mental state to start with will be adequate for most of the patient? Or?
Well, I think the first thing is to do the quality of life questionnaires and see which areas they're interested in. But then, it's very expensive to send patients off for full neuropsychological assessment. If you've got that luxury, that's great. But if you don't, then you could do some of the online testing, which is very, very simple and very straightforward, or even use something as simple as a mini mental state. And it's not perfect, but the number of times that we've got our patients who say, oh, my brain's terrible. I always forget my keys. I forget this, I forget that. Like, I can't concentrate. I can't do this. My life is awful. And we work out that actually what they have is fatigue and anxiety. And when we test them on their online neuropsychological battery, they actually score within the normal range. Just telling the patient that is enormously empowering for the patient, because they go away. They can manage their anxiety. They can help manage their fatigue. They can do simple things, and they're reassured that, yes, their brain will keep working and carry them through the rest of their life. It really makes a big difference.
I think this is the part of our care, of tumor patients that we should actually improve. So thank you very much for all the the speakers, and it's really enjoyable. I have a lot of questions, but we'll probably reserve it when I see you guys next time. Thank you very much for giving us a talk, this afternoon.
And we move to the most important session, photo of the session. So we will document every end of session. So we need all the moderators, speakers especially, and those who the panelists who can join. So you ready, Nazlin?
Yes.
Okay, just count on you. Just let us know.
Okay, so
very quick.
Get your cameras on. Right. Okay, so on a count of 1, 2, 3. 1, 2, 3. Brilliant. Thank you.
All right. Thank you very much.
Thanks,
Great
Sarah.
session, but we have to move on.
Okay. So thank you to our speakers for a brilliant session, and thank you, Dr. Donald and Dr. Patrick. We shall now proceed to the last session for the day. I would like to invite moderators, Dr. Muhammad Azman bin Muhammad Rafiq and Dr. Lee Shu Yi. Dr. Azman and Dr. Shu Yi, the floor is yours.
Thank you, Ms. MC. Good afternoon, everyone. Welcome to our second session of neuro-oncology. This is our final session for today. I'm sure it has been a long day for everyone, but don't worry. We have a few very interesting presentation upcoming. In our session, we have we have a total of 5 speakers. We are very blessed that today we have speakers from as near as KL and as far as Australia and Israel. In view of our time constraint, we will have our Q&A at the end. Please feel free to drop your questions into the Q&A box. Please include the name of the speaker you would like to direct the question to. So our first speaker is none other than our esteemed consultant, neurosurgeon and head of department, Hospital Sungai Buloh, and head of Neurosurgical Services, Malaysia, Dr. Azmin Khas Rosman. Dr. Azmin obtained his MBBS from University Malaya and did his postgraduate school diploma in neurosurgery at Catholic University Leuven. Dr. Azmin has a special interest in neurovascular and interventional neuroradiology radiosurgery. He is also an examiner for USM Neurosurgery Master Entrance and Exit exams. In fact, he was one of my examiner during my exam. Dr. Azmin is the first neurosurgeon that established our first brain suit in Malaysia at Hospital Sungai Buloh back in 2009. With that, I'm sure he's the best person to share his brain suit experience. Who else better than straight from the horse's mouth? Dato', the floor is all yours.
Thank you very much, Shirley. Thank you, Mr. Azmi and the organizing committee for the invitation. I suppose if had we been in a conference room, most of the people have gone for a coffee break now, and this is quite a very light topic for all the participants. And but nevertheless, I would like to share my experience being a senior surgeon in the Ministry of Health. I started in 1988 working in Hospital Kuala Lumpur, and in 1996 I went to Hospital Penang to take care of the northern area of Malaysia, the Penang, Kedah, Perlis, and Northern Perak, which is what was about the size of Belgium actually. Only one neurosurgeon, and I do about 600 cases of per year with my 3 medical officers, with a budget of about $50,000 US, about 200,000 ringgit. So as you can see, I wasn't born with a silver spoon in neurosurgery, and I had to learn through tough times. I had to learn through everything, the small things, the big things, and go through all the problems. I had no one to consult with, and my only supervisors were my books and my memories of how to operate when I was in training in Europe. So as time goes by, you build your confidence, you make your own decisions, and you learn to be careful in every decision you make, and respect the patient. And as long as you have intention in your heart that you want to take care of the patient, that's the most important thing. And to have the best outcome, I think you wouldn't go wrong. So okay, hang on, yeah, just. Do you see that? Do you see this everything at the side is as well?
Slideshow, yes. On your upper cursor.
Yeah.
After review, yes, slideshow. Left to review.
This one, huh?
Yes, okay.
Dato', you can click on the bottom right.
Bottom right.
Bottom right most.
Hang on,
There's yeah.
Right, bottom right. Here, no. Minimize this one first.
Yeah, you have to bring your cursor down.
Yeah.
Okay, and then yes, the bottom right, there will be like a photo of to run your slideshow. The one just next to Zoom. Zooming in and zooming out. Yeah.
Run my slideshow.
Bukan.
Normally mine is here at the top here, but I think keep on coming down actually. I don't know why.
It's at the bottom. Okay. At the bottom, there's notes and comments. You just slide next to it. Okay, your cursor is different.
No.
Yep. Notes, comments next to it.
Okay.
Next to it. Okay, next to it. Okay, some more.
This one.
Okay, that one, slideshow. Yes, click on that one. Okay.
All right. Okay. So this is the hospital. My brain suite experience, a hybrid surgery, hybrid journey for the last 10 years. And at the time when we started the neurosurgery for neurosurgery, when I wanted to request for a brain suite for neurosurgery in Sungai Buloh, there was only a brain suite in Singapore, 2007, one in Australia, and in Japan, 2008 and 2009 in China. And in 2010, there were only 56 hybrid operating rooms in the world. Now, last year, 2020, there's about 180 MRI and 50 CT ORs in mostly North America and Europe, and the rest are in the rest of the world. In Malaysia, we have one in Sungai Buloh Hospital. Then subsequently, we had one in Johor Bahru and one in Kuching, and one is in Putrajaya at the moment. But that is MRI, intraoperative MRI, which has been shared with the diagnostic and an operative. And we hope to have another one in Kota Kinabalu and perhaps Penang in the near future. So we always hear the few words about hybrid OR and integrated OR and digital OR. So a hybrid OR is a surgical room that's equipped with advanced imaging or interventional devices such as fixed C-arms, CT, or MRI scanners. So a hybrid OR is a functional operating room integrated with an imaging device for the surgical table. So it gives a real-time imaging guidance. So we also have integrated OR where all the information of the videos is integrated in the room, and it becomes a digital OR where the information of the room or the operating room is being shared, two-way sharing with the PACS system of the hospital. So it brings together a constellation of the best in surgical imaging and interventional technologies. Technology allows us to explore and push the boundaries of conventional day practice. So it allows you to do more complex cases, and it gives you excellent pre, intra, and post-procedural imaging. It enhances patient safety and has an efficient workflow, and is time and less consuming because you tend to be more confident in what you're doing because you tend to know where the anatomy of the patient. The convergence of patients' needs and technology, the growth of minimal invasive surgery, and it's patient-oriented and the boundaries disappearing between the disciplines. So it's no longer a hybrid operating theater. It not only can be used by the neuroscience, it can be used by the orthopedic department and by the spine surgeons. And of course, it has always been used by the cardiologists. They've always been using it for the catheterization. So there's always it's a good maximum utilization of space for imaging and operation. It increases flexibility, you get fewer complications, and you have better outcome and a lower cost. So of course, you have the initial investment is quite expensive. It may look like a shiny new toy that every specialist wants, but it may be an essential investment in the future. It ranges between the $3 to $7 million. And of course, the cost varies between the site preparation, the different medical devices, and the different imaging equipment. Hospital executives who want to offer competitive surgical care in terms of both quality and cost should have a hybrid OR, or at least plan one for the future. You have different types of operating ORs. You have hybrid angio, this is, as I mentioned, that should be used by the cardiologists. And you have the hybrid CT, which we have in the government. And we will be having, because we're dealing with the one in the intraoperative MRI in Putrajaya. So this is a hybrid MRI. Of course, we opted initially for the CT intraoperative CT because of the ease of use. MRI is people have to be highly disciplined for MRIs because of the danger of the magnet. And you also can, there's a different types of hybrid OR where you can have single room or two room, where one room can be used for diagnostic, for normal patients, radiology, and the other room can be used for operations. So in the development of the first hybrid OR, we chose Sungai Buloh because it's in the Klang Valley, and we had to complete within less than 5 months actually. The main OR, the main OT at the time was not functional yet, so it was a good way to cause minimal disruption. And the Ministry of Health is easy to monitor the progress of the development of the brain suit because it was the first in Malaysia. So they have an extra interest to keep make sure things go smoothly. So it requires careful planning, building the room to accommodate a wide range of specialists for the anesthetists, for the nursing staff, and all the surgeons to identify all potential users and bring them into the planning process at the outset. Recommend that hospitals spend substantial time to plan, and you have to know what your institution needs, your main goals to achieve. You have to consult with the surgeons, anesthetists, radiologists, nurses, OR managers, and other staff. Identify the hardware, software, workflows they need for their daily work. And it has to cater for hospital needs in 5 to 10 years. That's for Europe, but in Malaysia, it has to cater for 20 years actually. And we have to have things like this don't come easy. It's the most difficult thing to in brain suite is to ask for the budget for it actually. And to take care of the brain suite is very, very important. So you have to have all this group of people in your team when you plan such a system. I started with nothing. I have nothing, and so when I have given something, you really treasure it. So you have to plan things very well and take care of it, of what you've been given. So to accommodate all the equipment, you have to have a big amount of space. You have about 60 to 90 square meters at least. The walls, windows, and doors must be lined with lead to protect against radiation. And the ceiling spots must be reinforced to accommodate equipment rooms, positive pressure, zero particle HEPA filter, and specific temperature and humidity is important. So this is how when you have the plan off, before you sign off, you have to look into it inch by inch and to see how is your workflow, where you would like to have the pendants, where you would like to have the OT table, where is your the CT scan or the imaging device, where is your monitors, everything, and where is surgeon's pendants and anesthetist pendants. That's important because it's going to help you in your operation, where the nurses is going to stand and where your assistant is going to stand. I think it's not only that. As a surgeon, you have to have, even if you don't have a brain suite or hybrid operation theater, you have to have your own system. You have to know where you're going to operate, where you're going to have your assistant, where you're going to have your nurses. And it's good to have, if each hospital have their own system, one fixed system, so that everybody is familiar with it. How the patients, in terms of patient positioning, in terms of the flow of the flow of your surgery, everything is good to be standardized if possible. Of course, there's always difficulty. You have always hard-hit surgeons who always throw a spanner in the machinery, but doesn't matter, but take it, at least there's some form of structure is important. So this is where we do, here we have the CT scan, here is where the surgeon is supposed to be, here is where the anesthetist is supposed to be, this is where the anesthetist pendant is supposed to be, here is where the surgeon's pendant is supposed to be. And these are the monitors, this is where the control room is. This is what we propose, we hope to have when we design everything. This is just a construction. And this is how it was long time ago, in 2006, 2007. And initially, so because it's an operation theater, proper hoarding has been done, demolition, restructuring, removal of all the ducts. Actually, and you can see actually sometimes the workmanship can be quite shoddy actually. So the removal of the old AHU, in fact, it's supposed to be quite a new hospital, but the AHU looks a bit old actually, unfortunately. So then you have to have the barium plaster, resurfacing of the floors to make the floor thicker, to reduce the radiation down to the lower floors, a new laminar aircon, transport the gantry, because this here is where the operation theater is at the highest floor. And here at the bottom, you have the the ICUs are here, and you have the offices at the bottom. This is the control room. This is for the main base for the OR table, fitting of the equipment, fitting, and this is the pendants, as I mentioned. This is the final image of the operation theater. You have this is the surgeon's pendant, and this is on this side is the anesthetist pendant. So everything you have to try to put everything to minimize the cluster, to minimize accidents in the operation theater, because otherwise there are too many wires, too many things on the floor, too many pipings, too many electrical circuits. People can fall down, wires can get disconnected, the ETT tubes can be pulled out accidentally. Right. So, in safety is concerned, we always we like to have safety, sterility, and serenity. And this is the surgeon's pendant, as I mentioned to you, which has all the bipolar machines, the endoscope, lighting system, the camera system, the high-speed drills, the suctions, and this is here is you have the anesthetic machines and the perfusers, the monitors for the anesthetists and the suctions, and also the computers. Everything is on the anesthetist pendant. So he doesn't have to move. He doesn't have to run around looking for a telephone. Everything is on one pendant. Here we have the different things. Here now this is the old system. Now they have this called bus system, which is a bigger kind of bigger light box, and you have to have good LED light to operate. This is how the table is. Of course you design it according to for the future. I have this blue spot around here, is so that especially when you paint the patient with povidone, any dripping or doesn't stain the wall, the floor very well, doesn't stain the floor very much. So I think you have to think of things to make sure that the operating theater lasts for many years. This is my surgical chair because I tend to operate for many hours. And this is the thing we have, the sky ceiling that we have. So, because sometimes it's very stressful for the patients. They come intubate, they will be intubated in the OR. There's no induction room. So when they get pushed in, they see the sunlight. I mean, appearance of a sky with the clouds. I think it's quite nice and calming effect for the patient. So here we have most of the doors are laminated and it's all foot touch. It's all hands free. The floor, the walls we have it stainless steel, but of course this is just for cosmetic reasons. This is the control room, and we have a glass so that it gives a very airy feeling. This is where the control panels are, and this is the other operation theater that we have. Of course, the reason I have all these areas here is because sometimes the nurses they tend to put the OR table in the wrong area. Too much to the side or too much to the left or too much to the right, even with a circle, and I'll tell them that the OR table should be in the middle. They still can't get it right, so it's skewed to one side. So some things I design for the staff's benefit, somehow or other, it doesn't go your way. So this is, and later on in 2015, we managed to get funds for Hospital Umum Sarawak and also Hospital Sultanah Aminah, which has the same, almost the same design and planning involved, and as such we hope to have more in the future. So later on we had the user training by all the companies, the vendors of the brain suite, and all documentation for the workflow and to pass over the responsibilities for the operation, because we have to use this investment of the government very well. And we have every week they want to know an update, or every month they wanted an update of the usage of the brain suite. That's why after getting my feedback from me, then they had 2 more brain suites in Sarawak and in Kuching, Sarawak and in Johor Bahru. So this is the how I organize my OR. The microscope is always on my right. The nurse, my assistant nurse is on my left. My assistant surgeon is on my right, and the anesthetist is on this side. The head is on this side, and the CT scan is here. So normally, anesthetist is always on this side of the OR. The nursing team will be on this side. This is the number of cases that we do. Generally about 8 hours, but normally sometimes I do longer hours. Because at the time we only have 2 hours of operating days in a week, but slowly increased. But in 2020, as you can see, there's only 47 cases. This is the number of cases that we did. Mostly is tumor cases, and we have because of the zero particle, we try to do a lot of our cranioplasty, and we do 13% of our spine work. This is in Hospital Umum Sarawak. They share that orthopedic team uses quite a bit of their operation theater. So as you can see, their usage is also brain, but there's a big amount of usage from the orthopedics and spine. So there's about 24% here. In our 10-year experience, we're delighted with the quality and the flexibility and durability of the equipment. The 24 hours support the vendors and the suppliers, the environment, comfort, and the ambience the operation is very nice, but we're not so delighted about the hospital support service. So just a few cases I'd like to mention about some of the cases that we do in the operation theaters in the hybrid OR, spinal region tumor, the different approaches that we do. Normally in Sungai Buloh, if we have a spinal gland tumor, we tend, if it's a teratoma, we do a sitting position. Professor Raimondi, he's an Italian man I met in 1996 in Berlin. He passed away, and it's a nice man. And he was telling me, was driving. He drove from Berlin all the way to Italy for European Congress once, and so he does this sitting position for the patient. So this is what we do as well. So of course, in such a patient, we are not able to do an intraoperative CT for the patient, but we are able to do our navigation, and we do our neuro monitoring for the patient. So this is how the patient is, and the bed has to become really low because the patient has to be tilted up, and the chair has to be down as well, because you have to angle yourself according to the tentorium cerebelli. So this is, we do a standard suboccipital craniotomy. So we open up, and then I try to drain as much as possible the cisterna magna, and then it completely relaxes the cerebellum, and then you can go superiorly of the superior cerebellar system. So this, what you can see the tumor. All right, this is after the removal of the tumor. So what you do is, of course, we're not able to do this approach for, we cannot do intraoperative CT, but after taking out putting the patient supine, then you're able to do a CT scan. But of course, the advantage of this in sitting patient is you avoid deep venous system, gravity to work for cerebral traction, reduces venous bleeding and pulling, easy access to the ETT as compared to prone, reduction of facial swelling and ability to observe the facial nerve function, notable advantages of the sitting position. Of course, the physical inconvenience of the surgeon and monitoring inconvenience for anesthetists and arterial hypertension is other disadvantages. The pre-op MRI. Okay. This is the tumor. This is a teratoma. This is once the patient is put on supine position and you do a CT scan, normally all the patients have this pneumocephalus, so which subsequently resolve and the patient's fine. So this is also a CP angle tumor, but here you see we can do a CT scan intraoperatively, but of course you see this mild artifacts actually, but it's because of the pins, which is not really radiolucent, so it causes some amount of artifacts, but you're able to roughly see where the tumor is and what's left. Okay, this is following the operation. What I find most is good is in GBMs. Actually, we do for glioblastoma multiforme. We do with our with the gliolan, and it's of course because the outcome depends on how much you excise the amount the amount of removal of tumors that you can do. So the more you can remove, the better is the outcome of the patient. And in aneurysm operation, in any vascular operation, and we normally monitor the patient by ICG, by Doppler, by CT perfusion, by neuro monitoring. So in such case on aneurysm, so we are able to do the post-operative CT angio in the operation theater to make sure the distal vessels are not clipped or compromised, and but we also, of course, as I mentioned, we also do by Doppler. We confirm with the ICG. We confirm with the neuro monitoring. So there are many modalities that you can do to make sure that you are not compromising the distal vessels. So yeah, it's also for the multiple cases, multiple aneurysms, ACOM aneurysms. Likewise, use. This is all intraoperative done in the OT. We do a CT, the CT perfusion to see the blood flow. Make sure it's not. Make sure the blood flow is all good. It's useful, of course, in the spinal operations. This is in the spinal reconstructed CT. This is our monitoring that we use. So of course the clamp that we use has to be radiolucent, so it's not as flexible as the metal the steel clamps, but nevertheless it's adequate for you to do to move the head in the proper position. Planning is important, and so as I mentioned, if you go for congresses or meetings, when people present with all the different modalities of operation, the different equipments that they have with ultrasound equipment, etc. Even what's most important is what you have in between your ears and your hands, actually, to make the right decision, to read as much as possible, and if you're not too sure, be humble about it, and to throw your ego aside and ask your colleagues or your friends. I have no problem to ask my friends or my colleagues if I have any problems. I'm old, but I'm still, I don't know everything, so, and definitely not much anyway. And so it's important for everybody to ask and discuss and help each other. So in the future, there'll be a lot of new machines, new robotic equipments, and augmented realities and everything. So we'll never know what in 10 years' time things might be different. But hence is something which cannot be which is always is an asset to yourself. To train well, make the right decision. That's most important. In conclusion, hybrid technology provides a versatile, precise on-site imaging and navigation. It provides a state-of-art intraoperative imaging capable of 3D reconstruction. And imaging before the patient leaves the OR allows you to confirm the adequacy of your job. It makes you more confident, makes you allow you to go back to home, sleep well. The simple and easy workflow with minimal interruption of previous routine or standard operating procedure. So with that, I thank all the participants and Mr. Azmi and team for organizing the online webinar. Thank you very much.
Thank you, Dato', for the informative and interesting talk, and for sharing with us your journey. I didn't know that we come such a long way. I'm glad we have such world-class facility, which many of us take for granted. Next, we would like to invite our next speaker, Dr. Saiful. Dr. Saiful graduated from University Kebangsaan Malaysia and underwent his Master of Surgery in University Science Malaysia. Dr. Saiful has in-depth experience in the management of head and spinal trauma, congenital abnormality, hydrocephalus, infection, oncology, vascular and neurological disease for more than 14 years. He is certified as SEA trainer in glioma certification surgery for malignant gliomas in Germany in 2014. Without any delay, please share with us your experience in fluorescent guided resection of high-grade glioma. Mr. Saiful, the floor is all yours.
All right. Bismillahirrahmanirrahim. A very good afternoon. Thank you, Ms. Shuyi, as chairperson, all the panelists. I'm very glad to be invited to join into this webinar by AASNS. Thank you, Ms. Azmi, and the organizing chairperson. It's very difficult for me to talk now because Dato' Azmi is here for two reasons. One, his talk has already been exciting. Number two is that he will definitely know whether what I'm talking is right or wrong. Okay. Anyway, I'm going to talk about fluorescence guided resection of glioma, high-grade glioma, a local experience. High-grade glioma basically are categorized under WHO grade 3 and 4, which include anaplastic astrocytoma, anaplastic oligodendroglioma, anaplastic oligocytoma, and also glioblastoma multiforme. Once diagnosed to have high-grade glioma, is difficult to treat because of its nature, which is always been aggressive and infiltrative. Poor prognosis despite of medical and surgical treatment. As we know that for grade 3, the 5-year survival rate is only 30 to 60%. An average of survival about 2 to 4 years. And global GBM is 5-year survival rate, which is about 10%. And the average survival is about 12 to 14 months. The principle of high-grade glioma management includes surgery. Surgery always has to be maximal surgical resection, followed by post-op treatment, which are radiotherapy and adjuvant chemotherapy. There are many modalities come out now to treat HGG, especially the glioblastoma GBM. Basically, the most important is that you must do good job by taking out the maximum amount of cells in the tumor, followed by chemo or radio. And always the outcome for high-grade glioma is always being poor. What are the key issues in high-grade glioma resection? Gross total surgical resection of high-grade glioma remains challenging to the surgeon due to the infiltrative nature of this tumor and the inability to clearly visualize the tumor at its margin. Surgical resection must balance the goal of maximal tumor resection while maintaining the neurological function of the patient by avoiding damage to the region of the brain. Despite of best practice, surgeons are estimated to achieve gross total resection about 40% in high-grade glioma. Similarly, resection of recurrent tumors is limited by the difficulty in distinguishing tumor from the reactive non-tumor in patient with recurrence. So what is fluorescent guided surgery or FGS? Basically is some form of ways in making sure the tumor being colored well. So it is for better visualization of tumor margin so that the maximum cytoreduction or supramarginal cut is possible. It has been proven to be effective in many papers, soon or later in becoming standard of care. However, the resection is always limited by the eloquency of the brain and the depth of the tumor. There are two imaging technique or coloring technique of the brain of the tumor that is popular in Malaysia. Number one is sodium fluorescent, which use a yellow filter. Tumor will be stained as green, whereas the brain will remain pink. The sensitivity and the PPV is about 80.8%, specificity and NPV is about 79.1%. Complete dissection can be achieved in about 82.6%, and it is relatively cheap and easily available. However, there are some disadvantages. The fluorochrome stays in the circulation or in the blood. It will cause the unspecific background. And this fluorescence can leak through the injured vessels, which later cause staining of the operative field. The tumor cell uptake and cell sensitivity to fluorochrome is not being proven in many papers, and there is high degree of false positivity. The second one is 5-amino-levulinic acid or 5-ALA. It is a precursor of fluorescence and protofirin 9. Protofirin 9 have an optical properties for diagnostic as well as phototoxic agent for therapeutic. And this 5-ALA is selectively accumulated in the glioma cell so that you can see the glioma cell very well. The advantages over the fluorescence is that they are very specific, will appear glow on the tumor cells. And because it's contained within the tumor cells, not in the blood, there won't be any unspecific fluorescence as a background. I'm showing you some videos of how the 5-ALA works. As you can see here under the white light, the tumor won't be easily differentiate Now, once you change it to the blue light, you can see the glow or the purple or pink color or the violet color of the tumor cells. It will always be larger than the white, under the white cell, the white light. You can see here, this is the area which appear white, and you thought is the tumor are only limited around here, but once you make it under the blue light, appear actually bigger, much bigger. The cells are much bigger. The most important when you are doing surgery with glioline is that you must make sure your field is clean from the blood. There will direct visualization of the tumor. You need a lot of retractor to expose the tumor. So while you are taking the cells like this, you must make sure that the tumor is under the microscope field. This is how 5-ALA looks, and the tumor looks with 5-ALA under the blue light. There are 3 different areas. One is solid area, which is very, very pink. Second one is vague area. And the third one is the area where there's no fluorescence at all. Look like a brain and the normal tissues. How do we interpret this thing, fluorescence? You can see when it is blue or none, there won't be much of tumor cells. When it's becoming vague, you can see some tumor cells are mixed with normal brain. When it's purely solid, mostly the tumor tissues are filled with tumor. Again, another picture showing you the difference between the strong, the faint, and the necrosis. So sample or biopsy taken from the faint area will appear like this. The strong area will appear like this. We would like to share our experience in using 5-ALA guided resection for high-grade glioma for 5 years in Sungai Buloh since 2010 to 2014. We are using 5-ALA, which also known as gliolan. It comes with oral solution, 30 milligram per ml per powder. So the formula, if you want to give to a patient, you use the formula of 20 milligram per kilogram body weight. This gliolan will be mixed with 50 ml of clear water, cannot be juice, and the color is not very nice, very metallic kind of taste. Patient have to drink it about 3 hours prior to the induction. So to have 5-ALA used in your center, you must be certified. So if you can see above here, this is how the 5-ALA comes into the world. So it was first promoted or developed by Professor Walter Stammer from Germany. So it was recognized by EMA in 2006 and FDA in 2017. You need to get a license. Follow that, we get a license to use it, to buy it. Then after you have completed using it for many cases, then you'll be invited to become a trainer. Following that, you can be the certificate person who teach other people in using 5-ALA. This is a paper. It's published by Dr. Weng Wei Ping as a thesis, fluorescence guided versus conventional surgical resection in high-grade glioma, a single center 7-year comparative effectiveness study. This is a study basically looking into 2 categories. We have about 74 patients operated by the diagnosis of high-grade glioma, in which from 2007 to 2010, when there was no brain sweep, there was no gliolan, it was operated in a conventional ways of using white light. And since 2010 to 2014, we have a brain sweep. We start using gliolan. We start operating using the gliolan. This is a retrospective cohort study. We are comparing between the 2 arms, looking into the median survival time, post-operative functional outcome, and predictor of analysis. These are the parameters that was included into the studies. Okay. The studies found that the median survival time significantly longer in the fluorescent guided group with this characteristic: male, no comorbid, good KPS, left-sided, eloquent area, diagnosis of GBM, and tumor volume of 50 to 100 mils. In terms of post-operative functional outcome, KPS, was significantly better in fluorescent-guided group. You can see here, the KPS after 6 months in patient operated by using 5-ALA is much better. Predictor of survival found age, comorbid, surgical method, histopathology, and adjuvant therapy. Then preoperative KPS, histopathology, and adjuvant therapy was found to be independent prognosis factor of survival. As conclusion for this study, we found that fluorescent-guided resection using of HGG using 5-ALA have provided significant clinical benefit, and it is a significant independent prognostic factor of the patient. Subsequently, we continue to use 5-ALA. Now already becoming 11 years. We have been using it since 2010 to 2020. And we have total number of 87 cases. We are doing HGG dissection using 5-ALA 7 to 8 cases per year. Cost of 5-ALA or gliolan is very expensive. It's about 7,460 per vial, or USD 1797. Dato' Azmin and myself are the two gliolan C certificator that do all these cases, majority. And our indication for usage are basically, we want to achieve maximum cyto reduction for better outcome of patient. Our waiting time for adjuvant radio and chemotherapy in HKL or in Institute Cancer Negara is very long. So we decided we should take as much as possible the tumor out. And subtotal resection always lead to recurrence and resurgery. So case selection, we only select patient with features suggestive of primary high-grade glioma on pre-op MRI and MRS. Biopsy is an option if we are not very sure. All the cases that we operated using gliolan are basically newly diagnosed, a fresh case. We select cases which is completely, we have possibility of a complete resection, preferably in a very young patient with good KPS. And these patients have to be consented for radical excision, and they should understand about the risk of worsening neurology. There are many adjuncts that can be used together with 5-ALA, example, neuronavigation, intraoperative MRI, intraoperative ultrasound, cortical mapping, fluorescent, photosynthesizer, and etc. In Sungai Buloh, as Dato' has explained before, we have a brain suite with neuronavigation. We have intraoperative CT. We use Leica OH5 with blue filter, also supported by intraoperative monitoring using Inomed and ultrasound by BK Medical. So once patient has been given 5-ALA, they were taken into OT, and then surgery will be done. Subsequently, they will be reassessed by doing intraoperative CT with CT contrast to look into the outcome of resection. So in our cases, we did 87 with 5-ALA. However, we found only 77 which is glow. The remaining 10 did not glow. So why the 10 cases was not glowing? We found that 5-ALA was not swallowed. One patient cheated us by throwing it away. Another one vomit. We have one instrument failure. This one too early probably. And one patient on high dose of DEXA did not off. Ideally, when you are giving 5-ALA, the DEXA should be taken out, the last dose. The last dose of DEXA should be taken out. And 5 diagnosis was not high-grade glioma. Okay. For those who glowing, we found that supramaxillary section occur in 10 cases. Gross total resection occur in 32 cases. In total, about 42 or about 53 or 34%. This is occurring in patients with superficial lesion small tumor volume, and non-eloquent area. Incomplete resection also occur, almost half, in about 35 patients, which is 45.6%, due to excessive bleeding, brain swelling, or intraoperative monitoring changes, or the tumor is very deep-seated. Majority of the HP come back as GBM and anaplastic astrocytoma. However, certain diagnoses also may glow, like low-grade glioma or METS. There's one study done by Walter Stammer in 2006, fluorescent-guided surgery with 5-ALA for resection of malignant glioma. This is a big study, randomized controlled trial, multi-center phase trial. So they also found that despite of using 5-ALA and other modalities, the range of complete resections only occurring about 25 to 95%, in average about 65%. Using white light is about 25 to 67%. Definitely, when there are more solid color, the survival becoming less, as you can see here. The more you remove the pink or the violet color, the red color, the better the outcome. 5-ALA has been proven to increase progression-free survival in patients. In summary or conclusion, complete resection is only possible with fluorescent if tumor is superficial, small volume, and located in the non-eloquent areas. Tumor resection always limited by the important brain structure, and this portion of residual tumor should be left treated with radiation and chemotherapy. Biopsy is an option, can be considered if diagnosis via MRI or MRI is doubtful to avoid unnecessary usage of 5-ALA or surgery. Despite of multi-modality apparatus and adjunct, maximal safe cytoreduction remains a major challenge in high-grade glioma. Thank you very much.
Thank you, Dr. Saiful, for your interesting and fantastic sharing. I hope Dr. Azmi will give you a thumbs up for your sharing. For sure, you have got mine. Your aside, it is indeed a challenge to differentiate between a tumor and normal brain tissue, and personally, this has certainly been a game changer for tumor operation. Our next speaker is Professor Kate Drummond. She has presented earlier on the first session. Nevertheless, I will briefly introduce her again for those who might have missed the earlier session. Prof graduated from the University of Sydney. She is trained in neurosurgery in Sydney and Melbourne. She furthered her training with both clinical and research fellowship in neuro-oncology at Brigham and Women's Hospital, University in Boston. Her research and clinical focus is in biology and management of brain tumor. Prof. Kate had published over 150 peer-reviewed papers and received more than 16.5 million in research funding. Prof. Kate was also awarded with Member of the Order of Australia for services to medicine, particularly in neuro-oncology. Now, we invite Prof. Kate Drummond for her presentation entitled Awake Brain Surgery. Prof. Kate Drummond, the podium is yours.
Thank you so much. I assume you can hear me and see my slides? Yes? Okay, so we've just heard about fluorescence-assisted resection with 5-ALA, which I think is really the perfect technique, although a little expensive for contrast-enhancing tumours and low-grade gliomas. But I'm going to talk about awake brain surgery, which I think is really the perfect technique for low-grade glioma, particularly those in eloquent areas. Now, this can be a very complicated topic, and many people use a lot of very complicated technology. That hasn't been available to me historically, and therefore I've developed quite a straightforward, simplified technique to do this. And so I'm going to talk about this because I know that many of you in the audience may not have a lot of the sort of technology that's been discussed by the last couple of speakers, but this is still a technique that you can use to improve outcomes for your patients. So I think awake craniotomy with intraoperative mapping is really becoming the gold standard for tumours that are even vaguely eloquent in any area that may be eloquent. And it's well shown that there's a reduction in late neurological deficit and an increased extent of resection by using this technique. And this has been shown almost 10 years now ago by this in this large meta-analysis of more than 8,000 patients, really showing that using an awake craniotomy with intraoperative mapping via a number of different techniques was associated with an improved extent of resection and a reduced rate of long-term neurological deficit. And I emphasize long-term because, of course, it is associated with an increase in short-term neurological deficit, which then resolves. But of course, there's some nuance to this because each low-grade glioma, and I'm specifically going to talk about low-grade gliomas here, is somewhat different. And each patient is somewhat different. So there's quite an important decision-making that has to happen before you embark on this. And what do I discuss with the patient? So I know a lot of us like to pretend that a patient may have a stable scan with a low-grade glioma, and we'll tell the patient the scan's stable, but it never really is stable. And we know that these tumours grow on average 4 millimetres per year, but anywhere between 2 and 12 millimetre increase in diameter. So I have to be honest with the patient that they have a growing tumour and that malignant progression will happen, but it's unpredictable as when it'll happen. Although I think with molecular pathology, this has become much more straightforward to predict. We can't always determine grade from the preoperative MRI, and we can't always say what areas of the brain are eloquent, particularly for speech, based on the preoperative MRI. But you have to be honest with the patient when you're recommending surgery that they may stay completely well for many years. But there is now evidence that extensive resection is associated with survival for low-grade glioma. So how do I decide whether a patient should have a low-grade glioma? Well, I do a preoperative assessment of their risk. How soon is it likely that their tumour will grow quickly or change histopathological grade? What is the risk if it becomes larger that it'll cross the corpus callosum or move into an eloquent area? I have a detailed discussion with the patient about how I favour aggressive resection, what I think the evidence is for extended resection on survival, and talk also about the side effects and quality of life, which is paramount in these long-living patients. And then I apply all of this to the individual patient using clinical judgment and particularly the patient's wishes and my own experience. So once you've decided you're going to do the awake craniotomy, what are the essentials? I think the most important essential is make it common. If you do this procedure only twice a year, then you're never really going to be comfortable with it. So firstly, it should be only a small number of specialised consultants or neurosurgeons in your unit. And also it should be a common procedure for you. So you should do it as often as you can. You need to carefully select the patient and you need to carefully educate the patient. And both myself and my anaesthetist will spend time educating the patient as to what will happen in the procedure. You need a careful team selection and careful team education. This is not a procedure to do with a new anaesthetist or a new scrub nurse. You need to, and so I have a team that I use all the time, a very experienced team for this procedure. So this picture is just to show you my anaesthetist. I basically only do this operation with one anaesthetist because he really is the best and knows what's going on. A lot of people say, well, can't you get away without an awake craniotomy because you do a lot of fancy preoperative imaging? I think the important thing to remember both about functional MRI and about tractography is that these are mathematical constructs. They're not direct images. Particularly functional imaging, which will give me something like this, where they'll say, well, here's Broca's area. Well, I knew Broca's area was going to be there. But the trouble is what functional MRIs show me is that it shows me what's being used for function, not what is essential for function. And that's the difference with mapping. And of course, we can do some lovely tractography, but once I start taking this tumour out, I lose all intraoperative navigation. And so therefore, I think having some sort of monitoring for the deep white matter is extremely important because it's the white matter that matters. Cortex will almost always recover. White matter will not recover. Anesthetic techniques fairly straightforward. Antiemetic, anticonvulsant. We've got a lot of little tricks for making sure that we've got access to the airway for oxygen without the patient feeling claustrophobic. We don't use a lot of analgesic, a little bit of fentanyl, often only a single dose at the start of the procedure, sometimes a top-up dose later. And then anxiolytic and analgesics with dexmedetomidine being really the mainstay of our anaesthetic and clonidine. I use an awake procedure. So I don't use asleep. I don't use a laryngeal mask or other airway. I don't use preoperative scalp blocks. We basically put the patient to sleep with propofol and fentanyl for the application of pin scalp infiltration Sometimes the urinary catheter, or although I use that much less now, we just let the patient use a bottle on the table. And for the navigation registration. And then we let the patient awaken in the pins and we let them stay awake. We don't have them sleepy. I must admit that I don't like awake asleep, because the patients take so long to wake up and to be really good to test. And my patients are really good to test. They can't just name pictures, they can engage in complex conversation, which is of course the best test. So here we are, here's my anaesthetist talking to my patient as we're getting ready for his procedure. The setup on the surgeon side looks like a very straightforward surgical setup. And on the anaesthetist side, we get rid of most of this now so that the patient can see out the end. But this is the cave that we put the patient in. And there's my anaesthetist who does all of my neurological testing as well. I don't have a speech pathologist or a neuropsychologist. We do all our own testing. This is the patient having their craniotomy. So despite the fact that we don't have them asleep for that, they seem to cope with it very well. This patient's having a great time. She even got her eyelashes done before she had her surgery, because she knew she'd be having some photos taken. We have a few little tricks. Obviously, you need to make sure that there's a reduced chatter in the operating room. We have tricks to stop patients from getting too thirsty, getting too hot. You need to do this often so that you learn all these little tricks. The technique for removing the tumour is actually very straightforward, just a standard frameless stereotactic with an ultrasonic aspirator. You need to drape the patient to allow access to the airway if necessary, but we've never had to convert to a sleep procedure and intubate the patient without having it been planned. And the face and limbs obviously need to be available for testing. And you need to be able to accurately and in a detailed way explain every step to the patient. So I'm just constantly talking to the patient about what's happening next. Here comes the drill. This is what the drill sounds like. You might feel a bit of a mild headache now, and patients cope with it very well. The craniotomy should be big enough to expose enough cortex for adequate mapping, but I don't do a huge affair, take off half of the side of the head and map the whole hemisphere. I just do what I feel I need. And pain is not usually a problem. The drill heat on the dura can be a bit painful, so we use ice cold irrigation, and dural manipulation can be a little bit problematic, but okay if you explain it to the patient. And as you start to remove a very large tumour, you can of course get some brain sag with CSF loss and get a dull headache. So for an insular tumour like this, I use a transcortical approach. I don't split the fissure. I use mapping to find, so I do something about this large to get to that tumour and find a corridor, a transcranial corridor using cortical stimulation. These are the settings that I use, but I think basically I've just seen every single setting espoused in the literature, so I think you can choose whichever you like. I go up to 6 milliamps now. I had one patient, so I think I had a deficit because I missed positive stimulation. And we obviously treat seizures, which we have about a 10% incidence with ice cold ringers, which is usually able to control them. For the cortical stimulation for motor, you're obviously looking for abnormal movement. For speech, we use simple counting, sometimes picture naming, and in particular, conversation. And when you're stimulating, what you're looking for is speech arrest. And for sensory, for cortical stimulation, you're looking for paresthesia and numbness. And you really need an excellent understanding of brain anatomy and function to be able to do both the testing and the stimulation. So that you can work out where you are and what functional areas you're stimulating. The functional testing, once you start resecting the tumour, needs to be by someone competent, but it doesn't necessarily need to be a speech pathologist or a neuropsychologist. And as I said, I use my anaesthetist. It needs to be frequent and specific to what you're trying to preserve and rigorous to define early deficits. And you can do a lot of very fancy tests, but for speech, the best test is conversation, and that's what we use. The best test is to have patients, we've got a list of questions that we use. So tell me about your wedding. Tell me about your last holiday. Tell me the exact steps that are involved in your job. Tell me how you chose your children's school. Tell me about what you did at university. What was your thesis? All of these sorts of questions we have predetermined so that we can keep the patient talking and having complex conversation. And then we keep resecting. either until there's a gross total resection or until the patient gets a minor deficit, at which time we stop the resection, obviously. So that was the corridor that I had to remove that insular tumor, which went very well. So these are our follow-up. This is our figures for 82 awake craniotomies in 76 patients. So patients do come back. And these are just low-grade gliomas with at least 3 years of follow-up. So a young cohort, obviously, given it's low-grade glioma. 15% incidence of intraoperative seizures. Almost half of the patients had positive mapping, and 78% alive at last follow-up, with only significant surgical complications in 2% of craniotomies. We did volumetric analysis of the extent of resection for these patients, so using an outline to look at what was left behind on the pre and post-operative imaging. And these are our results. The interesting thing is all of these I thought were low-grade gliomas on preoperative MRI scans, but a significant percentage, or a quarter of them, were actually grade 3 or grade 4 tumours, finally, largely on molecular testing. So it's important to understand that, you know, when you think that maybe you will just watch these low-grade gliomas, they may not actually be low-grade gliomas, and at least a biopsy is necessary, if not the best resection you can do. The neurological outcome in the long term is very good, but in the short term is always quite troubling to wait for the patient to get better. So 16% of patients had a preoperative deficit, one of which persisted at 12 months. 44% of patients had a new early intraoperative or postoperative deficit, which added to the worsened pre-op deficits. Is 50% of patients were somewhat worse after the surgery, which a lot of people find concerning. But when you see that only 20% of patients had a new deficit at 3 months, and only 10% at 6 months, and at 12 months, only 5% of patients. These 4 patients were 2 patients with a minor speech deficit, which didn't stop them working. 1 patient with a spasticity of a foot, which did stop her wearing high heels, but didn't stop her dancing at a wedding. And 1 patient who had a very severe deficit who had multiple medical comorbidities, including a kidney transplant, and they had an ACA infarct. The extent of resection, our mean percentage extent of resection, 82%, which is as good as anything in the literature. So almost 70% of patients between 80 and 94%, and we think that anything above 78% will change the patient's prognosis. 25%, 95 to 99%, and 8% of patients with a gross macroscopic resection on postoperative imaging. The survival is as expected. We haven't reached the median survival for the grade 1 and grade 2 tumours yet. And if we compare our results with the literature, it's very difficult because there are very few that are absolutely comparable, but our extent of resection is exactly the same as the remainder of the literature, if you accounting for differences in tumour type, etc. So thank you very much for listening, and I guess we'll have some questions at the end.
Thank you, Prof. Kate, for a very informative sharing. I'm sure everyone has learned a lot from your sharing. Perhaps this is an option when planning for surgery for our patients. As a reminder, please drop your question into the Q&A box. Please indicate the speaker you would like to direct the question to. Without further ado, I would like to welcome Prof. Ido Paldo to deliver his presentation. Prof. Ido graduated his medical school from Hebrew University and did his residency in Hadassah Neurosurgery Department. Prof. Completed his Neurosurgical Oncology Fellowship in Johns Hopkins University Institute and in the Royal Melbourne Hospital. Prof. Ido's research interests include genetic and epigenetic alteration and differential localization in primary brain tumor. Today, Prof. Ido will be sharing his experience with his topic entitled Neuromonitoring for Extra-Axial Lesions. Prof. Ido Paldo, over to you.
Thank you. Can you see my slide?
Yes.
We can see.
Can you hear me? All right, great. First, I'd like to thank the organizing committee for having me and letting me present. I'll talk about our experience with intraoperative neuromonitoring for resection of cranial meningiomas and its effect on the during resection of meningiomas, and we'll talk about how we analyze the effect on the surgical workflow. So I have no conflict of interest other than to say that this was recently published in Neurosurgical Review. So we know that meningioma is the most common primary intracranial tumor. We all know experience that it's relatively unpredictable based on preoperative imaging how much brain invasion you will find intraoperatively. And the risk of motor decline after resection of meningiomas or extraaxial tumors around the motor strip is not negligible. Different reports have it up to 25%, meaning up to 1 in 4 cases will have postoperative motor decline, again, either a new deficit or worsened after resection of a meningioma in the motor area. We often use intraoperative neuromonitoring. We have a very, very readily available service for intraaxial tumors and for spinal cord tumors. And in general, we don't, I think in the world, it's very rarely used for cranial meningiomas. So what we wanted to do is to characterize the impact neuromonitoring might have on the workflow during resection of extraaxial brain tumors. So what we did is in 2017, we started monitoring cases for that were during resection of meningiomas. And we recorded all changes in the workflow of the operation and classified them, as I'll show you in a minute. I will note that the decision whether or not to monitor was completely up to the contending neurosurgeon. Generally, it was based on proximity to the central sulcus, adjacent to the central sulcus, and in a few cases, it was because the tumor encased the middle cerebral artery. And it will also note the patients who had a severe deficit preoperatively were not monitored. So a bit about what we did. We had we placed phase reversal strip, as you can see on the 2 left panel in B, placed the strip in order to localize the central sulcus. Then we performed cortical mapping, as you can see on the right panel, with a handheld probe, or what we call a ball tip probe, and we also used SSCP and MEP, which I won't go into other than this. This is how we classified changes in the workflow. So the workflow change class 1, which was the most severe, so the most dramatic, and thankfully also the rarest, means that the operation was aborted because of an alarm by the neuromonitoring team. Class 2 meant that we intraoperatively decided to perform incomplete resection. Usually this implied that the cleavage plane or the separation plane was lost, and we decided to leave kind of like a carpet of tumor on an eloquent area. And generally, this was the motor strip, I'll show you an example later on. Class 3 meant that a surgical change was made regarding the approach. Again, in most cases, what this meant was that we debulked the majority of the tumor away from, we were able to localize the motor strip, and then we left the smallest portion of tumor to be separated from the motor area, which enabled us to manipulate the motor area less aggressively, so to speak. And in some cases, this implied temporary clip in the MCA, which I won't go into in this presentation. In class 4, modification of the anesthesia or medical treatment during the operation, and class 5 meant that we made no changes in the surgical workflow or in anesthesia. 4 cases which we monitored. We see a wide range of age with a mean of about 60 years old. 90% of our cases had no neurological deficit preoperatively. 3 had a mild hemiparesis, one had a facial paralysis. Again, note that patients who had a severe deficit were not monitored in our series. A bit about where the tumors were. So a majority were parasagittal meningiomas overlying the central sulcus. 40% were convexity meningiomas, which either overlied the central sulcus or the sensory motor cortexes, or were thought to encase the MCA, and 2 were falx meningiomas. Tumor grades were pretty similar again to other meningioma series. 92% were grade 1, and 7% or 8% were grade 2, grade 3 meningiomas in this series. And the reason for monitoring, as I noted earlier, in 90% it was because the tumor overlaid the central sulcus, and in 4 cases we thought that it encased the MCA. So if you look at what changes we made, the most common change was in the cases where there was a change made. In more than 1/3 of the cases, we altered the approach, again debulking the tumor away and then resecting the smallest part of the tumor. In about a bit over 10%, we decided to perform in complete resection, what we called class 2 workflow changes. There was only 1 case in which the operation was aborted. And I will note that in 40% of the cases, there was no change whatsoever, either in surgery or in anesthesia. If you look at all patients who had any change, 1 through 4 of the changes versus the class 5 changes who had no change whatsoever, you'll note a difference because the number of patients who had a postoperative temporary deficit was about 8% in cases where there was a change made, and was about 3 times more common in cases where there's no change made. Again, 8% versus almost 19%. If you look at the patients who had a postoperative permanent deficit, these numbers are small and there was no statistical significance, but there were no permanent deficits, when there was a change made, and there was 1 or 6% in the cases where no change was made whatsoever. Here's an example of a class 3 change. Thanks to neuromonitoring or mapping, cortical mapping, we were able to localize the motor strip to this purple outline that I showed here. And what we did was we slowly debulked the tumor, and ultimately were able to get a complete resection. But again, the smallest bit of tumor was removed from the motor area. Here's an example of class 2 change, which I don't know if you can see well, so you'll have to believe me that we left a carpet of tumor here in the purple area that I marked out, where we weren't able to separate this, and the cleavage plane was lost. Therefore, we performed incomplete resection in this case. I will note that there have been, this is not completely the first report of neuromonitoring for meningiomas, because 2 previous studies described their experience with this monitoring, but it was, both of them used this only as a decision tool in cases where they lost the cleavage plane, and only as a tool to decide whether they were going to leave a carpet or not, which is pretty equivalent to our workflow changes class 1 or 2, They didn't elaborate about class 3, 4, or 5 as I showed. I won't go into all of this. This is the algorithm. Again, those of you who are curious are more than welcome to read the article. I will note in general how our workflow worked, where in general the most importance of everything was whether the motor cortex was in the surgical field, yes and no, which of course we were only able to identify thanks to neuromonitoring. If the motor cortex was in the surgical field, then you will make some kind of change, even if it is a type 3 change, which again implies that you debug everything and end the resection in the motor area. Of course, if you find motor activation, then you will consider subtotal resection, and if in fact you did that, then it will be a subtotal resection or type 2 change. As I noted, there was one case where we aborted the resection. To conclude, this is, I think, an important point. There, in more than half of the cases, 60% of the cases, neuromonitoring affected to some degree the surgical workflow. So it was more common that it did affect. This is not an insignificant tool, because more commonly it did affect the procedure than it did not. And as I noted earlier, overall there were 12.5% new deficit and 2.5 fixed deficit, and the effect, which I noted earlier, on the outcome and when neuromonitoring affected workflow change, there were times fewer temporary deficits, and there were 0% of permanent deficits if a change was made that affected. So I think it is impactful in meningioma resection in the pericentral area. Again, the most common, was alteration of the approach to the resection, and I will acknowledge limitations. First of all, we only focused on motor function preservation. The second point, which I will acknowledge, is that the majority of cases that were resected in our service, over 330, almost 330, only 40 cases were monitored. There was also a limitation. I thank you for your attention. Again, as my colleagues before, I will invite you to Jerusalem, which is very beautiful and interesting, and I welcome you in the following September to Jerusalem.
Thank you, Prof, for your interesting and inspiring presentation. This workflow classification is new to me. Maybe we can learn from the best practice you have shared. I'm sure we learned a lot from Prof. Kate's presentation just now. We are lucky to have Prof. Kate presenting not one, not twice, but for the third time today. Here, she will be sharing on online supportive care for brain tumor patients. Once again, let's invite Prof. Kate Drummond to share her presentations.
So I'm very sorry that you've been subjected to me 3 times today. I just put some options in about what I could talk about, and AASNS said that I should talk about all of them. So here I am. So I hope most of you were at the last session, because we can go a little bit quicker if you were. So obviously, managing health-related quality of life in brain tumor patients can also be seen as supportive care for brain tumor patients. And so, you know, I shared in my, I'm going to share some work that we're doing, which is funded by a large grant, $2.6 million grant from the Australian government. And I've put the partners here on the slide who are working with us on the grant, including Two Bulls. You might look at that and think, well, what is that? That's a digital production company. So I'll explain that a little bit further as we go along. So I did show you our work with surgical health-related quality of life after resection of low-grade glioma. And you've seen this slide that shows you that in all of the domains of quality of life, low-grade glioma in the darker blue has worse scores than a normal population. We talked about that. And we talked about how it lasts for many years, 120 months, with significant and clinically meaningful reduction in health-related quality of life. And we talked about how it's the same for meningioma, even tumours that we would think are largely, largely cured, that these patients still have difficulties with their health-related quality of life. And for meningioma, the graphs look much the same as low-grade glioma, not quite as bad, but particularly social function and cognitive function, significant and clinically significant differences in health-related quality of life, which persist over time. So we talked about that at my last talk. And I think I got to this part where I said, well, what are our next steps with this research? So we're continuing to collect data. We're expanding our cohort to individual tumour types and collecting more data on these patients, up to 1,000 in our database now. We're still working out what the exact determinants of impaired health-related quality of life are. So we've got a pretty good idea, and we talked about that last talk. But the next steps are really, what are the interventions that could improve health-related quality of life? And how do we identify patients who most need help? How do you decide in the first couple of weeks post-operative whether your patient is going to be one of the people who's really got significantly impaired health-related quality of life for the next 5 years or 10 years? Well, one way that you could do is use machine learning. And so this is Rasham Kari, who's a very clever medical student, much more clever than I am. And he's done some fantastic work looking at a machine learning or artificial intelligence algorithm to determine which of our patients, based on their preoperative characteristics, will actually have reduced health-related quality of life. So this is under review at the moment, hasn't been accepted yet. So he basically looked at our whole database, looked at patients who had their first survey conducted between 12 and 60 months after surgery, and applied a number of different machine learning algorithms to work out which best fit our data. And so if you have a look here, if the input is a 50-year-old male operated at the public hospital who's married with a small grade 1 tumour that's completely resected and doesn't need and some meningioma and doesn't need radiotherapy or chemotherapy and doesn't have seizures, not surprisingly, this person would not be predicted to have health-related quality of life decline below a certain threshold within their first 12 to 60 months. But if you change that to age 70, you make them single, you make it a grade 2 tumour, and they require post-operative radiotherapy for an incomplete resection, then you can change that whole algorithm completely. So this is, we're just starting to use this on a new data set to work out if it works as well on our first set as it does on a second set of data. But this machine learning approach may be something that we'll be able to use. And really the two most prevalent outcomes in our data, which is global health-related quality of life and fatigue. We had very good area under the curve for the ROC curves, which really show that this might be promising to help us determine which patients will need most help, because we all have very limited resources with regards to psychologists, psychiatrists, with regards to rehabilitation services, etc. This is a second way that you might be able to predict which patients need most help. This is Tom Peters and James Towner, two American neurosurgeons who came out to work with us, who looked at our pre-operative imaging of our low-grade gliomas and put the pre-operative map of the low-grade glioma, so the preoperative imaging map, you can see here that it's been put into a standardized Montreal Neurological Institute brain. So a standardized map combined, so you can see here that if there was only one tumor where it was dark blue, there were many tumors where there were yellow or red, and combined that with the health-related quality of life scores, basically showing which pre-operative tumours were likely to have reduced health-related quality of life depending on their position, which is very interesting. Most patients didn't have reduced physical health-related quality of life. And that's because as neurosurgeons, we so much try to avoid physical deficits. And so the patients actually do very well from this point of view. But interestingly, a lot of patients, and this is the old thing that I was talking about before, that patients feel their brain is not working. A lot of emotional and cognitive health-related quality of life deficits with a low score down around 50 came from this area in the parieto-occipital region, which we'd often consider to be a natural surgical corridor. So it's very interesting that tumours in this area can actually be associated and predicted to have reduced health-related quality of life in the long term. So really important that we can use these measures to determine what will happen to our patients in the long term. So what interventions might we be able to use? This is Heidi McAlpine, one of my trainees, now doing a PhD, and she's really done this 3-phase project to look at how we might improve, because it's very tempting to think that online or digital type interventions might be helpful for these patients who may live a long way from their centre for neurosurgical care. Many of the countries, Malaysia, Indonesia, patients can live many islands or thousands of kilometres away from their care. And so an online intervention may be sensible. Certainly that happens in Australia. So she's had a 3-phase project looking at a literature review of online interventions, looking at a survey of our own patients as to what might be helpful. And now this is what we've got the grant to build the community. So our first was a systematic review of online interventions for cancer patients. Out of 1,441 abstracts, we found only 14 studies in cancer patients. There weren't any in glioma or brain tumour patients. In cancer patients, where there was a rigorous evaluation of an online intervention. So either a control group or a before and after, or something where they didn't just say, look, we built this beautiful website and patients said they liked it. Something where they'd rigorously assessed it. And out of those 14 studies, it's fascinating. We found that basically most interventions didn't work at all. Some worked for a little while, and some were actively harmful. So some of the mindfulness studies actually made people feel worse. So you have to be quite careful about what you're building for your patients and rigorously assess them. So we thought, well, we better look at our patients and see what they might want to use. So we looked at 200 patients, basically just selected them from the waiting room with primary intracranial tumours, and we used iPads for them to fill out some surveys. And what did we find out about our patients? Well, we found out that because Australia is a big country and all the neurosurgery is on the coast, we found that a lot of our patients live a long way from our hospital, 50%, 10 kilometres at least, and 34% more than 50 kilometres from the hospital. Many didn't drive, and many were not partnered, or 36% no partner for various reasons, and 71% not working. So these patients are both socially, geographically isolated. So they're the perfect group to consider for an online intervention. We did find, however, of course, that some patients don't use the internet. 14% of patients don't use the internet at all. So online's not going to be much help for them. And we found if you wanted to consider a social media type platform, many patients who use the internet didn't use social media, up to 28%. And largely this was because they were scared their information would not be private. And so that's something to consider when you're thinking about online interventions. So from our survey of our own patients, we're able to recommend some features for online interventions for brain tumour patients. Our patients told us that they wanted to control the amount and type of information others knew about them. But interestingly, they wanted to know about the other people who are online. They wanted to use something at any time and any location, and they wanted to use particularly an online intervention as a guide or filter for useful information, because there's so much rubbish on the internet that makes you think that you might have found the miracle cure or something. They wanted to use it as a filter or a guide. They wanted a health professional or a moderator to contribute, and they wanted to be able to share their experiences and access the experiences of others in a sort of blog format or support group format. So this is what we're building now, and this is incomplete work. We're building a brain cancer online survivorship platform. There are 3 groups to whom it's aimed: patients, carers who are particularly underserved population and yet do most of the heavy work looking after patients, and clinicians. And there are 3 pillars. There's a pillar for information and connection with the treating team. So Friday afternoon chat room with the brain tumour nurse, and a very good information site with wayfinding, so you can find exactly what you need for your tumour in your situation. Peer support groups, which will allow patients to really find the people who are most like them. So rural patients, patients with young families, older patients with high-grade tumours, because there's nothing worse than trying to put a young woman with children and a low-grade glioma into a largely high-grade glioma support group. And then lastly, symptom management. So what we were talking about was determinants of quality of life. Can we teach patients how to sleep better or how to manage their fatigue online without the need for very expensive allied healthcare professionals? I'm going to actually skip that in the interest of time. So how are we going to do this? Well, we've actually got this very complex co-design program. So at every step of what we do, we're having patients, carers, and clinicians to come together to co-design this website, this platform, to make sure that both from individual interviews and what we call living labs, which are small groups to help co-design our platform, and then simulation labs, we'll be able to create something that really is exactly what patients and carers want, not just what doctors think they need. We've got a pipeline where at the end of 12 months, we should have a prototype. That will be July next year. So we're getting about halfway through our first year, and then a 2-year implementation and evaluation framework to determine if our program actually works and can actually change quality of life for patients, and we can actually run successful both interventions and also support groups for these patients. It's interesting that this will be new knowledge, because we actually know how to develop, say, a drug. We know that we do discovery and development, we do mice, we do toxicity studies, we do phase 1, phase 2, phase 3, then we do regulatory approval and post-marketing. If we have a digital or an online intervention, then we actually don't really know how to evaluate that. We can do discovery and development, but we don't. It's got a bit of a grey box or a black box as to how we should really evaluate that. And so we're hoping to provide new knowledge for this as well. So I'll leave it there, and thank you very much for listening to me for 3 times today. You're very kind.
Thank you, Prof, for your informative presentation. I'm glad we did not skip this presentation and have a chance to learn tremendously from all your 3 presentations. It is great to have machine learning algorithm. This is certainly a future we should look forward to, where we can feed more information, not only locally, but internationally, in order to make a smarter and faster decision. Last but not least, our final speaker for today is Dr. Teh Kok Hui. Dr. Teh graduated from University Malaya with distinction and obtained his MRC-PCH in 2008. Subsequently, he gained his fellowship in pediatric hematology and oncology with distinction. Dr. Teh has obtained various awards and international participations, such as the Elder Hay International Traveling Fellowship Award for the International Symposium on Pediatric Neuro-Oncology, the Children's Hospital Westmed Traveling Fellowship Grant, Hadiah Latihan Persekutuan, 4th ESO SIOP Europe Masterclass in Pediatric Oncology, and Senju Viva Forum in Pediatric Oncology. Dr. Teh will share with us the role of neurosurgeons in pediatric brain tumor, view of a pediatric oncologist. Without further ado, let's invite Dr. Teh to share with us this topic.
Thank you, Mr. Asmi, as well as the organizing committee, for inviting me to speak to you in this esteemed meeting. Thank you for the kind words to the MC as well. I hope I assume that you are able to see my slides as well as to hear what I'm going to talk about.
Yes.
I was given 20 minutes to talk to a group of neurosurgeons. I'm very glad that there are still more than 100 of you logging into this symposium. I thought I would use the time best to talk about what I feel we could work together to improve the care of children with brain tumors, and hence the topic that I've chosen. As you can see here, this is a list of what I think that we can do together to improve the care of children with brain tumors. There are 10 items that I've put on here, and I will go through each and every item of it, giving some examples to what I feel would be important. So the first and most important possibly is to involve the pediatric oncologist at presentation. And I still find that there are patients where the patients are referred only after the HPE of the results has become available. And I would like to emphasize that the HPE results is not a prerequisite for referral. So I'll give you some example, an example to illustrate this better. So this MAS, who is a 12-year-old boy who presented with the left eye squint and double vision and unsteady gait. A CT brain showed acute hydrocephalus with posterior fossa mass. A VP shunt was inserted and the MRI brain and spine was done, showing no metastatic disease. So this is the MRI brain that shows a midline tumor arising from the vermis, which is hypo-intense, obviously in very close relation to the brain stem. He had a posterior fossa craniotomy and tumor excision, and gross total excision was achieved. Post-operatively, he had good recovery. The HPE was reported as medulloblastoma, non-sonic hedgehog and non-wind activated. Unfortunately, he was only referred to us about 2 months later. This is the post-op MRI, which showed good resection with very minimal residual tumor, if any. So how do we treat medulloblastoma? This will be classified or stratified as a standard risk medulloblastoma, and internationally, most would use the PECR regime, giving craniospinal radiotherapy to a total of 24 grays and boost to the tumor bed of 30 grays. During radiotherapy, the patient will also receive concurrent weekly IV vincristine, and following the completion of radiotherapy, the patient will receive maintenance chemotherapy in the form of oral lomustine, IV vincristine, and IV cisplatin. This is a work that was done by my medical officers a few years ago, looking at the outcome of children diagnosed with medulloblastoma treated by us over the many years in the past. During this period, the patients received 36 gray craniospinal irradiation instead of 24 grays craniospinal irradiation. And you can see that the 5-year overall survival is about 86% if they were classified as standard risk then. I would also need to say that the classification as standard risk and high risk were not so clear-cut or not so clearly defined then because of the limitation of imaging post-surgery. Unfortunately, not surprisingly, many of these patients have got long-term morbidity. And as you can see here, only a minority of patients do not have both neurological as well as endocrine complications. A quarter of them have got both neurological and endocrine complication. Another quarter have only endocrine complication, and about half of them have got only neurological complications. So it is important to involve the pediatric oncologist at presentation because of the timing of radiotherapy. Although controversial, many of the international trial protocols for medulloblastoma strongly suggest that radiotherapy should be started in a timely manner. And timely manner means within 4 weeks in North America and within 6 weeks in Europe. This should be started after the tumor has been excised. And any delay in the start of radiotherapy is associated with worse prognosis. And it is also recommended that if radiotherapy cannot be started in a timely manner, the patient should receive a higher dose of craniospinal irradiation, and instead of receiving 24 grays, the patient will be given 36 gray craniospinal irradiation. And we try to reduce the amount of craniospinal irradiation because of the long-term morbidity associated with the extensive craniospinal irradiation. Most posterior fossa tumors in children are malignant and will require radiotherapy at some point in time, and therefore children with posterior fossa tumors should be referred at presentation. In the past and up until just before the COVID hit us, radiotherapy planning takes on average about 4 weeks before it can be started. And hence, if the patient was not referred at presentation, we will not be able to start radiotherapy in a timely manner. And therefore, if you were to wait, again, histopathological reports on average takes about 4 weeks for it to be available. The second and third items that I would like to highlight is which have been highlighted by in the previous session, is about sending blood and CSF for alpha fetoprotein and beta HCG, especially when the patient has got a suprasellar or pineal tumor, whereby an intracranial germ cell tumor is suspected. So I'll give you another example. This is AAH, who is a 10-year-old boy. He presented with altered behavior and squint and seizures. A CT and MR brain showed a pineal gland tumor. A tumor biopsy was performed during CSF diversion, and that was reported as diffuse astrocytoma. This patient was subsequently referred on to our neurosurgeons, and the posterior fossa craniotomy and tumor debulking was performed, and the histopathology was reported as germinoma. This is a CT and MRI which showed a huge tumor at the pineal region. The blood alpha fetoprotein was normal, and so is the CSF alpha fetoprotein, but the beta HCG is actually not normal. As you can see here, the beta HCG from the blood is 46 units per liter, and the CSF beta HCG is 61.4. With this information, a diagnosis of non-germinomatous germ cell tumor, basically choriocarcinoma, can be made. Various groups have taken various different cutoffs to be normal and to mean different things. In Europe, using the SIOP treatment regime, this is the cutoff that is being used. So if you have got alpha fetoprotein either from blood or CSF, which is more than 25 nanograms per mil, you can safely say that there is a yolk sac tumor component in the tumor. For beta HCG, if it is more than 50 units per liter and either in blood or CSF, you can fairly confidently say that there is choriocarcinomatous component. Tumor with germinoma component may secrete beta HCG as well, but the beta HCG should not be more than 50 units per liter. It may be normal or may be non-detectable from the blood or CSF. For yolk sac tumors, the alpha fetoprotein that is found in the blood is usually higher than the CSF, whereas for choriocarcinoma, the beta HCG that is found in the CSF is usually more than the ones found in the blood. This is a flow chart which I will take you through on how to approach a child with a pineal or suprasellar tumor where we suspect the patient could have a germ cell tumor. If the patient has got severely raised intracranial pressure or comatose, an emergency imaging should be performed, either a CT or MR, and in most of our centers, it will be CT, and an urgent neurosurgical intervention should be performed. During the urgent neurosurgical intervention for CSF diversion, CSF should be sent for cytology and tumor markers, and a biopsy should be taken at the same time. Post-operatively, the blood should be sent for tumor markers as well, and this should be followed by MR of the brain and the spine, followed by other treatment. In the second scenario, if there is raised intracranial pressure but the patient is otherwise stable, the patient can have a MR of the brain and spine instead of an emergency imaging study. Blood should be taken for tumor markers. If the blood is found to be diagnostic of a germ cell tumor, a biopsy will not be necessary to be taken subsequently. During the neurosurgical intervention for CSF diversion, CSF should be sent for cytology as well as tumor markers, even if the blood tumor markers were already diagnostic of intracranial germ cell tumor. In the third scenario, where there is a normal intracranial pressure with no acute neurological symptoms, the patient can have MR of the brain and spine, followed by blood tumor markers. And because there's no need for neurosurgical intervention, the patient can be managed by a pediatric oncologist. We would do a diagnostic lumbar puncture. We will do a diagnostic lumbar puncture, and we will send the CSF for cytology for completion of the staging, as well as send the CSF for tumor markers. If a diagnosis can be made with this intervention, then a biopsy may not be necessary, and the patient can then be treated accordingly. This is the SIOP treatment regime for non-germinomatous germ cell tumor. And the definition of non-germinomatous germ cell tumor is anyone with either a raised alpha fetoprotein or raised beta HCG, or from a biopsy of the tumor that is presence of choriocarcinomatous or yolk sac component. A patient with teratoma would be treated differently and not treated according to this regime. For non-metastatic tumors, the patient will receive 4 courses of PIE chemo or PEI chemo, followed by re-evaluation. At re-evaluation, if there is a significant residual tumor, consideration of tumor resection should be made. Historically, these patients were treated with focal radiotherapy of up to 54 grays, but there is good evidence to support that, to suggest that we should not just do focal irradiation, but also include the whole ventricle of up to 24 grays because of the possible mixed tumor in the mixed malignancy in the tumor. In other words, there may be a germinomatous component in the tumor as well, and the germinomatous component tend to relapse in the ventricles. If this is metastatic in nature, the patient should receive 4 courses of PIE chemotherapy again, and again after that a re-evaluation is made. And these patients should receive craniospinal radiotherapy of up to 30 grays and a boost to the tumor bed of up to 24 grays. This is the reported outcome of the PSYOP treatment with a 5-year progression-free survival of about 75%. Again, in the same study, this showed that in the presence of residual tumor, the outcome is much poorer compared to if there is no residual tumor, and hence the possible need for resection of the residual tumor. Many of these residual tumor are teratomatous in nature and hence would not respond to the radiotherapy that is given to the patient at the end of chemotherapy. And this tumor may need to be resected. If left behind, this tumor may grow with time and may turn malignant with time as well. So send blood for alpha-fetoprotein and beta-HCG, and if you're doing a CSF diversion, please do send the CSF for alpha-fetoprotein and beta-HCG as well. And raised blood and CSF alpha-fetoprotein or beta-HCG is diagnostic of non-germinomatous germ cell tumor. If only the beta-HCG is raised and the amount is less than 50 units per liter, a diagnosis of germinoma can be made. And therefore, a biopsy may or may not be necessary. And in fact, tumor excision may or may not be necessary in a patient with germinoma or non-germinomatous germ cell tumor. The only possible role of neurosurgeon in tumor resection for a germ cell tumor is if this is a teratoma or if there is significant residual teratoma in the tumor after chemo or chemoradiotherapy. The fourth point is to request for MRI brain and spine preoperatively. So I'll give you another example. This PTV is a 3-year-old boy who presented with reduced activity and vomiting. The CT brain showed acute hydrocephalus due to a posterior fossa mass and a VP shunt was then inserted. This is the MR of the brain that showed a tumor arising from the posterior fossa. It looks cystic in nature. A posterior fossa craniotomy was performed and tumor excision was then performed, and post-operatively the patient was referred to us. We then requested for MRI of the brain and spine, MRI of the brain to look for residual tumor, and MRI brain of the spine to look for metastatic disease. As you can see from the MRI brain here, there's only very minimal residual disease. The upper cervical region is clear of tumor, but as you go down the lower part of the thoracic region, the spinal cord looks a bit fuzzy. And as you go down here, you can see that the CSF space is no longer filled with CSF, but filled with what is suspiciously tumor or leptomeningeal disease. The histopathology was subsequently reported as a pilocytic astrocytoma, thankfully. And we know that in pilocytic astrocytoma, only 10% of the patients present with metastatic disease at diagnosis, and it is a very slow growing tumor. And therefore, we decided to watch and not do anything to the patient, as the patient was asymptomatic of any metastatic lesion. And we then repeated the MR of the spine later. And this is the repeated MR of the spine. As you can see from at the top, the cervical region, the spinal cord looks nice. The thoracic region, it looks nice as well. And if you go down to the bottom part of the chorda equina, CSF space is well filled with CSF, and there's nothing suspicious here. So the MRI spine is important, and it should be done as part of staging for a brain tumor, and it should preferably be done prior to surgery. And because post-op MRI spine is difficult to interpret due to the possible presence of a blood product, and the blood product may obscure actual leptomeningeal metastatic disease. And we may not have the luxury of time to wait and repeat the MRI spine for malignant brain tumors, and we may need to treat the patient assuming that the changes that we see in the MRI spine is due to leptomeningeal metastatic disease instead of a blood product. The 5th, 6th, and 7th points for the neurosurgeon to perform a safe maximal resection were indicated, and this would be in most circumstances except for patients with a germ cell tumor, and to obtain adequate tissue for histopathology and molecular diagnostic studies, and to arrange for a post-op MRI scan. So this MR, who is a 9-year-old boy, he presented with headache and vomiting and unsteady gait. MRI brain showed an acute hydrocephalus with a posterior fossa tumor. This is the MRI of the brain. We showed a huge mass at the posterior fossa, as you can see here in the imaging. A VP shunt was inserted and a posterior fossa craniotomy was performed, and a tumor was grossly excised. A CT brain was done without any contrast, and it was reported as post-op changes only. The histopathology was reported as medulloblastoma, classical in nature, and the patient was then subsequently referred to us. This is a CT brain post-operatively performed without any contrast. We showed a surgical cavity here, and it is very difficult to discern if there is any residual tumor or not. This is the post-op MRI brain and spine, and as you can see here, there is from the MRI of the brain, there is a significant residual tumor. This patient will be classified as high-risk medulloblastoma, and there are a few features that we would use to classify a patient with medulloblastoma as high risk, and this would include presence of metastatic disease, histological findings of a large cell or anaplasia, significant residual tumor with a cross-section of more than 1.5 centimeters square, and today possibly perhaps in the Wnt activated subgroup, you may not treat the patient with significant residual tumor with a high-risk protocol only. And if the child is less than 3 years old at diagnosis, this would be considered high risk as well, and as we would not radiate these patients. Unfortunately, there is no standard of care for medulloblastoma in the world. However, there are a few treatment regime that is adopted by various groups. The American POG 9031 as well as the AASNS 0332 regime uses normal dose chemotherapy and normal way of radiotherapy, whereby the patient receives a total of 36 to 40 grays of craniospinal radiotherapy and a boost to the tumor bed of up to 18 grays. The St. Jude group in the SJMB 03 protocol uses high-dose chemotherapy regime, and the Italian in the Milan protocol uses hyperfractionated accelerated radiotherapy. For the young children who are less than 3 years old, the German group in their HIT SKK strategy uses intraventricular chemotherapy on top of chemotherapy without high-dose chemo and without radiotherapy. This is the reported outcome of the POG 9031 regime, whereby they randomized between giving radiotherapy first or chemotherapy first, and they found that the survival outcome of either giving radiotherapy first or chemotherapy first were equivalent in nature. And we were very interested because of the limitation of radiotherapy at presentation or at the time of referral in our center. And therefore, we adopted the chemotherapy first regime using this protocol. Unfortunately, when we look back at our patients, although the numbers are very small, the outcome is dismal. The 3-year event-free survival was only 16%. This was a work done by our trainee a few years ago, about a year ago. The only patients who survived are patients who did not have any metastatic disease at presentation. Following that, we have now changed the way we treat a high-risk medulloblastoma, whereby we give radiotherapy first in the hope that we will be able to have a better outcome compared to giving chemotherapy first, followed by radiotherapy in the sandwich approach. The American COG AASNS 0332 trial have just been concluded. They have not reported their outcome, but they have shared their outcome at ISPNO recently. The addition of carboplatin to the radiotherapy did not improve the overall survival of the whole group. However, in the subgroup of patients with group 3 medulloblastoma, the addition of carboplatin seems to be superior compared to without carboplatin. As you can see in the wind and the sonic hedgehog activated subgroup, there is no difference in outcome with the addition of carboplatin. So is the patients with group 4 tumors. Today, we are now able to differentiate patients with wind activated and sonic hedgehog activated subgroup in our center, but we are still not able to differentiate the patients with group 3 and group 4 because of the lack of methylation profiling. We have also adopted the German HIT SKK treatment regime for infants or children less than 3 years old with medulloblastoma in our center, with the addition of intraventricular chemotherapy on top of the usual intravenous systemic chemotherapy. And this is the reported outcome of the HIT SKK strategy. As you can see here, the patients with desmoplastic medulloblastoma or medulloblastoma with extensive nodularity have got an excellent outcome with this treatment regime, in both progression-free survival as well as overall survival. And we know that most of the patients with this medulloblastoma with extensive nodularity, as well as patients with this histology, would have a sonic hedgehog activated regime, a sonic hedgehog activated medulloblastoma. And this is the outcome of the sonic hedgehog group. And the group 4 patients, although small in number, also have got an excellent outcome. Unfortunately, the patients with group 3 medulloblastoma still do poorly despite intraventricular chemotherapy. So it is very important for the neurosurgeons to perform maximal safe surgery. I know it is a very fine balance because doing too much would mean the patient have got significant post-op neurological impairment. Doing inadequately would mean the patient would have poorer survival outcome. Therefore, significant residual tumor is associated with poorer prognosis, and these patients would need more adjuvant treatment to salvage them. It is important to obtain adequate tissue for histopathology, and today we would need to do not just normal histopathology, but we would need more tissue for molecular studies as well. And I've mentioned here that with carboplatin, in patients with group 3 medulloblastoma high-risk group, addition of carboplatin on top of vincristine given concurrently during radiotherapy improved the survival outcome. And I would like to emphasize here that post-op CT scan, especially without contrast, is inadequate to assess the presence or absence of significant residual tumor, and MRI should be performed, and this should be done in a timely manner, and that would mean within 48 hours post-operatively, because beyond 48 hours, it may be difficult to interpret the MRI. So item 7 and 8, item number 8 is to provide good post-op wound care. This is NIM, who is a 9-year-old girl who presented with unsteady gait and frequent falls. The CT brain showed acute hydrocephalus due to posterior fossa tumor, and the MRI brain and spine showed no metastatic disease. This is the MRI brain that showed a mass at the posterior fossa with a cystic component. And post-op, the patient underwent posterior fossa craniotomy and gross total tumor excision, and this is the post-op MR that showed a good resection without significant residual tumor. However, if you can see the operative sites here, there is quite a bit of post-op changes. The histopathology was reported as a medulloblastoma, non-sonic shock and non-wind in nature, but unfortunately, post-operatively, she had a wound breakdown and requiring wound debridement, and therefore radiotherapy was subsequently delayed to about 11 weeks post-operatively. This patient would be deemed as a standard risk medulloblastoma and would be treated with the usual Becker regime, but because of the delay in the radiotherapy, we gave the patient 36 gray craniospinal radiotherapy instead. She received chemotherapy using the same regime, which is IV vincristine during concurrently during radiotherapy, and post completion of radiotherapy, the patient received oral lomustine, IV vincristine, IV cisplatin. Unfortunately, the patient had a local relapse about 12 months after completion of chemotherapy. Therefore, provision of good post-op wound care is important because wound healing is prerequisite before we can start adjuvant radiotherapy or chemotherapy. And good post-op wound care enable timely delivery of adjuvant treatment. The last two part is to consider re-resection or resection post-chemotherapy when indicated, and resection of a patient at relapse for palliative reasons. So this is MFB, who is an 8-year-old boy at the time when he was diagnosed with medulloblastoma. It was high risk because he had a metastatic disease with M2 and M3 disease, metastatic to the spine as well as to the brain. The primary tumor was resected. This is a patient that was treated very long ago, and we only used Becker regime then. And he was treated with a 36 gray craniospinal radiotherapy with a boost to the metastatic sites as well. Post-operatively, he developed severe cerebellar mutism syndrome, but however, that improved with time, and so much so that he was able to go to school. Metastatic relapse occurred about 3 years later. This is the MR that showed metastatic disease at the leptomeninges, near the leptomeninges at the frontal region. The metastatic tumor was resected and focal radiotherapy was given to the metastatic tumor, and the patient was given palliative oral etoposide. He remained relatively well and he continued to go to school, and he was independent for a period for a good time. However, he subsequently progressed, and that is not unexpected, and he passed away about 3 years later. And therefore, I feel that he had good palliative treatment at the time of relapse because he has had a good survival outcome then. And therefore, consider re-resection of residual tumor post-chemotherapy to improve survival. And at relapse, we also do consider palliative tumor resection because it may prolong survival and the outcome of the patient. And this is the list of the what I feel are important roles of neurosurgeons. And I thank you for your attention.
Thank you, Dr. Teh, for your sharing. Yes, it is indeed very important for both neuro and onco team to work hand in hand and have better co-manage for PEDS onco cases, and to start working together as early as possible in order to have better outcome. Now we have reached the Q&A session. I would like to introduce my partner moderator, Ms. Priya, to take over this session. Ms. Priya, over to you.
Thank you very much. I've taken over for a bit. I would like to zoom into the questions. First of all, fantastic presentation to all of the presenters. The first is a comment. I would like to just say, this comment is for Dr. Teh. It's a very refreshing and also progressive idea for you to say that you could refer the cases to us prior to the HPE. That is very good to know. It's very progressive. The second one, I would like to just read a question out from the chat box. I'm going to zoom into this very quickly. This is for Mr. Saiful. In a left-sided tumor or eloquent area under fluorescein guided, if the area still appears pink, shall we stop or proceed with resection? If to stop resection, what would the best indication be? This is from our trainee, Mr. Saiful.
Thank you for the question. I think I mentioned during my presentation, the limiting factor in resection of HGG using gliolan is that when you reach an area where there's excitation of the intraoperative monitor, which is eloquent area, if you had changes in intraoperative monitor, by means you have to stop. because you don't want to add new neurological deficit for the patient. So whatever left behind should be treated by either radiotherapy or chemotherapy. So these are the main factor that total resection or supramarginal is not possible in a local area.
Priya, you have to unmute, Priya.
Okay, can you hear me? Right. So the next question is meant for both Dato Azmin and Dr. Saiful. The question is from another trainee. Dear Dato Azmin and Dr. Saiful, what are the challenges faced in the maintenance of this hybrid OR so far, i.e. user training, funds, instruments, so on and so forth?
Dato Azmin wrong?
I think you, it can be directed to you as well, Dr.
Yeah, okay.
Saiful.
Dr. Azmin is there.
Yeah, I'm
okay.
here.
Okay.
Thank
Actually,
you.
normally the maintenance of the brain suite is actually maintained by the hospital support service. And this hospital support service, they have a budget to maintain all these items. So normally the things which can go wrong is sometimes with the software, which is supported by the brain lab, and could also be with the tech system that is out from the hospital. Sometimes there could be delay in the transferring of the images to the OR, but otherwise light, pendants, gas for the pendants, and the thing does not give us any problem at all. The only thing is sometimes with the software and the IGS navigation system that gives some problem, but it's all normally rectified within a few minutes by the staff or by the company, the vendors. And normally the consumables that we use in such a hybrid or operation theater is the same as all being utilized in the normal cases, except that you have to have the neural navigation markers. That's all for the drapes. Otherwise, equipments are all the same because it's not an MRI interoperative MRI hybrid OR. It's CT scan, so you can use everything just the same, except that when you transport the patient, when you do a repeat interoperative CT scan, you have to make sure that the patient is able to enter the gantry. That is what you have to be careful of, and to be sure that of the sterility involved in when you're doing imaging. Anything you'd like to add, Saiful?
I think it's very important that we must understand, even though we have some sort of like highly equipped brain suite, this is just a modality that helps you. You know, you still have to use our own brain, even though you have IGS to show where is the tumor. But sometimes all these things may change during the surgery, for example. Sometimes it get dislodged, then you have to go back to the basics. So in terms of maintenance, I feel in the first few years probably not a problem, but later when all this brain suite has over their expiry, the maintenance always come very late. And it has to be tanggung by our department.
Okay, thank you very much for your wonderful input. I have another question from Dr. Mason, and this is directed towards Dr. Tay. Dr. Tay, is there a relapse in patient with non-WNT or non-SHH and yet have received the standard Parker regime? What would be the next step of management other than the resection choice?
Well, unfortunately, patients with relapsed medulloblastoma would hardly be salvageable anywhere in the world today, except for those patients with maybe who were infants who were treated using a non-radiotherapy kind of regime. But otherwise, the patients who have had radiotherapy in the past would not be salvageable. What is available is a palliative kind of treatment. And therefore, if surgery can be performed, and we would reconsider everything that is that can be given to the patient, and that would include surgical excision, radiotherapy, as well as chemotherapy. And the chemotherapy we would give would be palliative chemotherapy. Dependent on how the child is, oral etoposide is usually very well tolerated by the patients.
Okay, thank you very much for your input. I have one more last question for you, Dr. Teh, and this is coming from Professor Xiao. Can I ask Dr. Teh if his neurosurgeons are general neurosurgeons or pediatric neurosurgeons? As Prof. Dharmendra mentioned, subspecialization is important and is likely that he will get better cooperation with a pediatric neurosurgeon who will probably understand the need of pediatric oncology much better, since the pediatric neurosurgeon will not need to focus on adult issues as well. Well, I guess this is a comment and also a question.
I don't think I have a choice about the neurosurgeons. I mean, I work with Mr. AASNS and Mr. Fas in our center, and I assume they are well-renowned pediatric neurosurgeons, but I do get referrals from neurosurgeons everywhere, including private practice, and I assume they are not pediatric trained. So I don't have a choice.
Yes, a
one
pity,
more question.
because can I also make a comment? Actually, you know, the reason why you get 48 hours MRI after surgery is actually if they're residual tumor, actually you can go in for a second round. Because that's one of the things, you know, it's not just for oncology re-stratification. It's actually also to consider, should you go back again to do some more, because you might have missed a little bit here and there, especially if you don't have intraoperative MRI or something like that. So I think that's also an important issue which you didn't mention.
Yeah, but unfortunately, in our local circumstance, I think most families would not agree with repeat surgery. I think in my experience of the many patients that I've seen, perhaps only one or two families who have agreed for repeat surgery after the initial surgery.
No, but you see that it changes the risk stratification. You know, from a high risk, if you can just take out a bit more tumor, it comes to standard risk. The amount of radiation that the child is going to get is much less. Even the extent of chemotherapy is going to be much less. In the long term, this is actually going to be better for the child, because you know the effect of, you know, giving more radiation is actually going to make that kid not so good.
Yeah.
May I add the comment? Actually, the problem is a logistic. Even I have a so-called the Women Children Hospital dedicated center. But unfortunately, the access to OT bed is very difficult. But this is a very good collaboration, I think, with Dr. Teh, so everything get facilitated. Last time post-op MRI was like crazy if you ask for that, you know. So now post-op MRI for neurosurgery, especially posterior fossa tumor, is a routine because we make it as a research. We do intraoperative ultrasound, then we compare with immediate post-op MRI within 24 hours. So by doing that as a research protocol, it become like a norm to them. And slowly the radiologists get adopted to that. And we also have intraoperative radiologists to help us in doing the ultrasound. So we bring them to theater so that they understand why we need immediate post-op MRI. So that is the first step. And the second step, of course, we have a very good facilities, but our support staff are limited. So we have an 18-bed ICU in pediatric, and we got 10 theater in pediatric OT alone. 10 theater. I got dedicated theater attached to intraoperative angio suite in the children hospital. But the staff are only quarter, maybe half. So we are fighting hard for this. Maybe in 5 years' time, we will come back in full force with a lot of effort. Now the staff being re-recruited for the COVID and so on. I think with Dr. Teh message 10.2, we can use as a reason that why we need post-op MRI and why we need all these facilities, and we need support from the hospital administrator as well. So I thank Dr.
Teh. Your head of neurosurgery in Malaysia is also in this conference. So you know.
Can we have one more last question?
Yeah, okay, last one.
Okay, so this is for Dr. Kate Drummond. In a single center, what would you say is your most common complication for awake craniotomy?
Well, the most common complication is early neurological deficit, but it depends on whether you call that a complication or not. A lot of people see awake craniotomy as being a way of avoiding a deficit. Actually, awake craniotomy is a way of controlling deficits. You're really pushing the boundary to try and remove as much tumor as you can. And, you know, for a patient to have a minor or even quite significant deficit, particularly related to resection of cortex rather than breaching of white matter, the patients will almost always recover. And as long as the patients are well educated for that. As far as, you know, the other complications, we haven't had to convert to an asleep procedure. I haven't had to do that since I was doing my fellowship in Boston. I think our post-operative infection and hemorrhage rates are very low, much the same as a standard craniotomy. So I think, you know, you have to learn to accept and manage the early neurological deficit, which is always very anxiety provoking for everyone, but it will eventually get better, and to work through that with the patient.
Okay, thank you so much, Dr. Kate. With watching the time limit, I think I will pass this back to the main speaker. Or should I say Dr. Nazlin? Thank you very much, everybody. It was a pleasure meeting you all.
Thank you to our speakers for another brilliant discussion as well. And thank you, Dr. Shu Yi and Dr. Priya. We will now have a group photo session. I would like to invite the moderators, speakers, and panelists as well to switch on your camera. All right, so then on my count at 1, 2, 3. Okay, 1, 2, 3. All right, brilliant. Thank you.
Okay, thank you, everybody. Good night.
Ladies and gentlemen, it's been a long day, but I'm certain it's been a fruitful one. I sincerely hope everyone has enjoyed our sessions for today. We all look forward to seeing you tomorrow. Our session will start at 8 a.m. sharp tomorrow. Take care and see you soon. Thank you.
Thank you, everybody. Thank you, Kate. Thank you, Edo. Thank you, Dr. Asmin. Thank you, Prof. Iwantiu. Thank you, Tate. Thank you, everyone. See you tomorrow.
Yeah.